Уважаемые коллеги, доброе утро.
Dear colleagues, good morning. I think that we have the highest number of the presentations. Let's keep to the timing, and if possible, you can cut your presentation so that we have the discussion. Let's start to keep to the program. Good morning. Roman Tarasov, the evolution of methods of endovascular treatment of newborns with ductus-dependent congenital heart defects. Dear colleagues, as for the definition, the pathophysiology of all congenital heart diseases is the deficiency of heart ejection, heart failure progression, acidosis development, and the function disturbance of most important organs. These children can survive only because they have fetal communications when there is the mixture of blood, it's open oval foramen and duct. These are most common congenital heart diseases that can be critical and threat the life. The frequency of these states are presented. This is aortic coarctation, master aortic ductus transposition, and so on. In 1975, pediatricians got the new possibility to manage risks and to improve the mechanisms of prognosis for the children born with congenital heart defect. Prostaglandin E1 appeared. It is still used, but unfortunately only when surgical methods were approved, the prognosis for these children improved as well. And that started in the middle of 20th century. Talking about main milestones of this surgery, we have to mention 1944. This year, the first subclavian graft was set, and the first radical surgical correction of aortic coarctation in 12-year-old child was performed. Also remember 1933, when first cardiac-surgical intervention was performed with bypass. It was performed by John Gibbon Jr. He corrected the defect of the septum. In 4 years in the Soviet Union, the first surgery was performed. At that time, in the middle of 20th century, microsurgical tools did not exist, as well as no ultrasound. The main diagnostic tools were auscultation and radiology methods. The bypass were not as good as today. You couldn't use this method in newborns because they required huge hemotransfusion. Talking about first interventions in the children with ductus-dependent defects, in 1961, Davignon suggested the valvulotomy of the valve added with the stent, and the first aortic arch correction was performed in 1987. Talking about artificial blood bypass was performed by physiologist Legalois. He wrote about that for the first time in 1812. And it was performed first in 1887 when the dog's head was supported alive for a certain time. Then there were attempts to revitalize the head of people died on guillotine, but Frey and Guber were the first one. During the French Revolution, 1789, the French professor anatom suggested guillotine as a mechanism for human way of execution, but nevertheless, probably that's why experiments developed. And the last execution with guillotine usage was in 1978 here in Marseille. The first mechanism was developed by Russian physiologists Chichulin and Terebinsky. And the first surgery with artificial circulation was performed by Terebinsky. You see the first machine for artificial circulation and experiments for dog's head perfusion. These how first machines looked like in the middle of 20th century. Talking about assisted circulation, we have to remember the meeting of American Thoracic Surgeons Association when Walt Leahy performed the first open heart surgery, and it was with the donor. The scheme and the idea are very interesting, especially in the situation when it was impossible to use circulation machine. But this idea was rejected soon because the parents of the children got severe failure of cerebral brain supply. Modern devices have centrifuge. There are different methods of filling oxygenator, antegrade venous filling of cardiotome tank that allows to perform the surgeries with assisted circulation. Talking about Crohn's catheter surgery that was performed to 10 months baby in 1953. It was performed by the surgeon in Mexico, Rubio Alvarez. He performed pulmonary valvulotomy at Buzhin with urethral catheter. It's important to mention that urethral catheter played a significant role in the development of catheterization, and Forsman also used urethral catheter. Talking about history of transcatheter methods in the USSR, in 1977, Petrosyan and Gorobyan performed first successful balloon ultraseptomy, and then the significant stage of the development of endovascular surgery was associated with double lumen balloon catheters for coronary angioplasty. And of course, this technology was fully transferred for transcatheter methods of treatment of congenital heart problems, and it was associated with balloon catheters while treating with valve stenosis, aortic coarctation, and then stents appeared that was created by Giulio Palmaz that implemented it into the clinical practice, and then stents started being used in surgery, in pediatric surgery, and of course Bagrat Alikyan, of course, Here we have also Manolis and Alexander, who made significant input into this direction. And to cut my presentation short, I just mentioned modern possibilities. We can talk about stenting in right ventricular with flow tetrade. This is the case from our institute. Stenting was performed in a child who was only 1,700 grams. Usually soon after that, we perform secondary intervention when the left ventricular is ready for hemodynamic correction. We performed histological study that shows the adequate formation of a new vessel. This is the literature data where we see that the methods exist of stenting for right ventricular with pulmonary valve atresia, and Manolis Georgievich and Alexander Viktorovich are dealing with that regularly. And if it is a critical aortic coarctation, we can use stenting, aortic stenting as the first stage palliative intervention. Here is our case. In 2 to 3 weeks, the stent explantation is performed and aortic reconstruction. And to wrap up my presentation, I would love to mention that the main idea and ideology of first stage surgical correction or palliative intervention means that sometimes we have suboptimal results of congenital heart defects surgery, and our main task is stabilization of baby stage and let him achieve the age when the surgical intervention will not threat his life. In 50s, there was two-stage techniques. At 70s, there was great trend for primary radical surgical correction because Brian Barrett Boyce and Alda Costenda got first very good results because they were using deep hypothermia and circulatory arrest. And in 1988, John Kirkland performed his famous speech, cardiac surgery moving to the younger age, and he demonstrated the possibilities of cardiac surgery in younger patients. Today we can see that the standard of care for these babies is palliative interventions. It's all happening in front of us. It's all happening under our hands, and we need to get the evidence base. And to wrap up my presentation, I would love to announce the book that would be published this year dedicated to endovascular palliative interventions in babies with ductus-dependent defects. You are behind the schedule. 10 minutes, less than 10 minutes, please, please. There we have one presentation less. That is great presentation. It's important to remember the path that we've passed to achieve the existing methods. I have a question. Question is off the mic. The modern stage of endovascular methods developing in pediatric practice. What's your opinion about biodegradable stents? What do you think about biodegradable materials in pediatric practice? I think this technology does have serious potential. It should be developing. It should be used not only in transcatheter interventions, but in many directions of endovascular surgery, in coronary interventions, resorbable scaffold absorb from polylactic acid. It was associated with high percent of thrombosis, but our center has very good thoughts of it. We were very cautious about the technology of implantation. Well, to answer your question, I think the potential, the big potential is there. It should be developed, it should be tested, and it should be implemented. Scaffold implantation would be a very good thing. It is good if we can avoid in children this radical stent expanding. Let's move to the next presentation. The next presentation from your own institute, Ksenia Osifovna. When is it purposeful to stent the excretory part of the right ventricular in case of pulmonary artery atresia with an intact interventricular septum? Well, first and foremost, we should say that pulmonary artery atresia with an intact septum is congenital disease. These patients are admitted usually in very severe state, and their mortal rate is 50%. So we have surgical and transcatheter methods of intervention. Primary purpose is to have survival of these patients. If we talk about transcatheter treatment, we have to understand anatomy and morphology of this defect. We need to understand which type of atresia is there, the anatomy of right ventricular. And we can have here the level of hematresia, and we need to understand the stenosis or bending of coronary artery. The favorable anatomy of right ventricular. We plan this type of patients. We will switch them to biventricular hemodynamic. And we need to understand if we see that there are normal valves, normal right ventricle. So when we're talking about where we're stenting the right ventricle, and when we try to set patient for ventricle and half hemodynamics. We have two clinical cases. This is a newborn on term. She was admitted on the second day after the birth with the diagnosis pulmonary artery atresia. ECG you can see on the slide. The patient was stabilized, and on the third day she was in the cath lab. The child data were the child data you see in one day. If we understand that we cannot postpone the intervention, the catheter was positioned selectively. Then recanalization was performed with coronary guide progress 80. In this case, I prefer working with this type of guide. I've performed recanalization with diagnostic catheter. Then we performed balloon valve dilation, 315, then 515, and then contrast through arterial duct. We see that it is restrictive. 3.34 millimeters, hand hemiplegia of right ventricle. And there was no cavity at all. We decided together with surgeons that we will perform the stenting to get a ventricle and half hemicorrection. Then the stenting of arterial duct was performed and control result. Well, as we are limited in time, on the second month of life, the baby was discharged. At 4 months, years, the selective diagnostic was performed. Gradient is normal. The patient disappeared, and when the patient was 5 months with heart failure, on ultrasound, hydropericard with tamponade, we see gradient 159. In cath lab, we perform the pericard puncture and control angiography. We see that right ventricle has not increased during 4 days. We see that the state of the baby deteriorated. The baby is in intensive care unit, and we decide that intraoperatively we decide that we need 1.5 ventricle correction, and when we open it, we haven't seen the right ventricular at all. So the correction was performed. Pulmonary anastomosis and antegrade flow. The baby is small. The cavity is not enough, so we decided to perform it. We will follow up the baby. Not clear what will be happening. And the other patient, the baby with atresia, with pulmonary artery atresia, though he was more stable. On angiography, we see that there is some cavity of right ventricle compared to the previous baby. Recanalization was performed, and through arterial duct, we see that we go through the center of the right ventricle. Same stages, same correction stages were performed, and angiography demonstrates that opening is open, is free. We just leave it here, then we stent the arterial duct, and on MSCT we see the stent when the baby was 5 months. Together we decided that we need balloon valve dilation. The baby was discharged after that, and then he was admitted for surgical correction. We corrected the right artery and trabecular. The apex of right ventricle was, and we ligated the duct. I can say that when do we stent these patients, if we want to have this baby for 1.5 ventricle, we need to avoid the cavity closing. The surgeons pass these patients to us. We're just getting acquainted with this type of patients. I think we'll have more of these patients, and it would be more clear how to do it. Technically, we can do it, but the further situation and correction is not quite clear. We analyze the literature, and sometimes there are absolutely equal babies with equal anatomies have absolutely different correction methods. So we still have to learn more. That's all from my side. Well, we don't have lots of time. Lots of questions, by the way. Well, this is a very difficult procedure. It should be performed only according to the indications. In the first case, you should have performed pulmonary anastomosis as palliative care. How do you decide where you stent Battle's duct? did you fear the hypervolemia? Usually we stent arterial ductus. In this case, we performed the stenting for the first time. We considered it would not be enough to fill in the pulmonary duct. We stayed with antegrade and retrograde ductus, but it turned out to be not enough for this particular patient. And the complication, recirculatory noise. So when there is a competing blood flow from the opening, technically, my question technically, Ksenia, if you talk about Botulus duct, when you are stenting, isn't it easier to go from the top, not from the bottom? From carotid artery, it's nearly direct approach. It can be easier. I've tried many times through the leg. For me, it's more difficult. For myself, I prefer top access. Is it right? In your situation, I see you were going from the bottom all the time, from the leg, and for myself, it's not. It depends on the Botulus duct. If it is different to stent, if it is from aortic arch, in this case, a transvenous approach is better. It's easier. You have the entrance to the pulmonary artery and you use guide catheter 5-6 French, especially. She has punctured femoral artery and it was okay. And as for carotid artery access, if it is a vertical situation, when it goes from aortic arch, well, in atresia, it will go from aortic arch. Can I have a quick comment? As for this patient, both open surgeons and endovascular surgeons decide when to set or not to set stent. We check hypoplasia of ventricle. If it's type B, we choose endovascular. If there are no sinusoid opening of the exit, it's more endovascular surgeons' work. As for recirculatory bypass, we also check the tricuspidal valve. It was okay, so initially there couldn't have been recirculatory bypass. Thank you. Well, let's pass to the next presentation. A.Soinov, development of a self-opening valve containing conduit for endovascular prosthetic of the pulmonary artery in pediatric patients. We discussed it already a little bit. I would love to say that this study was supported by the Russian Scientific Foundation grant. We know that this type of defects is seen in 20% of cases. Tetrade, stenosis, these are most common defects that we face. And there is a small group of ROS congenital defects where we need to implant conduit. In spite of the sutures that have been already performed, the opening part where there is either conduit or native pulmonary artery failure that requires additional intervention. We have symptomatic and asymptomatic patients. Asymptomatic patients should be treated if we have dilation of the right ventricle. And as for symptomatic patients with the first signs of breath shortness, they should be treated. Today, the European Association guidelines say that transcatheter intervention should be performed in patients with symptoms of stenosis or pulmonary failure. And there is a huge discussion what's better, conduit or transcatheter treatment. The recent guidelines suggest transcatheter treatment as more safe, so we need to choose conduit. Well, there are lots of conduits today, but with number of disadvantages. The biggest problem is the size and the price. That's why in Mishalkina clinic we decided to develop our own transcatheter valve, and we tried to overcome the disadvantages such as fast valve calcification and fixation points on the valve, and to create a valve that would work in different anatomic variants. For that, we decided to take retrospectively 350 patients with different conduits and started checking the size of pulmonary arteries that you see. We saw 6 anatomic type of conduits and pulmonary arteries, and the first type is cone-shaped. In 7% of cases, we have pear-shaped, and in 24%, it is sand glass.
The reverse cone, and in 6%, well, that's a mixed type, the aneurysm of the outflow tract, and that's the normal type of the conduit. In order to continue our development, we had to assess the mechanical properties of the conduit, which conduit is more rigid, which is more elastic, and it turned out that the native pulmonary artery is more elastic as compared to xenopericardium and xenovenous conduits. We gave the data to our engineers who were supposed to develop the more optimal frame and to choose the best rigidity. After the processing of material, it turned out that the red color is more soft, the blue color is less rigid. So we developed the specific conduits. Then we did a thermal analysis when we can basically fold this frame, or when the device can develop some specific properties. At 8 degrees it folds, at 20 it develops its shape. Then on the basis of this data, we did the 3 modifications of the conduit shown on the slide. Also, there was a need to sprinkle nitinol, and we basically conducted the study to compare titanium oxide. Titanium oxide is more physiological thing, and after this we studied different types of frames. The first one is rather simple, and again it could be put into the delivery system and be implanted into the animal model. However, this type of conduits can be implanted in case of the normal anatomy, but in case of abnormal anatomy, it was not effective. During the trials, it showed some optimal results. Often there were dislocations, so we dropped this kind of conduit. The second type of valve was quite interesting. There was the wide skirt, the wide crown. We decided that this type of conduit will be less dislocated. So we conducted a number of studies, and we got very interesting results. So we had one death case. After the implantation, the crown damaged the pulmonary artery. As you can see it here, there was bleeding. And in the long-term period, we got also suboptimal results. In one case, there was prosthesis dislocation, and there was regurgitation. And in other cases, after like 6 months, 35 months, the gradient was quite high in the long-term period. And that means we had doubts about the use of this valve. This is the third valve prototype. with the atraumatic crown, with the rigid skirt. That's the way this conduit looks like. We measured the hydrodynamic characteristics. Half a year later, it showed that there were no damages. After this, we started experiments using 3D heart models. So we printed the heart 3D model and implanted the scaffold. And you can see here, well, the crown is behind the pulmonary artery. The skirt doesn't go away from the RVOT. Here you can see our animal experiments and geography picture. Then there was the valve implantation, and the last picture is the angiographic results, the final results. Also, we did the experiment to assess the immediate results, whether there was the obstruction of our VOT, and you can see here that, and this is shown in picture 1, the valve does not cover the tricuspid valve, so it is very well fixated, as it is shown in picture 2. In picture 3, we see that the pulmonary veins are not involved, the blood flow is normal, and picture 4 shows the valve explantation. Everything is okay with the valve. As for the follow-up results, they are quite good. Well, you can see rather small gradients and no valve regurgitation. As you can see here, these are the final results of this experiment. Good gradient. The maximum gradient is 17. No drawbacks here. As a result, I'd like to say that the new transcatheter self-expandent valve of the pulmonary artery is rather safe. Well, it requires some improvement in the future, and during the experiments, we got 3 grants, and we explanted 16 valves. Thank you very much. That's our team. Thank you. I have a question. Why do you call it conduit? It's just a self-expanding valve. A conduit is something else. When there is no outflow from the right ventricle. Well, why do you call it conduit? It's just a self-expanding valve, and that's clear. Yes, I agree with you, self-expanding valve. Well, I have a question for you. You have this atraumatic crown, and it goes into the bifurcation of the pulmonary artery. It can just stick into the roof, but sooner or later you'll have to do the radical procedure. You know what patients should undergo this procedure, and in most cases these are people who is already grown up, and 10 years later he might need the redo procedure. So this additional part which will grow into the roof, well, will it be an obstacle in terms of removing this valve in the future? So we must be ready for the next procedure. Right now, a auto valve Edwards, for example, is designed in such a way that it can be implanted, and there are arches that can be ruptured with balloon. So are you thinking about the future? Well, about how we can easily remove it? Thank you for this question. In fact, well, you can see that we have just 4 arches which are elastic and they can be easily removed. Or you can just cut them off. Right, you can cut them off. Well, these valves are not just for the removal. If we implant a valve, well, we just try to do the treatment later on. It's not a valve-in-valve implantation. And you know, in cardiology, more than 2 valves, well, for example, the third one is usually not implanted. Well, these are patients with the expanded RVOT up to 3 centimeters. All right, here we're talking about narrow conduits. In case of narrow conduits, without pre-stenting, you won't be able to place this valve. Without pre-stenting, you won't be able to place this valve. Self-expanding stent is not intended for this. Balloon expandable stents, well, they have advantages in case of narrow tracts because their sinus is narrower. Well, CP stent should be placed first and then the endovascular valve. Well, here they developed a system when you can put another valve, but sooner or later you should think about the redo procedure. All right, let me repeat it once again. Well, if we use this kind of stent, well, there is the possibility of valve and valve. If we put in the valve for children, like 28, 30, well, 20 and more millimeters of RVOT, well, this size is enough not to cause any obstruction, and usually the gradient will be low in this case. Can I just make a clarification? The patient who had the procedure with the tetrade of Fallot, well, the patient might have some problems even when he is not an adolescent. Well, he needs this conduit like a brain, but he won't be able to implant this particular thing. Well, what's the size? 10 French. We have the delivery system 12 French. All right. So what's the smallest size of the valve? The smallest size is 18. All right. Well, that's enough. All right. That's a disputable question. So when we have time, we'll discuss it. Of course, that's a very creative thing and a very interesting one. So you did a hell of a job. And of course, we need this valve, but you must have a clear understanding when you should install this particular valve. We have a long line of valves, and we must discuss the advantages of a particular valve. Which patient needs this or that valve, like a balloon expandable valve, a self-expandable valve. You have more opportunities in this case. Yes, thank you very much. The next presentation is from Alexander Grigorovich from NanoMed. Thank you very much. Well, you called me and asked me to make a presentation. Well, so I offered you this presentation, but there were other options regarding the title of my presentation. But since we decided to start using the Russian-made occluders, NanoMed, for closing septal defects, we know that in 1976 there were the first cases like this. All other devices, except implants that are used for stenting the defect, are not effective. They just slide, and we can see shunts. We can see that the procedure is not efficient. And I'm very grateful to Yuri Firmashev, who was the first one in the world to implant implants globally. And he was our mentor. He came to the Mishalkin Center. He just made us acquainted with implants, and I, as an infectionist, dealt with heart failures when I was in the Mishalkin clinic. There was the old guard that basically drummed all this knowledge into me that I'm using right now. In fact, you can see the occluders. All companies produce basically the same device. They just modernize it. If a patient has allergy to metal, well, let's have a ceramic covering. If, well, it's rigid fixation, let's make it soft. Well, but basically you can see that all we can do is to repeat the design. Here is the occluder, and it's for the PDA, like PDA1, well, for interventricular defects, and you can see the materials are very good. Well, the wire itself, I compare it in terms of softness, so it reminds me for wire of Occlutech, used by the Occlutech company. And you can see the patch here, the matrix, which is developed from the stomach of swines. It is biologically compatible. And you can see the cover, which is the carbon cover, which is the proud of NanoMed. It's not shown here, but the pusher is very flexible here, which is a very wonderful solution. And you can see the packaging corresponds to all the standards. And the delivery system is probably of the Chinese manufacturing, and the pusher is basically packed here. The pusher should be packed independently from the delivery system. It should be in the sterile environment. It should not be packed with the delivery system per se. They promised to do it. Well, you can see the sizes of this occluder up to 45 millimeters. As for large occluders, I didn't get these occluders from them. Well, my experience shows it's up to 34 millimeters. I'd like to have bigger sizes. Well, there were questions about the PDA occluders. Now it's softer, more stable. Well, technical trials were conducted completely, and you can see that it can be loaded easily. Well, strength trials. Well, you can see all the physical parameters tested here. And naturally, first we did it in Penza. There were several devices used there. Then in the Amur Medical Academy in Blagoveshchensk, the Meshonkin Clinic in Moscow, in Moniki, and in the Transplantology Research Institute, we used these devices. There were publications on this topic. But I think that I'm not going to rediscover America. Well, my impression is that it's a very good occluder, rather soft. Well, nothing that can cause negative reaction. Well, it's softer than the Abbott occluder, and I think it's more friendly, in my opinion, more comfortable to work with it. Well, if we look at the post-infunction intraventricular defects, the Abbott company has something that they did 2 decades ago, and nothing changed since. Nothing has changed since then. When we're talking about polyurethane patches, well, there is bleeding, there is hemolysis, nothing has changed. And of course, we need to have the occluder twice as big as compared to the size of the defect. Well, we're not happy about the same patches. It's difficult to position it, but thinking about this manufacturing base, we would like to have a new device. Well, these are my drawings, and well, that's the occluder they manufactured. We modernized it, and here you can see the drawings and the patent that we got. Well, that's a separate story. What are the differences here? First of all, the size of the occluder is different, up to 40. Second, the patch is from PTFE. It blocks blood flow completely. And also, there is a lintel here, which interrupts the flow, the stop flow. The stop flow is much better. Also, we have 2 fixation systems. You can see on both sides. And if you were at my presentation yesterday, we talked about the case of our Siberian Association when there was the ventricular defect, 3 centimeters. and we had to use the ISD occluder with double fixation because we were trying to use the snare in the inferior vena cava. We positioned it on both sides. This occluder allows us to do it. So we developed the technology. We used double-sided pushers, and basically we can demonstrate another technology of closing the interventricular defects. And this device has some advantages. Stop flow occurs right away. So this occluder is already on the market, so you can see the sizes. These are small sizes, and we are ready to use it all too often. We've already had more than 50 cases with Evgeny Merkulov and Dmitry Sulimov, and yours truly. We've already done more than 50 closures of interseptal defects at our cardiac center. Patients, well, are on ECMO, well, they are on counter pulsation. And here you can see the manufacturer here, and we got the feedback. Yes, first we had the questions which were not unresolved, but right now it's a very good occluder that we can use in our practice. If you have any experience of using it, please share it with us. Thank you. Thank you, Alexander. The occluder that you developed, well, that's the corner occluder by LifeTech. Well, yes, it's not exactly the same, well, more or less. And we searched for patents, and our occluder has undisputable advantages and undisputable properties. We are glad that you have this Russian-made device. From 20 to 40, yes, you can close PDA using this occluder, which is nice. Right, so it has some advantages. Well, it's nice that we have a manufacturer here, but tell me please, did you encounter any constructive defects of these occluders? I know that one occluder was used in the Research Transplantology Institute, but well, they had some distal problems, but these were the first patients. They changed the structure, and now they showed that this occluder has no problems. About 3 weeks ago, I have the experience of using this occluder, NanoMed, and the PDA. Well, can you put on the slides? Well, you can see the NanoMed slides. All right. And, well, there was the detached thrombus. Well, that's a serious defect. Well, I don't know what to do with this occluder. Well, that's a separate presentation by NanoMed. Well, at the end, there should be just a picture, just put it on. Well, of course, such things should not happen. Well, the occluder should be reliable. In terms of the structure, here you can see the detached part. And again, you can see this detachment here, which is not nice. A very difficult situation. Thank you. Thank you. Let's move on to the next presentation. Endovascular closure of coronary ducts. Well, I'd like to just share my experience of using domestic NanoMed occluders to close septal defects in open arterial duct or PDA. Well, right now that's a serious problem. I cannot advance my slides. Okay, now we can do it. All right. So fistulas can be isolated, acquired after the surgery. Well, they may be rare heart defects. Classification is important. Proximal, distal fistulas, that's important because depending on the outflow level, fistulas can be of great importance. As you can see it here, and also in terms of proximal forms, they might be expanded coronary arteries, but not of a big size, so they might be fistula of the circumflex right coronary artery, left coronary artery. Fistulas can be small, medium, large, well, the so-called gigantic. Also, you can see the coronary fistula, coronary venous fistula, coronary pulmonary fistula. They may be simple and multiple fistulas. That's important because depending on that, we can have different clinical pictures. Well, selective coronography is the golden standard because only in case of coronography we can assess our opportunities and how you can close such fistulas. Depending on the size, we can treat symptomatic or asymptomatic patients. There are peculiarities shown here in case of proximal and distal fistulas. You can see the algorithm here. I wouldn't go into detail. Well, let's talk about technical aspects. First of all, imaging. We should see the anatomy of coronary arteries very well, because depending on the anatomy, we should choose the site of closure, the size, and the type of the occluder. Also, which access to use, how to develop the arteriovenous snare, because sometimes when we use guide catheters, well, they should be quite large in size, or we use a balloon for that. Well, these are important things. Also, the arterial venous snare should be developed. If you can develop this snare, in this case, technically, the procedure is much simpler in terms of the using of the delivery system, retrograde or antegrade. Access can be used. You can close fistulas without any problem along the coronary artery. Well, during the 5 years of our work, there have been 9 patients, 10 procedures altogether. Well, the distal part of fistula were closed. In 2 cases proximal, multiple fistulas occurred in half of the cases. From the left coronary artery, there was the outflow of the fistula into the right ventricle. And as for the right coronary artery, in one case there was the sinus, coronary sinus, into the right ventricle. Also, you can see the left coronary artery into right ventricle. You can see the coronary artery flowing into the right ventricle. So we use different types of devices, primarily MPLATS occluders, Endo-2AS. We started using Conor MF to close coronary fistulas. Using the integrate access, we did the closure in 6 cases. Well, here you can see some of the illustrations. The child who has a fistula between the interior interventricular artery and the circumflex artery. You can see the anatomy of arteries. We can see the expanded circumflex artery. There is a direct anastomosis here. And using just one drainage orifice, we open the right ventricle. We do the closure of the drainage orifice. We implant the occluder, additional size, and well, here you can see coronography shows there's no direct anastomosis between the left coronary artery and the circumflex. Here is one more case of the fistula closure. That's a rare case between the right coronary artery and the coronary sinus. The right coronary artery is expanded. You can see the descending coronary sinus, well, the large vein of the heart. We used access to the coronary artery. We used the delivery system to deliver to the coronary sinus. And you can see the delivery system is being implanted, then the occluder is implanted, and there are distal branches of the coronary artery which were not contrasted before the closure. Well, here is one more example. A wonderful case. I've shown it several times. And again, that's a rare case for the first time in my clinical practice when a child, a 3-year-old child, has no right coronary artery. And here we use the guide catheter. left the coronography. Could you just press the button to launch the video again? And you can see here the large reflows to the right coronary artery, goes into the right ventricle. First of all, our diagnosis was the VOT, and then we reconsidered this diagnosis. That was the coronary fistula. We closed this fistula. When this fistula was closed, well, you can see there was no shunt to the right ventricle. All coronary arteries are very well contrasted. It would be nice to do a coronography in the long-term period to see the changes. Well, you can see there are no microcirculatory shunts here. So you can see before that there were outflows from the arteries to the right ventricle. Here is another interesting case, the fistula between the right ventricle and right coronary artery. The child is 23 kilos of weight. The corner was implanted, and again, one disc is on the side of the right ventricle, others are in the coronary artery. Here is one more case. I'd like to demonstrate the proximal fistula, the large aneurysm of the right coronary artery drained into the right ventricle. And again, we can close it using the occluder. That's the plug occluder in the area where it flows into the aneurysmic part. So in all cases, when we did the closure, we achieved very good results. No complications.
No interventions were required. All the patients were discharged. In one patient, we performed the closing on 2-stage. We saw the fistula between circumflex artery and right ventricle. We closed fistula with the right coronary artery, and in 6 months, we closed the fistula the right coronary artery in 6 months, decreased in size, and at the 6th stage, we closed the fistula of circumflex artery. In all cases after occluder implantation, and thus we don't see any pathology of this child. The long-term result, we have the coronarography, the baby 1 year, 4 months with huge aneurysm of anterior artery. The child was operated on. We closed this fistula using ADO occluder of the first generation. You see the stages of fistula closure. After the implantation, there is no blood regurgitation. In 3 months, in 3 years, we have the angiography. Aneurysm is still there. It is kind of turbulence blood flow in this fistula tract. One more surgery will be required to close the proximal fistula in anterior interventricular artery. Thus, we demonstrated the endovascular ways of coronary fistula treatment are safe, efficient, and can be alternative to the open surgery intervention. We closed all fistula in our practice. All the rare defects were successfully treated. Thank you. Manolis Georgievich, you set example to everybody how the presentation should be prepared. The case is quite rare, unique, and the approaches are not everyday. If you allow, Dmitry Korzh is ready from Astrakhan. He's online. Mr. Korzh is with us. Why not? Okay, we're waiting for him. Very severe transeptal puncture cases for appendage occlusion. Good morning, dear colleagues. Thanks for giving me this possibility to discuss this case for this auditorium. Probably there would be nothing interesting, but last year we started implanting occluders for the left appendage occlusion. We performed 7 procedures. Mr. Merkulov helped us a lot, and also we had great support for our eco experts. The first 5 cases were performed during the first day. No particularities were seen. And the second day, we performed the 6th case, and on the 7th case, we got stuck. Still, it's a question. We don't fully understand here what's happened. So please do comment on this case. The tools were absolutely standard, achievable. Introducer and the needle for the puncture. The technique was a standard. The needle in introducer in the posterior lower part of the septum. That's how we did it. We positioned the needle. Yeah, we were going down superior vena cava. After each jump, we fixed the introducer, and as standard to projection, we were evaluating the position. In bicaval projection, we controlled the level up and down, and forward and back. Thus, we performed first 6 punctures, no complications. Here is our case, young woman, 46 years, with the indication for occluder implantation. Nothing particular. Transeptal introducer was going down. We had obvious first jump, second jump, but unfortunately, at some moment, our colleagues didn't see our introducer. We had all the measurements that we needed. All the contraindications were excluded. But nevertheless, we tried about 10 times. We reintroduced introducer, put it up, put it down, reintroduced, and every time our colleagues on echo and ultrasound, they wanted, we thought that we're in the superior vena cava, but when we were there, our colleagues could see our tool, but after that, we performed this kind of angiography. And it is a typical radiology methods. It seems to us that we are when we need to be, but here our colleagues didn't see our tools. And the main part of this procedure, the main issue with this procedure is high risk of complication. We try to perform contrasting through subclavian vein. Nothing. We didn't understand what's happening. Here, 4-chamber and 3-chamber projection, we could see the tools. But in standard puncture projection, they didn't see the tool. Then we invited arrhythmologists. Our colleague helped us. We used the heart sensor together with ultrasound. And still, nobody understood what was happening. It was kind of using standard pictures, but now here we only relied on ultrasound experts. And in certain moment, introducer dropped through the septum. Look here on the left side. That was kind of not our understanding. And as for stimulator and the probes, it just dropped through the septum. It turned out to be a safe place. We excluded hemipericardium, and then we understood that we are in the right place. We performed the occluder implantation. We implanted the occluder, 18 millimeters. We were afraid that anatomy will not allow us to set the occluder as it should be. Finally, occluder was implanted, probably not really well, but it was fulfilling the task it had. Probably there were some particularities here. This is the leak control. The isolation is performed successfully. So it was 2.5 hours while we were trying to perform only a transeptal puncture. And at the end of the day, the puncture happened by chance, if I can say so. After the procedure, everything was stable, no complications. In certain time, we performed CT with contrast, and seasoned, highly expert radiologists compared everything, and they said they saw no particularities. We see right ventricle, superior and inferior vena cava, the loop. Probably more experienced colleagues would say why that could have happened. We see the septum, no particularities, nothing special. And occluder. Thank you for your kind attention. That's what I wanted to tell you about this case. We really don't understand, as we lack an experience in our proctor who helped us. Our proctor doesn't have the question, as far as I know. Thank you so much. Let's continue. I think when there are difficulties when puncture, you have to put pigtail into the aortic arch. And when you draw it into the side projection, the needle should look at you, and then you will never puncture aorta or pericardium. Most of interventionists, they puncture septum without ultrasound control. My teachers always told me, put pigtail, you'll see aorta, you'll see will the point of puncture, turn it into the side projection, and you will to the arch or to the root, to the arch or the root. To the root. You said to the arch. No, into the root. Yes. Arterial accels pigtail to the root. When you are at the valve, your needle is where you want to see it. You change the projection. If the needle is not aiming aorta, you can puncture it. And under echo control, it is a standard approach. It's a standard control. But today, the standard is the femoral artery puncture under ultrasound control. But 90% cases, no ultrasound is used. Many famous arrhythmologists, even from Mishalkina, they were performing in transesophageal We wanted to understand what's the particularity here. There are just anatomical particularities. It was rotated, transesophageal. You don't see this ideal projection. From the other side, for bilateral projection, either right oblique projection, you can do to see the septum. Thank you. Thank you very much indeed. Is Korzh with us? Korzh is with us, Dmitry Andreevich, Dmitry Korzh. You have very interesting name of your presentation. One is a hybrid approach needed to close ventricular septal defects. Mr. Korzh, do you hear us? We hear you well. We hear you well. Then I'll start. Dear colleagues, dear chair, happy to see all of you. Sorry that I'm not physically with you. And I want to talk about hybrid approach to close ventricular septal defects. That's all okay. According to existing classification, ventricular septal can be classified according to the size, position towards the pulmonary blood flow, and the defects can be major, medium, and small. But most comfortable classification for endovascular correction is old embryological classification that demonstrates perimembranous, muscle, mixed, and subarterial defects. To answer the question, when do we need hybrid approach for defect closure, it's important to work on a number of issues, starting from the indications for endovascular treatment. The indications are based on guidelines for septal defects, also on professional association recommendations, Russian Cardiology Society and Russian Scientific Society for endovascular treatment. Few words about hybrid treatment. There are a few classes. As for the patient choice, patient selection, hybrid methods for big muscle and perimembranous defects are ideal in small babies less than 5 kilograms, in which we can have severe damage due to big catheter usage in patients with big vessel access, with poor vessel access, the patients with multiple defects, in patients muscle defects of the septum, and the patients with narrowing of pulmonary artery. And of course, surgical treatment is recommended to the patients with the septal defect if we see the balance of blood flow in the small and big circulation circles 1 to 5, when systolic pressure in pulmonary artery is no less than 50% of systemic pressure. The second sub-question is the stage, the golden standard for diagnostics for all congenital defects, echocardioscopy that allows to evaluate the localization, morphology, pulmonary hypertension, and we get the result on EKG. Then we perform left ventriculography if the weight of the baby is normal and if the anatomy allows. In cath lab, we attempt to perform endovascular occlusion. If it is not successful, we perform hybrid ideally immediately after endovascular treatment attempt. Particular question that we need to discuss over: do we need to perform transeptal echo? It should be performed in 100% cases in cath lab after intubation and anesthesia to decide on the tactics of treatment, hybrid or open. It should be performed immediately in the cath lab. If it happens, if we see that there was an attempt of defect occlusion, if occluder does not implant from the first attempt, what do we do? Do we change occluder or do we try hybrid approach? As endovascular occlusion of septum is labor-consuming process, it carries risk of hemodynamics deterioration. We need to overcome the mere thought of overcoming this defect. In cases, if we don't manage to close endovascular the defect, the reasons are rigid delivery system, the manage of aortic or tricuspidal valve, overbending of the delivery system. That leads to instability of hemodynamics. We need to use maximum number of attempts and get rid of other causes. You all know the complications well, so I will not read all of them. The complications in hybrid approaches can be major and small. If I talk about small complications, it is valve regurgitation, demolysis, and embolism. And we understand that hybrid has huge advantage. We always can perform conversion and perform the suturing while the patient is on the cardiac pump. This is a patient 2 years old with a septum defect. In cath lab, we perform left ventriculography. The defect was positioned too high, so we couldn't close it endovascularly. The patient in big OR got the implantation of occluder by hybrid approach. Next example, 2.5 years old, septum defect, aneurysm, perimembranous subtricuspidal. Ventriculography was performed in cath lab. We didn't understand quite well, as the result of ventriculography, how many regurgitation from this aneurysm, which defect we should enter and close. Balloon sizing was performed, and intraoperative echocardioscopy demonstrated us the position occluder was implanted to the place where diagnostic balloon was positioned. Also, successful case, 8 months, patient, 5 kilogram, septum defect. We went transvenously without touching the vessel approach. We managed to do transvenously with angiopulmonography. The defect was successfully closed. And to conclude, dear colleagues, I would love to mention that if we have all the set of the implanted tools, we need to have the whole selection of all the types for opening and closing of arterial duct, and we need all the occluders. Thank you. Thank you so much. Unfortunately, we are running out of time, so we will discuss the hybrid surgery later on. I think it is, well, hybrid we could use in the newborns. If we can close it endovascularly, we would prefer endovascular approach. Totally agree with you. Totally agree with you. I told him many times, I don't like the approach. The patients that are taken to the cath lab, then they take them to the surgery. Or, well, let's listen to the last presentation, A.V.Gorbatykh. I will continue the experience of our domestic occluders usage. I will not talk about the statistics as the time is running. I will quote from one paper by Diamond Kenny and Ziad Hijazi. Today, we cannot imagine surgical treatment of congenital disease without transcatheter interventions. Recently, we see huge breakthrough, and that happens in spite of support and possibilities from regulating organs. This is quite recent time when septal defects were operated under hypothermic protection. 30 years passed, and today we have the standard methods when we use a cardiac pump, we use different flaps, xenopericard, nithinol. A long time passed when nithinol was studied and they started creating occluders. In Almazov Center, mainly we have the trend to less invasive surgery. In our favorite journal, Statistic Review of Endovascular Surgery, we are on the 3rd place, but it's only a stimulus for us to work more. As for domestic nitinol occluders, we got the first examples in 2022. These were 2 DMPP, 3 OP, and 3 for defects of interseptal occluders, interseptal defects. And today, in 2023, 2024, we had some residuals of international occluders. In 2024, we started totally usage of domestic occluders. I will demonstrate few cases. The patient, 5 kilos, with 4.5 millimeters defect. We used 5 millimeters occluder, NanoMed, that closes this duct. And I would love to draw attention to the following. It's important to have this technically developed head that moves. When we disattach it, we do not have this fire back effect. And in the nearest future, the duct is fully closed. One more patient with huge septal interventricular defect. What is a great advantage, we are in contact with NanoMed engineers. They created this tailor-made occluder. The question was whether we use intra-atrium occluder, but it's a baby. So better we use occluders according to the indication. We shouldn't use them off-label. This is the standard closure. All the methods of arteriovenous introducer and occluder opening in the defect. The delivery cable is great here. It does not pull out the occluder, no deformity in the right side of the occluder, and disattachment is also very comfortable, no fireback effect. We perform autography to see the information of aortic valves, and we see good ultrasound result. We had off-label patients to whom we performed occlusion of aortic duct. These are adult patients. We have also patients with arteriovenous malformation. And delivery device allows to put occluder into the distal low lobe pulmonary arteries. Talking about our desires, we have more requirement for occluders, for foramen closure. We have the evidence base that it is important when we have cryptogenic stroke, we need to close foramen, and this is an efficient procedure.
Also, the detection of paraprosthesis fistula, different malformations, when we need more softer occluders to pass the delivery system of a smaller diameter. What Alexander has already mentioned is universal devices. There have been several publications. This device is universal, so you can basically close PDA malformations. So that's a 5 French device. A kid who is less than 10 kilos, well, you can use the arterial venous access, and soon we will ask engineers at NanoMed to develop such devices from the softer nitinol. Also, and this is mentioned in Europe and in our country as well, when we have pulmonary hypertension or chronic heart failure, well, we need some radical procedures. For that, the solution is heart transplantation or the installment of specific devices, and Occlutech was the first company that developed this kind of device, an occluder with perforation. You can see the types of perforation. If you look at the first MRI, the left atrium is overloaded, and after the installment, well, you can see there is the unloading through the fistula, and of course we asked to develop this prototype. NanoMed engineers, well, developed this prototype. Right now we're thinking how to use this occluder on animal models, like with heart failure or with pulmonary hypertension, to understand how to calculate the orifice, what should be the pressure, what should be the indicators, so that this device could be implanted. If the patient had lung edemas, well, using this device, you prevent the development of lung edema, right? Yes. If the patient has the edema, you will help this patient using this device. Yes, also patients with mitral valve stenosis, well, there will be the shunt to the right or vice versa, but there might be the negative side, such as saturation, well, or the overload of the pulmonary circuit. Well, the 2-year experience showed the high level of experience, including clinical experience and financial experience, because such occluders, well, are less expensive than foreign occluders, but they perform the same functions. We will continue to develop this occluder, but we need the close cooperation with our engineers. We have a very good opportunity to communicate with the manufacturer directly, and all our ideas, and this was mentioned by Alexander Grigorovich, well, all improvements and all our requests were heard by manufacturers. We need to develop the Russian register of implanted devices. On the basis of this data, we'll be able to analyze the long-term results, and we'll prepare publications. Thank you. Thank you very much. Well, speaking about Russian-made occluders, we need to wait for long-term results. If there is a small percentage of thrombosis in using such devices, this will change the situation. It's important to monitor such patients when the occluder was implanted. Well, we need to look for the results, publish the results like 50 or 100 patients a year later. If the Meshalkin and the Almazov Center bring their efforts together and prepare joint publications, that would be nice. Thank you. Well, it was a pleasure to listen to all these presentations. I had no time to tap on my phone, starting from the historical excursion and all the way to your case. Well, that's wonderful that we have all these presentations. Fistula closure, that was a very jammed breakout session. We planned 7 presentations. We added 2 more presentations. Well, 9 presentations altogether. We had no time for discussion. Thank you very much for participating. And I can see, well, there are people here who deal with chronic occlusions. Well, that will be our next breakout session. Thank you very much. Let's have a short break.
Надо двигаться.
Well, let's move on. And this is the next breakout session. I'd like to introduce our chairpersons. Well, I'm looking at the schedule right now. Anatoly Larionov. He needs no introduction. Also, Sergey Gennadievich, Sergeyev, and Vartan Piltakian. He is not here in the presidium, but let's start with Andrei Vyacheslamovich, chronic coronary thrombotic occlusion disease, recognition. Let's start with this systemic presentation, and then we'll discuss very narrow aspects. Thank you, dear colleagues. Thank you, members of the Presidium, for the opportunity to speak here. It's a pleasure for me to open this breakout session. Well, I'm a cardiologist, and that's why I am a spy in the enemy camp. This subject is very interesting. Should we do the CTO, chronic total occlusion, or cardiologists say that we need to use medication? I'm also a cardiologist, by the way. Okay, well, I never wanted to operate on such patients. Well, I agree with you. Well, let me just try to present my systemic analysis and the evidence. Well, a few words about the problem. Well, here you can see the ESC guidelines 2023 of acute coronary syndromes. Well, the same story about 2019 ESC guidelines. Well, just one mentioning of CTO, and here you can see ESC, EACTS guidelines on myocardial revascularization, and again, CTO in patients with ACS. And here, first and foremost, we're talking about the decriminalization should be used only when we have refractory angina or with a large ischemic area. What is optimal medical therapy? We have aspirin, we have statins. Well, but again, if you look at these guidelines, medical therapy should be used until the symptoms disappear. We can use a lot of drugs, up to 4. Also, if you administer nitroglycerin, well, that doesn't mean the patient should be operated on. We should wait up to 2 to 4 weeks to see if there is a response to therapy or not. Well, cardiologists are aware of this algorithm. Well, there are different types of therapy for patients with low pressure, with low pulse. Well, all the drugs are on the market, and here, well, you can see the classical studies here. Well, again, you can see the results, 2 groups, and these are randomized groups. COMET CTO and Decision CTO, no difference between the groups in terms of recognition or medical therapy. In terms of the patient's outcome, COMET CTO shows that the quality of life improves. Well, you can see also the ischemia trial when we discuss the prognosis of patients with recognition, AMI. Patients, well, again, you can see some patients had recognition, some did not. Again, the primary endpoint is survival rate. Again, you can see ischemia CTO sub-study, which is not published, but it was presented in 2020. Again, we know that every 4th patient in ischemia CTO sub-study had, the chronic occlusion. At least one CTO recognition should be done by experienced operators who had the success rate more than 85%. Also, the high mortality percent patients with CTO, well, as compared to, again, medical therapy, well, patients who had the coronary occlusion had a 2-fold increase in the mortality rate, and you can see that patients with revascularization had the reduction in symptoms and the reduction of the necessary therapy. Here is a banal example. Here are the patients. Well, this is my patient, 72 years age, cabbage, well, occlusion of shunts, well, angina, 3rd functional class. The patient is on therapy, and the patient, is limited in terms of going around. Well, there was the antegrade and retrograde approach used, but they were not successful. The patient will continue to suffer. In fact, the patient has the severe insufficiency, coronary insufficiency, but we should not be afraid of such patients. You can see the successful recanalization. Here, all the symptoms were treated again. You can see that the patient, well, was quite severe, but you can see that right now there is no need of ischemic therapy. Well, why can't we have an impact on prognosis? Here are two banal problems. First, patients with angina die rarely, and well, you can use aspirin and statins. They have an impact on the outcome more than recanalization of the artery, because the main disease that patients have, well, is not atherosclerosis, well, it progresses depending whether the patient takes drugs or not. So one of the main conclusions is recanalization of CTO can have an impact on prognosis, but only several years from now, because of the donor arteries events that may lead to patient's death. And here we have patients with acute coronary syndrome. Here we can see the randomized trials here. Again, EXPLORE trial, two groups, patients with MI who had CTO and without CTO. No big difference, but again, recanalization and CTO was done on day 5. Again, well, the success is like 77%. That's the success of recanalization when we use modern methods. Well, that's not an old study, but it's an 8-year-old study. A lot of things have changed since then. Well, here you can see the coronary occlusion in patients with MI, and again, the coronary occlusion, well, worsens the MACE, 10-year MACE by a factor of 3. And also collateral blood flow, does it have an impact? Yes, it does. If the patient has a bad collateral blood flow and there are STEMI patients, well, the wave area will be bigger, and despite the recanalization, we know that in case of such patients, the outcome is much worse. Here is the IBB shock, well, study. Again, you can see in all groups on day 1, on day 30, on day 12, on day 30, well, 6 months, 12 months, well, these patients have the worst prognosis. Well, this is the mortality rate, and also you can see that recanalization of chronic occlusion, and that was a 100% success study, improves the long-term results in terms of mortality, in terms of the primary endpoint. Well, that's not a randomized trial. These are prospective data, but that's what we see in real life. So you can see complete revascularization either during the index procedure or within 45 days. Well, these are class 1 recommendations. Patients with coronary occlusion after MI, we should vascularize such patients. Again, this is class 1 recommendation. Also, patients with chronic heart failure and CTO, these are 2021 ESC guidelines. Well, these patients should have a shunt. Again, you can see the evidence base. Patients with multi-vessel disease and chronic failure. Again, you can see STITCH trial and revised trial. Well, the STITCH trial compared, well, the optimal medical therapy with low ejection fraction, multi-vessel disease. We can see the 5-year results. Results are basically the same, whether it's a CABG or medical therapy, where patients have the same mortality rate. Well, this is the STITCH trial, and again, you can see the hazard ratio here, the 10-year data. Again, you can see the curves depart. Medical therapy loses in all respects as compared to revascularization after 10 years of follow-up. Well, here you can see the right graph. You can see, well, the curves depart. Well, patients with low ejection fraction are difficult patients. They can die during the procedure. Well, so this also may contribution, but surgeons win ultimately. Well, here you can see revived study, and here we're talking that revascularization should have been better, well, in time, but here is what we have. Patients who in revived study had occlusion, well, at least we knew that half of them had acute MI, and half of the patients had no symptoms, which is very interesting. And you can see the number of patients who had multivessel disease. The number of CTO is unknown. Revived showed that there is no clear data showing that revascularization is better than medical therapy. There is no dynamics in terms of ejection fraction or change in symptoms. At the same time, we're dealing with real patients. Here is a 61-year-old patient with shortness of breath. She was hospitalized to our center. And again, these are patients with terminal heart failure, and the patients who had MI before, no revascularization was performed here. You can see what the heart looks like. Again, ejection fraction is 14. Difficult patient. Well, again, she doesn't walk. Well, she is confined to the bed. And of course, the question is what to do with this patient. Here you can see the angiography. Well, left coronary artery, the circumflex artery, the occlusion of the right coronary artery, and again, well, you can see MRI of the brain and meningioma, and again, the patient is bedridden. The only option we can do is to deal with the chronic occlusion. We open it, we get very good results. We restore the antegrade flow. And on day 1, ejection fraction is 18. Well, revascularization on day 6. Well, again, now it's on day 9. Ejection fraction, left ventricular ejection fraction is 28%. Well, again, the patient was discharged despite the severe heart failure. So right now, evidence data tell us that we must treat such patients with refractory angina, patients who are candidates for revascularization. As for prognosis for such patients, it's difficult. Well, 10-year follow-up is needed, and this data will show that our recognition will have an impact on prognosis. Patients with low ejection fraction and chronic occlusion should be properly selected because this may have an impact on long-term results. Thank you. Thank you for this wonderful presentation. As you all know, there are patients with chronic occlusions. They were excluded from many randomized clinical trials, so we don't have enough evidence here, but 10-year trials like the Canadian and the Korean registers show very good results. Well, the Korean, study showed that the curves depart after 5 years. There is a less mortality, in patients with optimal medical therapy, 5-year period. Well, of course, all these periods, all these studies ended up earlier. The patients live longer, and there was no such an opportunity, to follow up such patients. Atherosclerosis is progressing. The artery will be closed sooner or later. Should we wait for the total occlusion? Well, is it normal? I think it's abnormal. I agree with you. We encounter this problem at our clinic. Sometimes they say, let's wait. But why should we wait? Well, with age, occlusion will be simpler. Well, you can canalize occlusion with the probability of 99%. A 10-year occlusion, the success rate is 70-75%. And of course, with age, the rate of complications grows up. All right, the next presenter. Thank you very much for your presentation. The next presenter, de-escalation of conductors of wires for antegrade canalization of chronic coronary thrombotic occlusive disease. P.Piltakian, you are right on the stage everywhere. That's great. I hope that at least I will make a presentation in every breakout session. Well, thank you very much. And dear colleagues, my presentation is not very well prepared in a sense that, well, there's no scientific interest, but I would like to talk about some technical nuances. Well, the global algorithm, I think you are aware of it. And I would like to grab this opportunity and thank Alexander Grigorovich and Anatoly Alexandrovich because, well, in my recent presentations, well, I improved the content. Why should I talk about de-escalation? Well, I should say that, well, this particular approach of recanalization is associated with the fact that we passed through the occlusion, we placed the microcatheter, the balloon, and then we use the wire. Well, but when I encountered several cases like this, it turned out that even the global algorithm says that if the penetration wire cannot get into the lumen, well, you can use the polymer guide. And in this case, well, you can see the Kovačić's book, well, CTO toolbox, hydrophile wires, well, and again, polymer wires can be used here to do the recanalization to get into the true lumen. The method is very well described, and you can see you can penetrate into the occlusion zone in several directions without leaving the occlusion per se, and then the polymer wire can be used for recanalization. Here are several examples. A man, well, 56 years old, well, bypass was done 10 years ago. Well, you can see the venous shunt on the right artery, and the memory artery is also involved. Well, but you can see that at that time, 10 years ago, there were two occlusions of the LAD. After that, the man felt better, but he still had angina. It wasn't progressive, but, well, that was a problem for 10 years. As a result, well, a decision was taken to do the coronography. Well, the optimal therapy was administered, and you can see the occlusion here. Well, the stump is not quite clear. Well, I think the stump is the dream of every surgeon. Well, again, you can see the septal valves, the small branches, and of course, in such a situation, we try to use the guide wire. It is more manageable. Again, going back to the algorithm, well, we recommend you start with a polymer hydrophile wire. I don't know if it's justifiable or not. Well, but in this case, we started the escalation. And again, you can see the right shunt collaterals through high branches of the right coronary artery. And we started the escalation Gaia 2, Gaia 3, but unfortunately, well, we went into the body of the occlusion, but we didn't manage to get into the lumen. Again, you can see it here in several views. We did our assessment. We go in parallel. It doesn't make sense to dissect the artery. We need to change the situation.
Here we also see that Gaia 3 and we use the guide wire with a cone-like tip. And in the created channels, we are nearly immediately in the lumen and microcatheter. We confirm where it is, and the following steps are just technical recanalization. In the diagonal artery, it was not quite clear where it is, but we spent quite a lot of time and we didn't struggle for it. And it turned out, retrospectively, 10 years ago, I sent this guy for cabbage, and that's his previous angiography. Next patient, 72 years, severe angina. and we see the damage of the ostium of anterior descending artery, and in the middle segment we see occlusion. Occlusion, it goes to the septal part. Here, the idea was to recanalize it easily and then deal with bifurcation, but that didn't happen. Gaia 2 again here, Gaia 2 and Gaia 3, same story. We used them in parallel after penetration, and you see that the guide wire goes in parallel. In the first stage we perform stenting, then bifurcation from the ostium of anterior descending artery, and as we see as bifurcation proximal. In the second stage, I decided to use Gaia 3, and it was the same. Again, we used guide wire, microcatheter, and nearly immediately we are in the true lumen. Then all the issues are quite technical. Microcatheter, standard methods, recanalization of apical segment. In 2 or 3 months we performed stress echo. For thinking about stress segment, so as it was septal diagonal, we didn't want to compromise it. So this is the final result. Well, only 3 slides I will show you here. This is the patient with a occlusion of the main branch. She had a progressing angina. The ejection fraction was decreasing, and she came with a shortness of breath. We operated on her. We saw that type of occlusion, and again Gaia 2 or 3, and we didn't manage to penetrate it, to manage it. We didn't even have possibility to set guide correctly because the zone was very small. We understood that the angioplastic was performed there. And again we used polymer guide wire. We got a dissection in the circumflexatory ostium, and then we used a reverse wire technique, catheterized the big artery. Probably it is not ideal, but the ejection fraction increased. In 2 weeks she had 35 or 38 ejection fraction. And here you see Gaia has some resistance, and that's all what I wanted to say. The situation seems to be quite straightforward. Anatoly Alexandrovich told us a lot about that, but in practice, sometimes this algorithm is forgotten. So I wanted to draw your attention to that one more time. Thank you. If we talk about de-escalation, quite often in ORs, we don't always have all possible guide wires. I see that we don't see everywhere the pilots. If we do microshape, as in Gladius, they are not quite manageable. And when we have the next stage of the guide wires, it would be quite easier to work with them. I'm absolutely sure about that. When we have Gladius and Gladius 6 and MG, we'll see how easy it would be work. Thanks, we'll hope, we'll hope. Well, about 70% it's now. At the moment, we see that occlusion, if the occlusion are not quite chronicle with microlumen, I mean the true situation. Next presentation about retrograde recanalization. through ipsilateral septal collaterals of circumflex artery with their previously implanted stent to the trunk of left coronary artery, anterior descending artery. Mr. Koshkin. Hello, dear colleagues, dear moderators. I wanted to demonstrate our clinical case. To support the words of Anatoly, we don't need to wait for a long time when we see occlusion, and we wait. I would say we don't need to wait, we need to try to recognize as soon as we see it. And this is our clinical case. Well, this is the patient, 64-year-old patient with multifocal arteriosclerosis of the vessels of exterior and interior carotid artery. He had stenting of left carotid artery, 21st, 22nd year, diabetes, bronchial asthma. And you see that the clinic of coronary failure, he had angina of the second and third stage, primary myocardial infarction, and angiogram. We didn't manage to find. We have only the description of the coronarography. The trunk with stenosis, about distal, 90% of distal part, and it goes to the ostium of anterior descending artery. Diagonal artery also is there. The circumflex artery, stenosis. And we had the stenting of this artery. And we see the kissing balloon. And it is written that we have the 90% of the ostium of circumflex artery. It seems that there is a migration. Kissing was performed. Everything was performed in this situation. And the patient is discharged on the medical therapy, unstable stenocardia, 3B. We don't have angiogram, but from the description we see that there is restenosis, significant restenosis in the stent of the trunk, about 50% of anterior descending diagonal artery, and about 90% multivessel defect, as we can see. It was suggested to perform cabbage, and after passing the selective evaluation on the chest CT, they see some kind of this disseminated lesion of the lungs. A consultation with pulmonologist, biopsy is performed. It is sarcoidosis of the second grade, and along with it, the surgeons rejected to perform cabbage, and they discharged him on the conservative therapy. The surgeons did not intervene. But all in all, the patient is ill. He has the clinical picture of coronary failure, and then he is admitted here for secondary visualization with the deterioration of his state. And talking about the results of ultrasound in the 2015 and 2016, there was no hypertension zone, and we see that there is concentric remodeling of left ventricular. The diffuse ejection is decreased, and we see hypertension of basal segment, and the fraction decreases and decreases. In 2024, 44 ejection fraction, not very bad. We perform coronarography, and this is the picture on coronarography. We see the stent in the trunk, short subocclusion. It seemed to us that it's straightforward. Anterior descending artery critical stenosis in the second segment, and right artery is hyperplast. We thought it is very short occlusion, left type, and we have to do something with the circumflex artery. I don't demonstrate antegrade imaging. We have very limited experience in recanalization, and we would reject the occlusion of fostrum because we have to have the antegrade approach, but it would be quite obstructed. So what was the problem with this situation? There is stent in the trunk, there is protrusion, and adequate catheterization was not successful. We tried different types of catheters. Very poor support, very poor support. They were integrated attempts, and they were many. And it seems that you can try to punctuate this cover, but it doesn't happen. And we could have switched to the retrograde approach. We see that there is septal communication between posterior ventricular and anterior arteries. We introduce the introducer, and that's it. No, I'm not showing. Yes, I'm showing. To show or not to show. I hope you see it. We introduced the introducer. Just want you to show you the tortuosity. You see that interventricular septum is tortuosed. And how do you go through it? It was very difficult to introduce microcatheter due to this tortuosity. In the distal segment of circumflex artery, there is also subocclusion. A microcatheter is near the distal part, and it seems to you that's it. Work is done. And that was not the end. The pattern of this occlusion is specific. There is no classification, but there are stents strouts, and fibrotic tissue appeared between the strouts. There was even an idea to punctuate it with the tip of the introducer. All in all, we recanalized it, introduced the guide wire into aorta, and you should try kind of tip-in, but microcatheter is introduced only to this point. It is all fixed. You cannot enter the guide. The pinpoint technique was achieved. We tried to use it again. We didn't have any traps here. Last week we had recanalization. We managed to put the guide wire into our aorta. We still didn't have any traps. We created long trap. Probably dear moderators will help. I will discuss how to create it. This time we didn't do that. And what we have here for the retrograde introducer, we wanted to introduce a retrograde system, but it didn't allow us to do it. It just prevented us. Why didn't you put why didn't you take balloon semi-compliance, inflate it, and the cell would open? Look at this. Look at this. We tried to do it. Initially, yes, initially we tried it many times. In dilation, with a pressed microcatheter, we go into the circumflex ostium with improvised kissing, and most possible, the previous doctor didn't manage to set this to be in the proper place. And there were these attempts with dilation, and, well, there is some dismoral was by the operator. We spent a lot of time there. It was decided to remove the retrograde system, and we managed to put it. We performed the predilation. The stent is definitely not put. You use non-compliance balloon 5 millimeters, and you inflate it, and you will open it. It would be easier. I had 5 millimeters compliance balloon. It didn't work. It just didn't work. Well, all in all, we did it all. We tried to perform it. We implanted stent from the circumflex to the ostium of the trunk. Early implanted stent. We performed culotte, kissing. We took 5 millimeters balloons. Well, we implanted here. We implanted here the anterior descending artery. This is the final result. We see in the posterior interventricular artery the stenosis is there still. We wanted to take the patient for the second time, and we were waiting for IVUS sensors. The patient came, but not the sensors for IVUS. We got this. The patient was happy. He said that he felt extremely better, significantly better, but he didn't want to come again. He said that even if you call me, I will not come. So this is the conclusion. Even if at that moment the operator didn't have the stent position, if the operator guessed the right diameter, all our interventions would not be even necessary to be performed. So if we have this big side branch, we have to perform kissing and port dilation, and it, of course, should be performed under IVUS control, if possible. That's all from my side. Well, great presentation. If we have these proximal issues, it is great to have IVUS assistance. Of course, after such proximal optimization, if we lack support and penetration of proximal stem, this occlusion can be used. You can use big diameter guides as 2-lumen catheter, some aspiration catheter such as expert. If you use expert catheter on the guide wire from donor's artery, you bring it to the place of puncture from expert. You can use Corsar, for example. You use either 300 guide wire, or you have to use extender. If you use escalation, de-escalation, Corsar, and then from expert, you have to take away all these construction. So check if you have 300 guide wire for de-escalation or the extender. It is one of the ways to resolve this issue. And your question about how to make a loop, well, it is also straightforward. If you use ping-pong catheter, you use Godzilla or absolutely any extender. You can go inside the guide. You use any guide wire, 0.5. You make the loop in aorta on the same guide wire. You don't take out this loop from the guide wire, from guide extensor. You just inflate balloon inside, and it is inside. You have this loop inside, and you can drag this guide extensor, and it would take this introducer into the guide. Do you understand more or less? More or less. Well, it's very straightforward. Very straightforward. And if what do you think about loop in out? Well, along the wall, nothing special. Either loop or you use guide extensor. You shape this loop, just whatever you have at your hand. In August, we will discuss it in Kazan. Early announce of our Kazan meeting. The topic of chronic occlusion is quite wide. And let's go to the next presentation. Let's pass floor to Sergey from Yalta. He has a different approach to retrograde. What's the sense in chronic total occlusions? It helps not only in CTOs, it helps also in different other procedures. Let's discuss the early retrograde approach. Good morning, dear colleagues. This is our experience. Not going to talk a lot about typicality, but I would love to mention that the better tools are, the better skills are, successful ratio excesses 80 to 90% of chronic occlusion recanalization. The definition of the chronic occlusion is well known. It is a lack of antegrade blood flow, at least for 3 months, according to the clinical data, or as a result of previous coronarography. The frequency of occlusion is 15 to 25%. Right coronary artery is usually occluded in 0.5% of cases. Among the patients after CABG, it is very common in 90% of cases. And in the patients with ACS, it is seen in 10% of cases. American radiologist ecologists increased the indication up to level 2B. So, if we talk about revascularization, what do we want? We want the collateral blood flow that allows to preserve myocardic function, but it does not prevent ischemia. Recanalization of CTO aims at improvement of myocardial perfusion, and it decreases the severity of angina, as well as improves the quality of life. Revascularization can improve the left ventricle function. Recanalized occlusion has antiarrhythmic potential. In multivessel disease, the occlusion can become donor for collateral. Recanalization is indicated when the significant benefit is foreseen as decrease of ischemia and improvement of left ventricle function. We already mentioned that we can perform it in asymptomatic patients if they perform the treadmill test, if ischemia is in more than 10% of left ventricle mass. In case of akinesia and dyskinesia, we also can perform recanalization. Morphological components, it consists of proximal and distal cap. Proximal cover is more dense with fibrotic tissue that develops due to antegrade blood flow, and calcification is more common in occlusion older than 3 months. All chronic occlusions have microvessels with the size 160 to 230 micrometers, and they develop, and we see the bridge-like collaterals. A distal cup is softer, and it has less resistance for the tip of coronary guide wire. Here is the occlusion, how it is formed. The occlusion The particularity of occlusion is collaterals. We see collaterals in more than 90% of cases. For development of collaterals, they need from 2 to 12 weeks. This is Rentrop classification 0, no filling of occlude artery, Rentrop 1, partial filling of occluded artery, Rentrop 2, full. To perform retrograde recanalization, Werner suggested classification with the size of the collaterals. ACCR is a lack of constant connection between donor and recipient vessel, BCC1, a tertiary connection, and BCC2, stenotic connection. Where do we use retrograde approach? First, we evaluate intervention collaterals for which we can perform it. We can have shunts collaterals, and we have to keep in mind the operator's experience, of course. Primary retrograde access we consider when you have ostium lesions, stumps, proximal branches in distal and proximal part. The occlusion that is covered by stent when you cannot just pass through it. When you have long occlusion, more than 20 millimeters, calcified millimeters. The choice of collaterals that can be subcutaneous vein transplants. They are very susceptible to the guide wire, and we use them in 90% of cases if we talk about retrograde PCI in patients after CABG, but there is risk of perforation and distal embolization. Internal artery, thoracic artery can be used, but there is increased risk of dissection, ischemia, and hemodynamics, especially in retrograde PCI. Septal collaterals are most preferable. They have less tortuosity, they are less susceptible to ischemia, and they support recanalization. The risk of severe complications is lower compared to epicardial collaterals. Epicardial collaterals are less favorable to use in retrograde recanalization, as there is high risk of perforation and hemotamponate. If it is the only source of collateral blood flow, acute ischemia and myocardial infarction can happen. Ipsilateral collaterals can be the side septal branches, and we don't need quite often contrasting with them, but they are overbending, and the movement of the tools is not quite easy here. So, what is the advantage of retrograde approach? It is easier to put the guide through the distal cap. Anatomically, it is usually easier, and retrograde approach is used when antegrade approach is impossible. The switching between antegrade and retrograde strategy. Each occlusion is unique. To achieve success, different strategies of recanalization can be required. Japanese algorithm recommends the shift from antegrade to retrograde after 20 minutes of manipulation with the guide wire. The time of shifting depends on anatomy and operator's experience. For each method of the guide wire movement, whether you change the tip, you have to spend 5 to 10 minutes if you do not achieve success. And then you have to change techniques and strategy. Suboptimal recanalization, or you change antegrade to retrograde approach. The change of strategy leads to the decrease of the time of procedure, decrease the radial load, and lack of contrast.
Well, here you can see our experience of recanalization of chronic occlusions, 3-year experience, and we had 369 patients, 391 procedures, You can see males, females, age, angina, well, ejection fraction, well, from 27 to 77, well, occlusion of the circumflex, 21%, occlusion of LAD, 47%. The choice of the method, cabbage, well, we do plated aggregation, well, depending on the degree of complexity, we use the JCTO scale, we use the Werner and Rentrop classification. Well, the continuation of the procedure is placing the coronary wire beyond the occlusion area during the 30-minute period. 43 minutes is the average duration of the procedure. Again, we used the radial approach. In one case, there was the femoral approach. Antegrade canalization, 351 cases. Well, 53 cases. Retrograde approach, 9.7%. Again, you can use, in this case, 6 French catheters. Well, retrograde recanalization was done on 2 patients through the cells of the earlier installed stent. Here is a clinical example. You can see the circumflex artery involvement. Again, the stump of the branch, very good blood flow. Also, we used the wire marker technique. You can see the aorta, and you can see the wire is placed here using the antegrade approach. The stenting was done, and also you can see here the stenting of the left coronary artery as the second stage. Here is the second example. Well, this kind of occlusion with the calcified stump. So let me go back. Well, here there was an attempt to antegrade recanalization, but it was to no avail. So we used the methodology of the curved wire. We did the de-escalation, as you can see it on the right picture. The microcatheter is being placed. Here is the wire. The antegrade approach, and you can see the final result. Well, here is one more example. When there were unsuccessful attempts of retrograde recanalization, you can see the dissection here, then the retrograde approach in one stage. Well, here you can see the capture of the wire by the balloon in the right coronary artery, and then using this wire, we pass the microcatheter. So here you can see the result. Here is another example, another clinical case. The patient who had the attempt of recanalization of the occlusion of anterior interventricular artery. The stent was implanted from the trunk to the diagonal branch. Again, there were no chances to do the antegrade recanalization. The retrograde approach was used right away. So we used the method of the retrograde snare. When the wire through the contralateral introducer is placed, there is the snare, and you can see the cell of the stent. Well, everything was a success. And here is another case. Again, we did the recanalization. The patient was less successful, but I did the stenting, and again from the right coronary artery, the patient has the orifice of the anterior interventricular artery involved. We used the retrograde approach. Again, you can see the stenting here of IBS. The microcatheter was placed, recanalization was done, and the stent was implanted. Here you can see the final result. Here is one more example. Ipsilateral recanalization, stage 1, stenting of the recanalization of the anterior interventricular artery. Then stage 2, you can see the occlusion of the circumflex, the left type. Well, we tried antegrade recanalization, but this kind of occlusion is very complex, several layers, so it's not quite clear where the wire was going, as you can see it in the middle of the slide. So we used the ipsilateral collaterals through the cell of the earlier implanted stent. We put the wire. It went to the to another retrograde wire, and here you can see the results. The success rate of all recanalizations amounted to 83%. Unsuccessful attempts 63. Well, you can see 360 patients had 670 stents implanted, and you can see the results of retrograde recanalizations. Out of 38 procedures, 23 were successful. That means the success rate is 60.5%. The average time of intervention was from 50 to 150 minutes. The degree of complexity on JCTO 2 to 4. 23 patients had 59 stents implanted, more than in case of usual methods. Well, circumflex 1, well, right coronary artery 13, well, IVS 50. Well, you can see one complication case of retrograde recanalization. Well, the dissection of the trunk of the right coronary artery and of the circumflex. In conclusion, I would like to say that the data obtained show the technical success of retrograde recanalization at the level of 60%. The frequency rate of this method is 9.7%. This method was used when the JCTO was 2.75 points. And again, you can see that it wouldn't have been possible to achieve the success using other methods. Retrograde approach is a very important component in case of PCI-CTO. It can be used in more complex occlusions, but it also marked by the higher risk of complications. And of course, in this case, antegrade recanalization is preferable. Thank you. Thank you very much. Well, you overran your time. You spoke 25 minutes instead of 15. And Dr. Rustem Daudov is supposed to be online right now from Brisbane, Australia. He is not online yet. All right. Send the link to Rustem so that he could connect. All right, questions from the audience. Just a question and a comment. Thank you for your presentation. Wonderful data. As for American guidelines, well, I would like to add that there was the downgrade in class. Well, again, Americans are working in their own conditions, and of course, the cardiac surgery community is having pressure on them. In reality, of course, well, they need to upgrade the grade, but, well, Burlakis and others, well, they are doing their best. Well, you know that patients are being treated by cardiologists. The cardiologists do not let the cardiac surgeons work normally. Well, cardiac surgeons are very pissed off, but the patient originally is managed by cardiologists. They do, well, TEE, they do all the interventions. Well, in the United States, the statistics are different. For example, as for interventions in case of acute coronary syndrome, there are lots of interventions way above the average, well, in order to prove the economic efficacy of, well, such procedures. You need to do 1 million procedures or something like that. Well, if you have progressive angina, well, then the chronic patient may be presented as the progressive case patient, and many patients are operated on under the guise of acute coronary syndrome, ACS. We also do it like this sometimes when the patient needs to be hospitalized. They write down, well, unstable angina. The same is true of here. So the recommendations, the guidelines are often written under the influence of some particular company. Is Rustem trying to connect? We have another presentation before Rustem connects. Okay, let's give the floor to Vyacheslav Vorobyov, who represents an experienced team from Vladivostok. Well, rupture of the interventricular septum, please. Well, let me just present our clinical case, the rupture of IVS in case of retrograde recanalization. Well, as for PCI, well, you can see the history of PCI, lots of different events. I'd like to mention retrograde recanalization, in particular 1990, when for the first time retrograde recanalization was offered by Dr. Jeffrey Hartsfield from using the coronary bypass. Well, also there was a boom when Japanese specialists, together with engineers, developed a miracle, as they called it. That's the first manageable right coronary wire miracle, and the use of the septal collateral for the first time for recanalization by the Japanese specialist Sama Akata, who did the live broadcast on the second JCTO Congress, and the first successful recanalization of chronic occlusion done at Mishalkina Institute by Dr. G.Osiev, with the presentation of the results at TCT in Washington. And Alexander Gorovich came to us together with Dr. Verin at our regional hospital. They did the retrograde recanalization in the Primorsk region. Also in 2007, the Corsair microcatheter appeared on the market. It contributed to the success of recanalization. Here you can see the major techniques to recanalization. They have already been mentioned before: antegrade, retrograde approach, and also bilateral injection. Well, the recanalization of chronic occlusions are accompanied by the risk of complications like any other PCI. Well, but I would like to mention such complications as perforation. It can be septal or epicardiac, or it can be the recanalization of the target artery that may lead to tamponade and heart chambers compression. Well, here's a meta-analysis of 3,500 patients who were subjected to recanalization of chronic occlusions. The percentage of perforation is 11, and more than half of the patients had the retrograde approach, which led to 1.5% of tamponade. Here is another meta-analysis. Patients were included in this meta-analysis from different groups, more than 10,000 patients, 5% of perforations. Half of them are also in case of the retrograde approach. And here is our clinical case. The patient who called the ambulance, well, she had a typical clinical picture of acute MI. Well, our cardiologist from the vascular center, well, consulted her. She was hospitalized to us. Well, ejection fraction 48, troponin and glucose levels are elevated. Coronography shows the acute occlusion of LAD, and also the occlusion of the right coronary artery with the good collateral blood flow through the epicardial outflow and septal outflow. You can see the occlusion of the right coronary artery. The first stage was stenting of fork-dependent lesion. Well, then the patient is supposed to come back to us 3 months later to make a decision regarding right coronary artery revascularization. The patient followed all the recommendations. The test was positive. She was hospitalized. And you can see JCTO occlusion was marked as 2. The risk of complications was high. The attempt to use the integrate approach was unsuccessful, and we decided to use the retrograde approach. The wire was placed through the first septal outflow, but the microcatheter could not be placed. You can see the arrow here and the angle which was formed. The catheter could not pass through this angle. Well, in this situation, there are many ways to solve the problem. Well, for example, Piltakian offers his own approach to solving this problem, and you can see lots of items here. You can use any item to solve this problem. We decided to use another septal canal. Also, the wire was placed here, but the microcatheter could not be passed. Here you can see the red line. Here you can see the invagination of the microcatheter when it was placed. It took us more efforts to do this. Well, we didn't do angioplasty of the canal, so we managed to form the coronaries there. We did angioplasty with the stenting in the future. 2 stents were implanted, and you can see the removal of the microcatheter and the wire. You can see there is the complications such as the rupture of the septal canal with the formation of the hematoma of the interventricular septum. Well, you can see the literature data here, and there are some interesting cases like recanalization of the anterior interventricular artery through the epicardial canal. Perforation was detected. First, they tried to inflate the balloon on both sides, and no success, and then there was the embolization by using coils. Here is a patient, 70 years old, after cabbage, the attempt of recanalization of the right coronary artery. Well, you can see the complication developed, such as the hematoma of the interventricular septum. Before the intervention it was 1 centimeter. Well, when he had the complication, it increased by 2-4 centimeters. Well, the patient died on day 10 from multi-organ failure. Here is the rupture of the artery of the septal canal with the formation of aneurysm, and here you can see it was drained, and the right ventricle was involved. No attempts of embolization. That's the way it looks on CT. Well, it was closed 6 months later. Well, our patients are monitored on a regular basis. Well, they're prone to hypertension, bradycardia, so we decided to embolize. 2 microcatheters were installed. Stage 1 was embolization with neuro coils on both sides. And it turned out that the attempt was unsuccessful. Hematoma began to increase in size. Extravasation continues, and due to that, as for the posterior interventricular artery where the perforant was placed, we decided to implant the stent graft. It was done successfully. Could you launch the second video? Could you launch the second video? The one where the picture is still. All right, anyway, no extravasation here. Well, some minor extravasation, let's put it this way, through other perforants. And on the left, you can see there is extravasation. Well, we decided not to implant the stent graft, not to close all the septal arteries, so we decided to use a coil. And here you can see a coil on the top, and also there are PVA particles. And 10 minutes later, we did the control angiography. You can see there is no shunt to the hematoma area. And also there is some minor extravasation through other small branches, but we decided to stop our intervention here. The patient remains in the ICU, but she is in a stable condition. And you can see the IVUS was done in the cath lab, but no pericardial infusion, no transeptal flows. Again, the ejection fraction was the same as during the first hospitalization, no pericardiac infusion. The patient was discharged on day 14. 6 months later, we called her. She is quite satisfactory, no signs of angina. Or the operator must be aware of potential complications. He must plan the procedure to reduce the complications to the minimum and to know how to respond to these complications. Well, it's not the complication which is dangerous, but the inability to cope with it. And what is important is not just the experience of a surgeon, but also the presence of the necessary instruments, such as big guides, wires, microcatheters, stent grafts, devices for atherectomy, high-pressure balloons, embolization systems, etc. And I would like to conclude by quoting Andreas Grusing, the total closure is a real problem. If we cannot solve the total closure problem, we probably will never really address the question of total heart revascularization. Thank you. Thank you very much. So you did not overrun the time. We have 5 minutes for discussion. Rustem Daudov will join in 5 minutes according to the agenda. Well, I liked your presentation. It was very interesting. And, you mentioned complications. Yes, it's for the first time we did this presentation. And Dr. Saitor solved these complications using the subcutaneous fat that he borrowed. It's quite simple to do through the microcatheter. You can just gather the subcutaneous fat and inject it there. So did you ever try something like that? No, we've never tried to use the subcutaneous fat. When I was preparing this presentation, vacuum aspiration is possible through the microcatheter using a deflator, just like Berlakis recommended. Using the vacuum extraction for hematomas. This is done through Stingray, but here we already have a microcatheter. You can just suck blood out of the hematoma. Some introduce glue, some, fat, some spirals or coils. There are lots of different options, and you can see that fat is free of charge. Thank you very much. Thank you for your presentation, and I would like to give you one life hack. When you finish the use of the retrograde approach, don't remove the retrograde wire right away. Just leave it there, even if you went through the septal or collaterals, and if there is some kind of complication, you already know how to place the microcatheter again, so that you wouldn't just do this procedure a second time. So I usually leave the catheter until the end of the procedure, and then when I do the X-ray, you just remove it. Rustem also has experience in this field. He presented his presentation in Switzerland regarding hematoma, and also IVS. He also has his own solutions. Let me just make one correction to your report. In 2007, we indeed did the retrograde canalization of osteostenosis, and we made a presentation at TCT in Washington, D.C., and also at that time I was invited to Belgrade, Serbia, to talk about retrograde recanalization. Then I was in Japan several times, and I talked to Dr. Carter directly, and we spent a lot of time together at the restaurant and other places, and all Japanese guys at that time were saying I did the recanalization with microcatheter, neurologic microcatheter. I was convinced that externalization should be done and not the dilatation of septal channel. At that time, well, we had no microcatheters. I said we need microcatheters and do not do a repeat procedure, you just do the internalization. And the Japanese guys said no. In 2007, 8, and 9, they had the dilatation of the septal canal by a balloon. And at the same time, well, you said that this balloon showed up later on the market. But when we couldn't pass with our balloon, in some cases, I used the tonus. So I rotated tonus in the septal canal, and then my colleagues and I had a discussion on this at one of the international congresses. I told G.Osiev, well, I did it like this, and he said, that's nonsense. Well, I usually passed through the canal with a laser, so the septal canal, well, people just did everything with it, then everything was, tonus got the covering, it became crosshair. And what I wanted to say is that we started using these methods, well, not of externalization, but we stopped dilating the septal canal until 2009. Well, we got 100% results. All right, that was just a flashback into history. Your experience is absolutely valuable. Rustem Dautov is ready. I can see him. Thank you for your previous presentation. That was a difficult case. Good afternoon, dear colleagues. Rustem, we can hear you very well, loud and clear. How is your workshop going? Very good. By the way, I was unable to come because in Uzbekistan, there is the first conference, Uzbek line, like India line, and that's the pilot version, but we had the cases presented by Germany. Today is the structural day, and I'm presenting the cases at the other clinic. And between cases, I also, well, tasted some Uzbek plov. All right, here I would like to show you a case, CTO proctoring, and I'd like to show you this case. That's the shortest CTO I've ever done. A man, 63 years old, with occluded LCs, post PCI, LM, LAD, 1 year prior, proctoring CTO, revascularization. Well, and well, then, well, it was done in a different country. You can see BAT to cross the radial. They could use the radial access, but I showed them this technique. It was started at the right artery. You can see it was diffused lesions, but we were talking about the circumflex. I decided to place 2 guides, 7 French, as you can see it here. And again, there was this optimal shift. Well, so the circumflex is being filled retrogradely. A lot of collaterals here. And, well, we used the integrate wiring, different wires, where angles also changed. I changed them, well, 1 millimeter of occlusion, well, but I did manage anyway. So that was a study case, so I decided to do it step by step. Well, as you can see here, filling in lots of collaterals. Then, well, I used the 2-lumen catheter. I forgot the name, but anyway, you can find the publication by Najmuddin recently, in which he uses the usual balloons. Well, there is the motorcycle cradle technique, but also in the distal part of the balloon, he inserts the curved wire for a specific function like bifurcation or to make a puncture, for example. So it works in his case, and we also tried to do it. Here we failed, also reversed wire technique, is being used using the microcatheter, and usually we use the wire like the pilot and try to capture it. Well, but as far as I know, because of the anesthesia, we couldn't use this simple wire to pass the area. Finally, I started using, well, scratching. I forgot whether it was hornet or any other wire. Again, you can see that if there was a perforation, it would be difficult to treat because of the retrograde feeling. Then again, you can see balloon deflection technique inside the stent. Again, I put in the balloon and I tried to pass using it. Well, I forgot what kind of wire was that, but I did manage. Again, this technique works if you have the antegrade blood flow and you need to capture it. Well, but I failed. Well, again, you can see this is the Guy family. Well, as far as I remember, so I tried to use the pilot. Again, you can see the contrast wire, long, well, the pilot family, and again, you can see it is the curved one.
Having tried all the antegrade option, I decided to switch to retrograde LED using collaterals, as you see the whole system. Then I decided to use SOR. These are quite expensive microcatheters. After the wire started working well, I added one more guide wire, as you see, just in case, because the second is closed, circumflex is blocked. I can always do it. I always can put it into the trunk. SOR 0.3. Behind it we have microcatheter. It achieved the apex and it does not go further. We further go on. You will see that the guide wire is stuck and there is a layer that it cannot pass through. What can we do here? It's the Gaia, the second Gaia. You see it's contrasting, Gaia 2, but it was going at the side, kind of. You see, it goes to the side. In this situation, if the perforation happens, it would be quite difficult to treat it. I substituted with Pilot 150. You know, Pilot 150 preserves in the structure of a vessel. There is less danger of punctuation. I achieved the distal cap. And I tried to knock there. It went through the guide wire. Then the other side was confirmed at about 3 grams, and it was enough to have this kind of a jump. You know, it hops forward. When we lose a diagonal, the pilot wires work well. The next stage is to put it into the antegrade catheter, 7th French catheter, and here the task is to perform T-pin. 3rd grade Carabel is not passing through. It got stuck. I try to use fine cross to set fine cross. When it happens, it's inside. And then fine cross goes to the ostium of the circumflex. Then we see a little bit of movement, a little bit of turning. And further on, my task is to switch to antegrade system cautiously. That's what I did. but I just did it for learning purposes. Then I used the wire through antegrade fine cross controls this, and I remove antegrade. So this was the balloon 0.5. Did you perform ultrasound of the trunk and anterior part? Have you performed IVUS? IVUS? Yes, they have, but we didn't do it. It seems to me there could have been some malposition, and predilation of the trunk would help. Probably we had recently such a case, and I've demonstrated such a case in Hungary when the stent is underextended and immediately antegrade and retrograde on port. Yes, we can do a port. Port would have helped here, and it would be easier for you to perform it. The operator was really good. He said the stents a year ago. I'm learning from him how to do this cut. Yes, I didn't think about it. Just didn't think about it. We passed 1.5. One balloon got ruptured in the middle of circumflex. Then we used balloons too. In their center, they perform PCI with balloons. They decide themselves. So they just said, use balloon. And I think 220 that balloon was. And the final result. In this center, they have PCI with volcanoes and DCB. In this center, they use these type of balloons. For me, it's strange that you didn't use IVUS and DCB balloon. If the artery is 3 millimeters, it is useless. So you inflate the balloon, but the drug goes into the blood flow, not in the wall. DCB balloon without ultrasound is not a good idea. It's good. It's important to perform good kissing. You check ultrasound. After that, you introduce balloon of the needed diameter, and a DCB balloon should be 3 millimeters. We always perform IVUS. We prepare the vessel 1-to-1. It's important to have good DCB results. This is kind of small branch, and they decided to do it just for the sake of it, with other factors. If they do all the other cases, it is 1-to-1. It's 3 millimeters. It's 3 millimeters. I'm sure about that. That's it. And we have to perform these rotors, and we perform the DCBs. I just wanted to demonstrate to you the case where antegrade, simple case, but it didn't turn out to be as simple as we thought. It can be carina shift or black shift, and we had to use this long way. Well, I like all your cases, you know. When they hear it's a great case, but I would do as I said. But you had retrograde approach. You resolved the issue. You opened the branch. Well, thanks. Great case. Why not? Rustem, thank you. Thank you for being with us. All the best to you in Uzbekistan. We wish this conference to become annual for all of us to share the experience. All the best for you. It's all developing here really well. In recent years, they had new cath labs, They have new approach. They have approach to all the this approach. They would be happy if you come. You just come to your, your break to your childhood. All the best and good luck. Thank you. Thank you, Rustem. Thank you for being with us, dear colleagues. In short, I'll announce our future happenings. In Kazan, we will have the meeting of Russian club. We're waiting for you. Please do come and be with us in Kazan. Thank you. Thank you. I love this session a lot. I loved it. I really loved it. Let's start. I think that Marat Ravilievich and all the rest panel participants will join us soon. It's high time we start, not to rush further on. And we start with the first presentation, autoesophageal fistula after isolation of thoracic aortic aneurysm. Let's start with the presentation. Hello, dear colleagues, dear experts. The name of the presentation does not allow me to make you any surprise at the end. But the recommendations, the guidelines say quite straightforward what we do with the patients with acute aortic dissection. Of course, we have to perform prosthesing, and if anatomy is favorable, as European Society of Thoracic Surgeons says, we would perform intramural hematoma or dissection of type B. We have to perform minimal invasive intervention. I'll start with the clinical case. The patient was admitted from one of the clinics of our city. He had the pain in the chest. Thankfully, our colleagues saw the problem. They found the dissecting aneurysm. The patient was admitted to our clinic in stable stage. We had time to order the instruments, to think. So what we see at the computer tomography imaging, we see the dissection and the contrast saturation in the thoracic part of aorta. We see also at the left pleural cavity a small pneumothorax. As the patient is stable, we ordered instruments and implanted it. The surgery was performed without any particular difficulties, 30-40 minutes. The patient was in ICU under observation soon. Postal period was calm. In 4 days, the patient was discharged into the Department of Vessel Surgery. According to MCT control, the pneumothorax and hydrothorax volume did not increase. And in 10 days, the patient was discharged in acceptable state. But in 3 weeks, the patient comes back. We see him in the acceptance ward. He has shortness of breath, coughing, with pute, and we see aneurysm at the same thoracic aorta part and the accumulation of air in aneurysm cavity. On the right side of the slide, you see and you can visualize it well. To exclude the sorbate in the esophagus, we see, and FDGS, we see the rupture in the medium part of esophagus with the fibrin layer. So there is some inflammation. When the contrast stent with barium was performed, we see the leakage of the contrast into aneurysm cavity, and there is also air. Consilium decided to perform stenting with a drug-covered stem. Contrast X-ray demonstrated that there are no leakages, and everybody decided to send the patient into therapeutic department. But we see in the lab tests the increase of CRP. That meant that there is systemic inflammatory reaction. People started being nervous. CST with peripheral contrasting, we see that stent is insufficient. Contrast is in aneurysm cavity, air accumulation, and they started thinking what to do with this patient. The patient felt worse, and he was sent to the intensive care unit, and it was decided, after all, to remove the stent and to set a drainage system to clean all this cavity. After endoscopic stent was removed, we see the VAC system. We see the picture before. We can visualize the prosthesis of aorta. And at the bottom, we see how it looked like.
According to CT, there was a reduction in the volume of the air in the aneurysm cavity. The patient was being treated for 7 days. He was completely cleaned up, especially the excess side, but the dynamics went from bad to worse. There were erosive hemorrhages, and since the patient was in the inoperable stage, we decided to use the conservative treatment. Unfortunately, the result was quite predictable and not quite good. And if you look at literature data, well, aortoesophageal fistula occurs in 1.5% and in 50% of cases. The reason is the thoracic aneurysm, according to the literary data and registers. Talking about conservative treatment of this cohort of patients is basically impossible because conservative management is linked to a 100% mortality rate. The mortality rate in case of active surgery is 63%. So here the patient has a chance when 40% of cases can end up positively. As for mechanisms, well, that's a chronic aortal disease. Traumas. We're interested, first of all, about, aortal replacement, and this happens in 50% of cases. Here are the main mechanisms. Long-term compression, according to literary data of our Asian colleagues, they describe this particular option. When we place a stent graft, we do the primary aortoesophageal fistula. We make the entire system rigid, and the aneurysm has a stronger pressure on esophagus, leading to sore spots. We also close all the branches, supplying the esophagus, and this leads to esophageal ischemia or fistula. Well, you can see symptoms shown here, such as bleeding, and occurs in 60% of cases, and in some cases, in case of this pathology, we can detect sepsis. There are 2 studies that can visualize this problem. That's fibrogastroduodenoscopy and CT. Well, we can see the fistulas, we can see ulcers, well, esophageal defects, and we can see the wall of another vessel here, for example, and computer tomography. Here we can visualize air. And as for the methods of treatment and guidelines do not tell us a lot. They just tell us that 100% of cases should be treated surgically, since the infected prosthesis should be removed, and we need to use a radical method. Well, we also should be aware of all the possible problems, and we should do the proper tests quickly. The multidisciplinary approach is very important. Unfortunately, in our clinic, we didn't achieve any success because we understand that this is a very difficult patient, and we can just lose the patient on the operating table easily. We lost our time, and well, of course, a radical treatment must depend on the somatic status or the performance status of the patient. Thank you very much. Thank you for your presentation. I have just one minor question. Well, as you tested the patient, did you use the CT? Yes, we did it. And of course, when the patient was hospitalized, well, we did not detect anything. Well, judging by the picture, well, diverticulum, was it diagnosed or not? Diverticulum. No, according to CT, it's difficult to judge if there was a diverticulum or not. Well, but in fact, well, we didn't see it. All right, so treatment was done together with thoracic surgeons. Unfortunately, we don't have thoracic surgeons in our hospital, but we discussed this with cardiac surgeons and general surgeons. We were part of our multidisciplinary team, so they were not in favor of the radical procedure in this thoracic part of the aorta. Maybe the esophagus should be switched off. Well, gastrostoma should be on the surface, and then to compensate for the infectious process in the sac. And then in the cold period, we could think about some radical treatment. I wanted to make a remark regarding this complication. That's a very severe complication. You're always afraid of it. When it happens, well, you're appalled, and without experienced thoracic surgeons who work on the esophagus, not on lungs, but on esophagus and on posterior mediastinum, well, without them, you cannot treat this patient. Well, drainages, well, not always help. Well, when we decided to place a stent, the drainages were not efficient. And then we woke up 2 weeks later, and our endoscopists did it. And it looks like everything was fine. The edges were clean, the pus was gone, but, well, the relapse of hemorrhage brought everything back to square one. So willy-nilly, you will have to involve thoracic surgeons. I'm a cardiac surgeon, and what is mediastinitis? Well, of course, I didn't see a lot of cases, but a couple of cases I did see, and the complications are very treacherous. Even when the tests are normal, well, you start thinking, well, it looks like you coped with the situation, but, well, it may be the beginning of an end, well, this cold period, as we call it. So the participation of thoracic surgeons to treat this complication is a must. Well, we should use the vacuum system, well, adequate drainage of the posterior mediastinum, because posterior mediastinum is the area with which not every thoracic surgeon can cope with. There should be a real specialist if there is such a complication. So you should try to do your best and also involve thoracic surgeons. That's very important. Well, you cannot just cope with this complication on your own. Thank you. Thank you for the presentation. It was very interesting. Sorry, the question is off the mic. Thank you for your question. Only clinical symptoms. Leukocytosis or the inflammatory reaction was not present. Usually, well, we had such a problem as shortness of breath and, well, blood-tinted sputum, but the major problem was the problem with the esophagus. We looked at this right away and we expressed our opinion to surgeons and cardiac surgeons. There should be radical treatment done as soon as possible. Well, probably they didn't hear us. They didn't hear us out because the procedure was quite traumatic. Well, so the risk of losing the patient was very high. Unfortunately, in case of conservative therapy, the risk is even higher there. May I ask you one more question? endoscopists did the drainage through the defect. Yes, endoscope was placed there, and all the tubes were inserted freely. I have a video, but unfortunately of very poor quality. All right, thank you very much. If there are no questions, let's move on to the next presentation. The use of physician-made graft in the treatment of patients with unsuitable anatomy. Try to open your presentation. Okay, we'll move on to the next presentation. We have problems with opening the slides. All right, Murat Sharafudinov, IBD options. That's debranching of iliac artery, internal iliac artery. Okay, dear colleagues, well, I'm back with you, and today we'll consider an interesting option when we have to restore the internal iliac artery and common iliac artery, but we don't have commercial grafts. That's what the situation is. According to the existing terminology, well, EMG, that's PMG, that's the physician-modified endovascular graft. IBD, that's iliac branch device. And well, you can see you can be done on a table. And what are the options? Well, originally, historically, we used the sewing branches on. We used the PTFE component. Well, we basically did the fenestration, and our goal was to do the opposition using the bridge graft. Well, what's the best option to say? Well, bridge graft, okay, let's put it this way. The second option, well, fenestration on a table in situ, and then we insert the bridge graft or side branch graft, and there is another option. We can place a stent or anything else. If the lumen is small, we should preserve the lumen of both branches. And also longitudinal sewing, well, that's when we resort for this option of bifurcation. But if we do it without sewing, well, we have two endoleaks on both sides. You can see like a triangle here. The system is not very reliable. And if we do the suturing, well, we can have a very good hermetic zone for bifurcation of common iliac artery. So what are the major problems we are going to encounter? First, well, problems with branching. Well, of course, we have a PTFE, the standard prosthesis, and here might be some problems. PTFE has a trend toward just gluing by layers, and that is why PTFE may cause some problems with recannulation. Fenestration on the table, if the geometry is wrong, can lead to specific problems. It looks like you unfold everything in a nice manner, but while unfolding, you have the system rotation, and it looks like the direction was right. You just hit the spot, but then there was the dislocation of fenestration area, and you encounter specific problems. Fenestration in situ requires the stabilization of the instrument. Often iliac veins are tortuous. You cannot just bring the instrument properly. Sometimes you need to install the stent additionally. And the longitudinal suturing, here the major problem is the difficulty of recannulation, especially in small diameters when the geometry is wrong, and there is the risk of kinking, and you should just monitor this thoroughly. Here is the clinical example. Here is an interesting patient, abdominal aorta aneurysm up to 60 millimeters, also the aneurysm of the right iliac artery up to 30 millimeters, and pelvic renal dystrophy. right renal dystrophy. Again, you can see it comes from the common iliac artery. This branch coming from the common iliac artery is the main one. Can you launch the video? That's the way it looks on axial video. Okay, pelvic dystrophy. Next video, please. You can see the 3D reconstruction. That's the way it looks like. And in literary sources, they describe surgical treatment when, for example, this kidney, they try to save this kidney, or, well, the kidney will be annihilated by way of mobilization. So they say, you have one more kidney. You lose one, it's not a big problem. Well, also we used this particular option. Well, IBD, fenestration on a table. Launch the video, please. Okay, that's the way it looks like. We just mark the basis, and we mark the fenestra. We use neurocoils. They are very well visible, and they do not cause any artifacts on a CT scan. Well, here you can see the stages of the procedure. The diameter was very small. It was not very convenient, but nevertheless, it was possible to do recannulation of the target vessel, placement of the bridge graft, and the final scan. Could you launch a video, please? At least one. Please launch at least one video. Well, this is the control scan 3 and 6 months later, but 2 years later there was the thrombosis of the branch of internal iliac artery, but the other side keeps the perfusion. That's the way it looks like when the control CT was done. That's the 3D animation. Well, when we show 3D animation, some people say that they try to deceive us. So do not trust me, I can deceive you. Well, that's what it really looks like. Fenestration on the table. Again, this is the anatomy. We use the fenestrated graft placed. We have the neurocoil marked. Well, that's our fenestra. Then we insert it, and here we use the B graft as a bridge graft. Well, this technique is very convenient because it is quite effective. Well, you can recharge, no problem here, and here we did the kissing, so we placed one more stent or plant, but in general it may not be needed. In situ fenestration, the anatomy was narrow. It's not exactly IBD, but that's possible as well. Could you launch the video? Well, if there is the covering, you bring the guide catheter using electrocoagulation. Well, you can just coagulate here. This works on radial grafts, on PTFE grafts. It's not so easy to do. It is thermally stable, and well, it becomes, when you do these manipulations, more viable, but you cannot do a good fenestration here using electrocoagulation when you have a PTFE graft. Well, suturing, well, you place everything in a very effective manner, and that's the way the control scan looks like. So usually the covering area is around 1 centimeter. Well, in this case it was 2 centimeters. Everything is easy, effective, and right now we've been monitoring this patient for 2 years. We did not have any problems with patency. I understand it perfectly well that in the case of stent anatomy, everyone can do it. Parallel grafts don't always allow us to solve the existing problems. Well, commercial grafts are very expensive, extremely expensive. That is why in case of non-standard anatomy and in short time we can solve the problem by using physician-made grafts. If we cover this area, well, everything looks very simple here. Well, as for pelvic ischemia, that's not a big problem, but the major problem is the, well, colon necrosis, and here we have a lot of problems when the inferior mesenteric artery is covered. These patients are very complex. There might be infection, and in this case, we cannot just resolve the problem quickly. Well, that's all I wanted to say. Thank you very much. Questions? Well, as a moderator, well, sorry, the speaker is off the mic. Well, fenestration of prosthesis, and you show different technique. Well, for beginners, what should they start with? Well, I think parallel suturing, when you take the pedicle of a large diameter, like 20 millimeters, 24 millimeters, you do the suturing. Longitudinal suturing, that's the easiest thing, but it is also more expensive because you need 2 branches in this case. Is it Prolene? No. No, it's Capron 4 or 5.0, or rather thick one. Well, so you use the sutures, nodular sutures sometimes. You do the suturing along, okay? What about the anatomical criteria for doing this procedure IBD technique? Because on one of the CTs, aneurysm was 3 centimeters of the iliac artery, but as for the blood flow, well, it looked like less than 2 centimeters. And in fact, in speaking of, well, commercial grafts, well, if it's less than 2 centimeters of the blood flow, they will just reject you, because that's one of the anatomical criteria. There is a risk of squeezing the external iliac branch. It's more important. So the question is what beginners should start with. I would probably recommend first do the procedures when we have the fit contralateral side. That's the first thing. If you have just one iliac artery and you want to preserve it and you've never done it before, you'll better consult someone how to do it. And well, it's better to start when both iliac arteries are working and there are no questions with the counterlateral side. And it's off-label technique, and despite any price, well, think about how to acquire commercial devices. Discuss it with your administration, but the technique is good. We use it. And yesterday we had a master class where we discussed this subject for an hour and a half. This technique is very relevant. There will be more procedures like that, I'm sure. Well, there is another aspect in terms of the diameter. Well, here we must remember banal geometry, and if you have the sum of branches in terms of diameter, it should be equal to the diameter of the common iliac artery. If you have the discrepancy here, then think twice whether you should preserve it or not. That's very important. Well, in terms of planning of the procedure, if you have angles which are non-critical, well, in this case, technically it will be easier to do, but if the blood flow is impeded, there is massive thrombosis. I agree with my colleague. There should be a continuation. There should be a plan B and plan C for any emergency cases. All right, thank you. Did you manage to open your presentation? The second one on the list. Okay, the floor is given to Nikolai Kuzmin. The use of physician-made graft in the treatment of patients with unsuitable anatomy. Dear colleagues, it's a pleasure to speak here. And on this slide, you can see a list of authors. It's not complete. Our A.O. team includes more people, and I'm grateful to all of you for the obtained results. So why do we use physician-made grafts? First of all, because the aneurysm anatomy has its own requirements. Optimal aneurysm anatomy is not widespread. Usually it's the proximal or distal areas, and here we are kind of relaxed by stent graft manufacturers when they reduce the number in French. But when we're talking about, manufactured or commercial grafts, well, there might be some problems, and we have a shortage of such stent grafts. It's quite clear. When we're talking about patient safety, when we're talking about the off-label, there is another side of it. When we use the commercial device, which was developed for specific situations, but we use it off-label in case of difficult anatomy, and maybe physician-made grafts should be used to make the patient's life safer. And remember how we started. Well, I do not want to compare myself with this person, but I'll try to explain why we use it in clinical practice. We started with the aortic occlusion, a young patient, 52 years old, obliterated atherosclerosis, multiple occlusions of visceral branches and main branches, the occlusion of the superior mesenteric artery, iliac artery. Here you can see, the artery performed the function of corontarization, and also there was the stenosis of inferior mesenteric artery. For some reason, the patient was rejected for surgery, but after the conversation with vascular surgeons, nothing came out. So this young patient, you can see the syrup here, covered endovascular reconstruction of aortic bifurcation. So it can be used as an option to open surgery, but that means there is a need of covering of the mesenteric artery. And here is a total corontarization and the reconstruction of the superior mesenteric artery. If we were vascular surgeons, we will just do the fenestration for the inferior mesenteric artery, preserve the blood flow, did the syrup using the endurant pedicle. Well, not the balloon expanding stent graft. Bentley is not available in Russia, so we used Endurant 2. We protected the artery with the catheter, did not implant a stent graft, and the only one thing is we did not do the stenting of the right iliac artery properly. We didn't have enough stents. 6 months later, we did the control CT. There was a lameness on the right, and we can see the right branches. Maybe because of restenosis of the non-stented segment of the iliac artery. However, the endurant pedicle is very well expanded in the aorta, as you can see here. Here you can see the size at 20 millimeters, and the functioning of the lower artery, which is being fed from our area. The pedicle is in the proper position, and again we use this method in other situations. For example, patients with intramural hematoma, and again you can see there was the manifested calcinosis of the left iliac artery. We decided to do reconstruction right away. We had a graft, but also then to send the patient for replacement. And anatomy told us that it's better to use a prosthesis in the aorta. In fact, the patient had some complaints like right extremity pain. So you can see what happened. We used the endurant and the formation of the big fenestration for the right iliac artery. So that's the aortic reconstruction. Not using syrup, but it's a safe procedure. Quick modification. And both legs now have the good blood flow. Here is the CT done half a year later. Also, again, you can see replacement of renal arteries in order to unfold the hematoma? Well, here you can see the dysfunctions, subocclusive thrombosis. Well, in the branch, maybe it's due to cancer, or maybe it's due to anastomosis or stenosis. And as far as this patient is concerned, a similar method was used, but due to occlusion of the branch, we did a thrombectomy by rotarex using the subclavicle approach, and we did the stenting using quite good clinical results. No lameness anymore. And again, I have already mentioned the fact that biografts are not available. We use a balloon expandable stent graft. We think that balloon expandable graft means more force, and your experience shows that when you do the replacement of aortic arteries in aneurysms, there is the long-term, unfolding of aortic valves when there is calcinosis. So this is not a big problem. When we're talking about the pseudo-weak radial force, the major advantage of Endurant as compared to other stent grafts on the market is the maximum diameter, which falls into the category of the aortic dissection, and I think that you didn't see such cases in your practice. The maximum length can allow us to save on the number of instruments and the comparable cost. The Endurant modifications are not a problem. Well, they are being modified, unlike fluents.
Modification can be used in more complicated situations. Here is a patient, 70-year-old. For 5 years, he knows about aortic aneurysm. He's under the observation. Maximum diameter was less than 55 millimeters. Every time we check aneurysm and see how its neck narrows, when the patient cannot be operated neither port chimney nor port endofixation. There is angulation, dilation, calcification. We see that the volume grows, and without maximum diameter, the volume grows. The neck becomes shorter. We try to decide how to treat him. We talk to the surgeon. Fenestrated graft is not good enough because the anatomy is not comfortable. It's not clear where what would be, what interleaks will have. That's why we look from the side of this anatomy, and we decide to use the fenestrated graft, paying attention to the fact that after 50 milliliters, the stent graft decreases in diameter. It becomes narrower. We perform the fenestration with cauter. We have we see that non-strong fenestrations can lead to long-term endoleaks to the rupture of graft. That's why we always perform coagulation. We use coronary guide wires. We have stage prosthesis of aorta, the proximal fenestration, kissing formation, and all in all, bridge graft in renal artery. And this is the final result. Very comfortable for this type of result, for this type of anatomy. A lower mesenteric artery was embolized. It would be sad to lose such a result if we had the interleak of the second type. And we see the decrease of the aneurysm. It's a good result. It's really good result. Where would we love to talk about? We want to preserve the pelvic blood flow. Each third patient has suboptimal pelvic zone, and the patient will have either impotence or gluteal issues. If you can see this patient will have a gluteus problem, and the open surgery are kind of doubtful. I'm not sure if there are many surgeons who have the stenting or during after prosthesis. Beforehand, we have to think how to preserve the pelvic blood flow. We have IBD device from Cook. The only problem is the price. When it was a good time, we used these devices, but unfortunately, at the moment, the situation does not allow to use them. It was used in different situations. It was performed in other stationary. You see that there is good hermetization. A graft migrate proximally. And we have internal and external artery. And we use the graft to prolong hermetization zone. It was a lot said about the problems of the expenditure of the leg in neuroanatomy. We made a decision to have, we see that these methods should be described in details, how we make ourselves safe so that we do not have anything under the endurance leg. The combination here with the neuroanatomy and iliac artery, and there is the endurance. Whereas in this chimney technique, this stent graft fills well, and they do not compromise their pre-entered guide wire allows to perform this procedure. There is 50 to 60 milliliters of contrast, and you can preserve it. And this kind of guide wire will save us in this clinical case, multiple ulcers, the patient with the occlusion. We have this segment. We can preserve this iliac artery, the diameter about the bifurcation, 13 millimeters, and under the lumen it's 7 to 8 millimeters. We can expand common iliac artery with a balloon, 18 millimeters balloon, and we preserve subiliac artery. And if we talk about coronary arteries, the total sum of the distal branches should be 2/3 of the proximal further. We see that in a year we see the dissection of the branch, and we stented it with self-expanding stent. And now, if we see a chronic dissection, the stages of stenting, we see this diameter, the thrombosis does not increase. Then we close the side branches that feed the false lumen, and then we close the fenestration of right iliac artery. The patient is a hunter, so it's very important for him. He asked to preserve it all. The same technique, it is the primary. I said on the left side of the slide, we spent the time for catheterization of the side branch, the final isolation. We see good dynamic in aorta, and the aneurysm volume decreases significantly. What do we see here? The delivery system is better in the batch production. We can expand anatomy. We can use this side branch. It expands better than strong stent from IBD. And you know that more than 20 centimeters is contraindication for IBD. And this is we can save one bridge component. So as for accessibility, if we act sterile in OR with good ventilation, there would be no question why do you use physician grafts? Well, there is no other way. We want to save the patient's quality of life, not to explain to them what he has gluteus claudication. Here nobody suspected pathology. The patient was sent to the vessel. Surgeons, we see double blood supply for the renal kidney. If fenestration allows to preserve this artery, we didn't want to lose half of the kidney, and we used coronary stent graft and preserved the half of kidney. The low mesenteric artery was near the aortic ulcer, was embolized, and at the moment it's more or less fine. So to conclude, I would love to note that preservation of pelvic blood flow is underestimated problem, and we face lack of understanding why it should be performed. There are no extra arteries, so all the arteries are important for the patient, and the possible complication of the occlusion probably sometimes is more often than stent graft modification. And if we talk about GI necrosis or spinal stroke, there is a problem of unconscious manipulation and thrombomigration. We have had a case when we were performing the prosthesis on the iliac artery, but there was a branch thrombosis, and we saw the ischemic colitis. Both internal were closed, and collateral blood flow was compromised. So the evaluation of collateral blood flow should be evaluated thoroughly. And actually, a patient needs all his arteries. Thanks for the attention. Thank you for your presentation. My question about the last case, when you have renal artery, what's the diameter? 3.5. And what's the observation period? It is the fresh case. 2 weeks ago, on the distal edge, we set the drug-eluting stent. We prevent restenosis risk on the distal edge of peripheral graft. We know that the small diameter of renal arteries have very low patency. It was evaluated in chimney technique papers. If it is less than 4 to 5 millimeters, the patency is very low as well. The disadvantage of this work was that common peripheral stent grafts were evaluated, and there were no methods of protection used if we use the drug-eluting stent. Well, in our center, we participated in one of the studies on chimney technique. We know this technique. In the first issue, you mentioned that in narrow cases, we have this communication with chimney, the iliac artery bifurcation. It was only studied from interleague point of view. And as for Bentley problem, there is no doubt about that. And there was only good communication started with a stent graft and big graft. and about its curves to exclude, and from the point of view of excluding of gutter channels. So, well, talking about thin bifurcation, please think about that. Don't teach colleagues if they cannot do it. And as for the same blood flow, there is not 4 millimeters but 5 millimeters question. When we send our patients, if it is 5 millimeters, our patient were not always happier. We have this experience of this shift. It works. It works. Of course, we do not implant it, but it was at its place very soon, in few months, though we were kind of aggressive and did use a distal covered graft. Well, of course, when I mean 4 millimeters, in our case, we have this landmark 4 millimeters. Each renal artery is different, you know, and some people proximal is 7 millimeters, distal is 3. In somebody is 3 and 4. Can we evaluate the diameter as equal? We need to evaluate the blood. Well, the patient anatomy is as it is, but there is statistics that is confirmed. Well, if it is 5 millimeters and more, we need to check. Probably some more aggressive therapy should be prescribed. There are no strict recommendations. There are big, and there are sometimes 1 month, 3 months therapy. When we talk about this type of stent grafts, well, we should not reject this painkiller. We should warn the patient that it's not a guarantee. When we consider all these techniques that we discuss right now, 4, 3, 5, chimney has this bend of graft. There is, if we talk about fenestration, there is more trend to move all the system of endolegs, and 3.5 would be efficient here. The other issue, if we talk about internal iliac, a local fenestration and kissing stent, and we can navigate these problems. On the base of angelog, there are grafts, betaxil, and you can create a bifurcation higher. And in narrow anatomy, you can use 2 nithinol PTFE grafts. Well, there are different variants. At the moment, we are accumulating experience, many different techniques. We cannot say this technique is wonderful and this technique is not. We cannot say anything. I hope that in 10 years, you remember what's happened with chimney technique. We got certain critical volume of studies, and we can present it, and we will understand what we can do. More questions? Next presentation: the fenestration method in patients with aortic dissection. The speaker is off the mic. The speaker is off the mic. Microphone. As for not complicated forms, we first and foremost deal with drug therapy and dynamic observation when we try to find anatomic risk factors. We perform intervention. The purpose of endovascular intervention, first and foremost, closing of the opening and redirection of the blood flow with further modeling of aorta. Malperfusion. If we have the aortic dissection, we can see it in the acute aortic dissection, and the methods of treatment of malperfusion include stent grafting, endovascular fenestration of false channel, and aortic branch stenting. Endovascular closure of these stent grafts can be efficient in 55 to 60% of the patients, including recommended method fenestration of false channel. It allows to achieve and to increase the efficiency of endoprothesis up to 80%, including stenting of the branches. This is a particular case of treatment of malperfusion and aorta. Young patient, 28-year-old, with acute stroke in the left cerebral artery. The dissection of type A is seen with the involvement of the ostium of left carotid and right renal artery. Malperfusion was treated. Left common carotid artery was stented and right renal artery with following fenestration under IVUS control. With the fenestration of false lumen, we also use the technique of transaortic arch. Then the patient was sent to the surgeon where prosthesis of thoracic aorta was performed. And then we got rid of all the types of malperfusion. The second example, visceral malperfusion in dissection type B, patient 52-year-old with hypertension. He was admitted after 3 hours after short-term intense pain with arterial hypertension. Then he had increasing pain, abdominal pain, and the patient is admitted. On CT, we see the compression, total compression of the true lumen. This is how angiography looks like from true channel. All the arteries are filled, but for left renal artery. Performing the malperfusion treatment is not easy because we cannot enter the true lumen neither in antegrade nor in retrograde manner. We perform the fenestration of false channel and then endoprothesing of descending aorta is performed on the left common carotid artery after the implantation. We see total compression. Graft just collapsed in this place, and we needed to post-dilate it. It is easy to perform it quickly, by the way. After the implantation, the blood flow is restored totally in thoracic aorta part, but the patient got hypertony and conscious suppression. After the restoration of the pressure, the patient still had cerebral circulation issues. It was the Robin syndrome, and urgently we had to perform in situ fenestration of subclavian artery, achieving the blood flow on all cerebral arteries and thoracic vessels. We see here no more the Robin syndrome. Our possibilities in dissection include hybrid prosthesis with subtotal debranching and prosthesis with the fenestration, endovascular fenestration of stent graft. It is an example of the technique we performed in 2016, the first endovascular technique for endovascular debranching. This is the technique of parallel grafts. Subcutaneous access helps us here. We use debranching with chimney methods of carotid, left carotid, and subclavian arteries. Now we perform fenestration in situ and in vitro more actively. The dynamic of transeptal transplantation of visceral artery, especially in acute aortic syndrome. The first patient to whom we performed endoprosthesis of thoracic artery from the osteobrachiocephal artery with subtotal fenestration in situ, subcutaneous approach, and it was in 2020. The axillary access was used here on the level of internal carotid artery. The fenestration was performed successfully of internal carotid artery and subclavian artery. Stent grafts were implanted and removed. Result, the grafts are with good patency and the cerebral blood flow is preserved. This is an example of the prosthesis of thoracic aorta with subtotal, total debranching and fenestration. Total fenestration is here of the left carotid artery and left subclavian artery. We have axillary approach and femoral approach. These are the stages of the procedure. For the surgery, we use 3D navigation. We have combination of fenestrated part of brachiocephal artery with common carotid artery. Then fenestration in situ is performed. Long-term results in 2 months. All the fenestra work and cerebral blood flow is preserved. And to conclude, I would love to show you one more fenestration method that we use in our practice. If it is impossible to have the lower access in acute situation, it is the transcaval situation and the stent grafting, endoprosthesing, and the restoration of blood flow, and the closing with occluder. Thank you for the attention. Thank you for the presentation. Do you have a big experience of transcaval implantation? It's mainly is performed in aorta, but now we started using it even in abdominal issues. Do you have some anatomic criteria like the size between aorta and vena cava or angulation? When you would not use this method? I would not use this method if I see that abdominal aorta has this circular calcification. And what about size? Size does not influence that much. We need to find proper occluder. That's the question in this case. But all the rest is acceptable. Thank you. Thank you. If there are no questions, we move to the next presentation. The next presentation. Infectious aortic aneurysm, Mr. Pletnyov. Thank you for giving me the possibility to speak. I'll talk a little bit about infectious aortic aneurysm.
Впервые термин и серия докладов.
Well, for the first time, such presentations and this information was presented by William Osler in 1919, patients with bacterial endocarditis. Well, there was the growth of aneurysms in the abdominal aorta and iliac arteries. This eccentric position, well, basically reminded him of the growth of fungi, and hence this term appeared. Well, but in fact, in 1924, Stengel and Wolf III showed the possibility of forming such aneurysms in patients with septic conditions, non-bacterial endocarditis. In this case, in 1959, Somerville decided the type of infectious aneurysms. That's the infection of the existing aneurysm of the degenerative type, aortic aneurysm and other sites. And of course, at the 20th century, gave us the fourth type of aneurysm of infectious genesis. That's aneurysm related to multiple traumas of the arterial wall, primarily in intravenous drug users when they use syringes to inject drugs. As for pathogens, well, we can do the culture of such pathogens. Well, usually these are Staphylococcus, well, gram-positive, gram-negative Streptococcus, and Enterococcus, Escherichia coli, and Salmonella, especially in East Asia, where the percentage of the infection can be up to 70%. Well, in these infectious aortic aneurysms, in 20 to 30% of cases, it's difficult or impossible to detect any pathogen. As for the aortic aneurysms, well, in 40%, these are infrarenal, 20 to 30%, well, these are thoracoabdominal aorta, distal thoracic aorta, and you can see the breakdown of other sites. Well, as for the diagnosis of the disease, we use the clinical criteria, lab tests, and the radiological criteria. Well, 2 of 3 criteria, possible diagnosis, 3 out of 3, that's confirmation of the diagnosis, 1 out of 3, well, not possible diagnosis. When we're talking about the strategy of treatment, we must understand that infectious aortic aneurysm is not just a surgery, it's not just the arterial reconstruction, but it's a serious problem. These are difficult patients. Often they have to go from specialist to specialist. Well, they have the fulminant process. Well, they have the system of inflammatory response and multi-organ failure. We needed to deal with anemia, and of course, a blood culture should be done in this case. Antibacterial therapy should start as soon as the diagnosis of infectious aortic aneurysm is established. Should last from 4 to 6 weeks and up to the end of life of the patient. Well, in guidelines, there are no proper solutions, so this issue merits the most serious consideration. As for reconstruction, there are two options. Open reconstruction remains the main as of today because historically it so happened. And in my view, there are several problems. One is a purely technical problem because, well, you all know that there are technical difficulties related to manipulations in closed space surrounded by the infectious process. And the second probability is the wide debridement and the dissection of tissues in the abdominal space. Another problem is the selection of material for reconstruction for replacing the resected part of the aortic iliac segment. What can we do here? We can use Dacron prosthesis. Well, there are prostheses that contain silver, or we can use gelatin Dacron prosthesis saturated with rifampicin before reconstruction. There are different saturation methods, up to 600 milligrams, different time of exposure, but the rifampicin prosthesis works for 7 days. Well, then the antibiotic will be washed out from the prosthesis and the tissues, and we will have just usual unprotected synthetic prosthesis in the area of the reconstruction. We can use also femoral veins of the patient, and there will be the new aortic iliac system, which shows very good indications in terms of the risk of infection, but unfortunately up to 22% we can have deep vein thrombosis. Well, and in 15% of cases, well, there may be chronic venous insufficiency. Well, as for the bovine xenopericardium, well, it is not very widely used. In terms of the risk of reinfection, it's basically the same as the risk of reinfection after the use of the rifampicin or silver prosthesis. Its use requires additional manipulation and the formation of a xenopericardial patch, the formation of the tubal structure, which requires additional time. Well, the donor aortal homograft can be considered as one of the options, the option of choice for reconstruction of such situation. Good indications in terms of infection, but there might be degradation and the development of ischemic complications. Well, extra anatomical bypass is still the option for such problem. The endovascular reconstruction can also be used. You can see the recommendations allow us to do it. It can be the standard reconstruction method, especially for elderly, unfit patients, or as the therapy in case of rupture. So the use of EVAR in patients with infectious aortic aneurysm can lead to a higher risk of repeat bleeding and fistulas, which was mentioned in the first presentation. Well, the rigidity of the structure can lead to the higher risk of fistula formation. Well, it looks like, well, this idea is not quite good. The implantation of additional foreign body, which might be the source of infection, even in case of antibacterial therapy, EVAR done in this case, well, doesn't seem a good idea. But if we look at the situation in general, in the left part, you can see the comparison of endovascular techniques and open procedures. Well, you can see there is an advantage here, showing the advantages of the open procedure in time, especially when we're talking about 5-year follow-up. They have an advantage due to the more reliability of reconstruction. Well, extrapolation and the trials, retrospective trials on patients after EVAR and open reconstructions in terms of infectious aneurysms, well, you can see that there is no advantage of open surgery. Endovascular surgery has the advantages in the post-operative period, the reduction of mortality in the post-operative period, and then, well, you can see Kaplan-Meier curves depart, but then they are basically the same. If we analyze subgroups, we can see that patients after EVAR was done due to infectious aortic aneurysm, there is no increase in the mortality rate due to infectious diseases. These patients die from other reasons, not from infectious complications. That's why, as for guidelines, especially, well, the ESE guidelines, well, you can see the guidelines showed here. Well, if you look at the use of the multidisciplinary team and the post-operative therapy should be administered, such as antibiotics. Again, everything depends on an individual patient. Well, just a few words about the technical aspects of doing the open procedure. Well, the major condition is achieving the proximal distal control before you enter the zone of infectious aneurysm, because if there is a bleeding develops, it will be difficult to stop it because of the difficulties related to the manipulation in scarred tissues. Culture tests are necessary, and also the sanation of infectious structures. Well, debridement of these structures. Well, you can see proximal control area on the left. On the right, the reconstruction has already been done. That's not the picture we usually see when we have a procedure for degenerative aneurysms. We cannot just use the T-shaped incision. We need to remove the entire artery. There is wide dissection performed of the bone structure of the spine. You can see the inferior vena cava, the resection of the muscle here, and there was abscesses here, so it looks a bit different. Here is the reconstruction zone. It should be covered with the highly vascularized tissue. Usually it's the omentum, for example. That's the way it looks on all sides. We reduce the risk of the repeat infection. Well, the donor aortal homograft, it can be harvested, and it can be kept up to 16 to 30 days. It remains live. Well, in Russia, this is not an indicated procedure. Well, not a registered procedure. Well, in other countries it exists, but its price is for $20,000 per 1 unit and even higher. That's not cheap. Aortal homograft doesn't require selection, doesn't require immunosuppressive therapy in the future. Just 3 cases. A man 61 years old was monitored for a long time, was treated by neurosurgeons. Well, inflammatory spinal diseases, destructive diseases, and again you can see a repeat CT was done, aneurysm was detected of a complex shape. There was a procedure together with neurosurgeons, spondylolisthesis. There was the resection of the 4th vertebrae, and there was the implant inserted with the metal structure. We did the resection of this aneurysm with the replacement by aortal homograft. Well, as for guidelines, after this procedure, we should do the reconstruction. After the reconstruction, there should be the 4-week antibacterial therapy intravenously. So the patient was at our clinic for a long time. Well, that's a repeat CT. 1 month later, the formation of a complex aneurysm in the distal anastomosis area. Although there was the drainage which was being washed, they didn't save the patient, so we had to do a redo procedure together with neurosurgeons who removed the bone homograft, and we did the cross bypass because we were not sure that we'll be able to control the infection in the retroperitoneal space. Another patient, 46 years old, a young patient, was hospitalized, pain in the back, in the lower back, lower abdominal pain. Abscess was detected there were 2 abscesses filled with pus, and there were also black necrotic masses next to the right iliac artery. We did have a homograft at that time. We did a cross bypass. And the last patient I'd like to show you, unfortunately, we didn't manage to save him.
Часов вечера, и в понедельник на следующей неделе, то
And again, you can see the patient died. Unfortunately, he was hospitalized with the systemic inflammatory response, tachypnea, tachycardia. He was put in ICU. We ordered the homograft, but unfortunately the patient died at night. Unfortunately, no autopsy was done at the request of the relatives. Was there the rupture in the retroperitoneal space, so the patient died of sepsis? Well, probably he just died of sepsis. Well, I'd like to give my tribute to Oleg Reznik, who died this year, unfortunately. Well, but he left a lot of legacy, a cohort of students, and thousands of grateful patients. Thank you very much.
Спасибо большое за интересный доклад. Инфекционный аневризм.
Thank you for this interesting presentation. Infectious aneurysms are rather rare things. There are not so many surgeons who have thousands of experience of treating such patients. Well, unfortunately, hopefully it's not very widespread, so I hope you will encounter such patients not too often, because treatment of such patients is very specific. And sometimes there is no response, no clinical response. All right, well, can I ask a question? Well, a question for my colleagues. Who is ready to implant the stent graft to do the EVAR in this case? We do it, what there is one nuance say, we do it using PTFE grafts because they are more resistant to infection. Second, well, there must be a good sealing area, hermetic area, wider areas of sealing as compared to abdominal aorta. So like 20 millimeters is not enough. Well, tissues are kind of poor, and well, the third aspect is oversizing. Well, it's difficult to understand what should be the oversizing. Well, like in case of dissections, and of course, it's not clear whether we should use. Well, let's put it this way: since it is aneurysm, we should. Well, say that oversizing should be 20%, but there are such intimate properties when we need to do it size in size, and here we use the tactic the same as in case of dissection, so well, up to 9%. And as the isolated procedure, we do not do it. We later, well, do the debridement, and we do it openly, and again, we involve the omentum. There is no other option, and in this case, patients usually survive. So we give them some time to stabilize the process, and we use a PTFE. Well, PTFE is very convenient because we were at the autopsy of such patients 2 or 3 weeks later. Well, you can see a good growth, and there is a powerful tissue adhesion, and usually there is a very good isolation, unlike usual prostheses, which remain the source of infection in such cases and not properly internalized. Let me just make also my remark. On the right part of the slide, it was written, may be used as a standard method. Well, it grades on our eye because, well, I would probably, well, use endovascular approach, and you should be psychologically ready for EVAR because you must realize that this patient will be your patient after implantation. Well, that's not my conclusion. Yeah, I understand that these are the guidelines, not your conclusion. That's why I did not make any remarks, but first, try to use the open surgery because this patient will be your patient. You will be responsible for this patient. Well, if the vascular surgeon makes this decision, well, you will have to be responsible for this person. Well, open surgery can be more difficult, and after EVAR, well, especially after the tissue exposition, and as for PTFE graft, well, the growth is quite good after 1 or 2 weeks, and I think it's because, well, there is inflammation coming to an end, and this growth is due to the inflammatory process. Well, that's my opinion. You should see what happens in 2 weeks, but after 2 weeks, PTFE graft is grown into the aneurysm wall. Maybe it's not good. After 1 month, well, this growth can lead to the graft infection, and this is a totally different story. Thank you very much. Well, that was a wonderful presentation, well, wonderful exposure of the aorta, and it reminded me of the surgical treatment in case of foot ulcer. Well, you studied different literary sources, and maybe you can say a few words about this super selective use of antibiotics when we have a jailed catheter. Maybe antiseptics, antibiotics did encounter such works. No, but the problem is, well, jailed catheter, for how long can it be there? Months. That's the problem. As the initiation, yes, it's possible. Yes, we had a catheter, we left it, we washed, but they didn't save the patient, and there was the nosocomial Klebsiella, polyresistant Klebsiella. Well, the catheter was used here, we used a bacteriophage, but it did not save us in the area of the distal anastomosis. Thank you. Thank you very much for your presentation. We are behind the schedule, so we must move on. And let's give the floor to Mikhail Valerievich, and then I'll try to catch up. My presentation is devoted to long-term results. Well, and prosthesis is probably the gold standard, not an alternative to the open surgery. We do not see 30-day mortality or any complications, and of course, the hospital stay is shorter in case of with open surgery, but there are still the advantages of open surgery. First of all, that's the surgical suture in the area of hermetization. Well, we can use the Charlie fix with distal suture. We still have questions when we're talking about common iliac arteries. Surgeons just zero out the aneurysm diameter, they sew up the sac, they just ligate the side branches, and I've known I didn't know a surgeon who would not just suture the orifice of spinal arteries, and surgeons who do EVAR, they don't have questions about the spinal stroke or not. And as for the implantation of the lower mesenteric artery to prevent any complications, that's one thing, but as for spinal strokes, I think they do not mention it.
Такой надежной герметизации мы можем рассматривать
As an alternative, we can talk about proximal embolization of large branches, spiral embolization, and the problem of long-term results is of great importance. 40% of our patients do not have the optimal anatomy. That means there is a risk for such patients when we use this device off-label, hoping to have some miracle. The favorable predictor is the reduction of the aneurysmic sac. well, our patients need high-quality post-operative monitoring. How to see this reduction of the size of the sac? You should do a CT on a regular basis, and we use the active surgical tactic for first and third types of leaks. Well, but again, you can see the second and fourth type of leaks. Well, we do not quite embarrassed by them, so the guidelines recommend we intervene in case of significant growth of aneurysmatic sac. When it's type 2, we should interfere, especially when the sac is more than 2 millimeters as compared to the original size. As for the diameter, we turn to diameter when we provide indications for endoprosthesis, and we'll look at the diameter also in the post-operative period. However, this is not, in our view, a reliable assessment of the post-operative dynamics. There are several works showing the different frequency rate of endoleaks of type 2, like maximum is 40%, but endoleaks type 2 occur rather often as the patency of the lower or inferior mesenteric artery before the procedure. We deal here not with a puncture hole after coronography that will be closed itself. Well, if you exert pressure there or isolate the aneurysm, well, this side artery will be closed, but here we're talking about nature itself. Well, there is some kind of way from aneurysm to the stomach, and obviously this way will not be closed itself. Maybe we did the CT in the arterial phase, or, for example, it was venous delayed CT, but it doesn't show the endoleak. We do super-selective angiography, and the situation changes. Well, again, well, as for retrospective studies, they show that even with the non-enlarged diameter of the aneurysm, 20%, we can see the growth of the volume of aneurysm. That means change or morphology. That means the risk of endoleaks type 1 on the edges, which is dangerous. The standard is 5 millimeters. Well, 5 millimeters. Well, this can lead to significant growth of aneurysm. Well, step by step, we can say that we must be more attentive to the post-operative period, to the assessment of the volume assessment. Right now in Russia, there are two software allowing us to assess the post-operative aneurysm size using the semi-automatic method with the bias of 2 to 3%, as it was shown before. And you can see the assessment is done on the basis of summing up of voxels from the lower renal artery. And also, before the surgery, we can assess the thrombotic burden, the intraluminal thrombus, and this became the pretext to study the prognostic value of this factor, such as the thrombotic burden. Well, there are several nice examples. Again, no growth of the maximum diameter of aneurysm. Well, you can see the landing zone is shorter. The patient could have done this 2 years ago, but now we're thinking about chimney and fenestation with different kinds of risks. The change in morphology is shown here. The maximum aneurysm diameter after endoprothesis increased, but the volume reduced. So the aneurysm changed. Well, we see that the volume then goes down. And, well, everything looks differently. Several works based on the volume assessment, as I have already shown you, and they are very contradictory. Some people say that the risk factor leads to huge thrombotic burden, and some people say that it's not the juxtaposition, but thrombotic burden is a good predictor of the normal isolation. Of normal isolation, maybe the high thrombotic burden leads to the occlusion of the passable branches. We don't know whether the volume is a method of forecasting, but we know that after the surgery we can use it. The simpler, the better. Look at the maximum diameter, and that's it. Here is another example, shining example, a patient with a proximal neck. He's on blephrin, and again you can see the low rate of wall thrombosis, and here we have a patent mesenteric artery. The procedure was done, no endoleaks. We did not measure the volume because we didn't know about that method, but we monitored the patient for 2 years, and you can see the maximum diameter is shown here. It is growing, well, 5 millimeters over a 2-year period. Well, I don't know. Well, anyway, this is the patient scan. Well, we let him just relax, saying that let's do the control 2 years later, and then after this we can see that the aneurysm is 100 milliliters, and you can see the growth of aneurysm, and again you can see the growth was 70% over the last year. We worked with patients who had the COVID-19 infection. We just did everything possible for our patients, and angiography was done from the orifice of visceral arteries. Well, I'm not going to criticize my colleagues. We did the same mistake, but if you do angiography from the orifice, not super selective, you may not just notice things in the future. Endoleak was not detected. It was decided that it's endoleak type 5 due to warfarin. I monitor such patients, again, endoleak type 1 and good and the prosthesis. You can see the fixation of the prosthesis here. Here is another clinical case, a patient with the stable endoleak type 2, and again we just used the iliac arteries. We tried to close the feeding branches, but the patient has other problems. That's why the patient is still in the hospital. And here is another example, the growth of aneurysm of internal iliac artery when they're not adequately embolized. I mean, the feeding branches are not properly embolized. Well, and just a couple of positive examples, simple anatomy of doing the aneurysm repair, standard EVAR, no endoleak of type 1, but the persistent endoleak type 2 that is seen here. On CT, we can detect the venous phase of endoleak. Again, we can go to the orifice of the lower mesenteric artery. We do the embolization of the preosteum section, and on the right you can see the replay. That's angiography before embolization. On the left it's after embolization. Well, endoleak isolation and the post-operative control. The stabilization of the volume, because the control was done, well, let's put it this way, the operation was done several months, 3 or 4 months after the left CT was done, the post-operative control in terms of volume stabilization, and we're very grateful to those people who developed this method. This is another example of endoleak type 2, the same story, from CT to operation was 4 months. The post-operative control was after 1 month, and the sac was probably growing before embolization of the inferior mesenteric artery.
The method can be used both in evaluation of the volume after isolation of such a particular pathology as aorta dissection. It was discussed earlier, and still we discuss whether to embolize or not embolize the inferior mesenteric artery. the ligation or implantation is performed normally. We are still evaluating it. It's good study, well planned, but the results are not published yet. Whether to intervene or not, we do not ask ourselves. It's very simple. You use 15 minutes and embolize the inferior mesenteric artery before prosthesis, then dealing with complicated instruments, complicated tools. I'm not talking a lot about the conclusions. The clinical value of this method dictate the further popularization of these methods, and it would be great to see the response from the centers with big volume of prosthesing when we talk about evaluation of the volume of aneurysm. Thank you. Thank you. Our time is quite limited, and I announce the next presenter, Mr. Salishkin, on the prosthesing of aortic arch, standardization of the methods. We have to start the presentation already. Dear colleagues, I will say only a few words. We were talking about in situ, on-table fenestration. I will not talk about the technical issues. The founder of this direction is our compatriot. Most all of the producers have their own stent graft with their particular characteristics. In the guidelines, we have it all. Endovascular methods of aortic arch prosthesing. This is our way from surgical debranching with creating of so-called bold arch, and we have different fenestration approaches, and this is the dynamic of the growth of fenestrated on the aortic arch. We did nearly 50 cases, and most of the surgeries are performed in 3-zone when subclavian artery you see that it is concilium, scallops. We sometimes even suture the fenestration of the head position when the tortuosity of aorta is very high, when stent graft will turn. And it's difficult to compare the ostium of the vessels, and the fenestration should be sutured by wunderkist. Very good mark that you will see well. My presentation is dedicated to the standardization of the methods. I'm not talking about technical aspects. The number of the procedures is increasing. We can move to some standard. This is the protocol that we have created in the recent years. It is pre-op diagnostic, some methods. It can be intra-op control and fixation of the branching in supra-aortic. The master branch, and we can compare to all the doctors who work with a CT well. We have calculation, different softs. Without this knowledge, we cannot deal with these issues. In the zone 2, we do not use a TOEFL, but in 0 zone, it is a must to perform this navigation. It is a must to perform this navigation, intra-op navigation. This is a typical example on patient stent graft opens in the 0 zone under the navigation control, and the clinical example where I'll talk in details In angiography, everything is patterned, even we can palpate where the pulsation is there on all the vessels. There is a pressure on the left hand. At angiography, it's all okay, but on the ultrasound, we see the blood flow in the carotid artery is monophase, retrograde flow, and the stent graft implantation into carotid fenestration. This stent graft would be centrated, and the blood flow normalizes and becomes as before the surgery. It is very rare case, because architectonic of the ostium changes in any case, and any enhance of the blood flow. It should be two-phase. We have to have systolic phase, diastolic phase. We have to have normal speed. In the implantation, if on the previous slide we see retrograde blood flow of the spine artery, the implantation and graft centration in aorta, so the fenestration of subclavian artery, and without additional stenting, we add this antegrade blood flow of the spine, and the pressure on the left and right hand increased. We're talking about efficiency of debranching here. And we see that the difference in the pressure is different interoperatively. We consider CT, or it's a must. Without CT, you should not discharge these patients. This is our small development. We want to try it on the animal model, this kind of introducer into aortic, intra-aortic shunt to have the blood flow for the opening of the graft in the ostium of carotid artery. It is not excluded that we will achieve full prevention of ischemic events. Thanks for the attention. We are done with our session. Thanks for being here with us. And It's high time to start. Well, let's start then. Well, dear colleagues, we start our session that is dedicated to chronic hypertension. It's a very interesting session because here we have all the experts that deal with this problem. We start with Mr. Grankin presentation, the result of endovascular treatment of chronic thromboembolic pulmonary hypertension and proximal lesion of the pulmonary artery. Let's talk about postponed result of the treatment of chronic thromboembolic pulmonary hypertension when we use balloon angioplasty. The topicality of the problem is that chronic thromboembolic pulmonary hypertension appears most commonly due to thromboembolism and in situ on different levels in main segmental and subsegmental damages. Thromboembola that did not dissolve spontaneously evoke occlusion, damage of the pulmonary artery that leads to pulmonary hypertension and heart failure. It can be seen by the following symptoms. It is shortness of breath. We have the symptoms of the shortness of breath together with the shortness of breath. And MSCT and CT and pulmonography Что? The segments of the upper lobe segments, that branches go from the side, and we have this side. The distal segmental and subsegmental branches. In thrombosis, most commonly we see the damages of distal part of subsegmental artery. The position of these arteries does not influence the level of hypertension and modeling of the right ventricle. We commonly see concomitant damages on different levels, relapsing state and the state of after catheter thrombolysis. This is the design of the study where 144 patients and 446 sessions of balloon angioplasty was performed with pulmonography and invasive physiology. Before and after the treatment, the patients were divided into two groups with proximal and distal groups. The inclusion criteria is hypertension with the according to the date of catheterization, at least 3 months of anticoagulant therapy after manifesting. And this patient couldn't have been sent for the operation, and after the surgery they had residual hypertension. If these were patients who were rejected the open surgery, mainly these were relapsing tela that appeared after a certain time after the surgery. 4 patients died in early post-op period, and few patients were on ECMO and 1 patient after endarterectomy with the high level of residual pulmonary hypertension. 144 patients were analyzed. Proximal damage 76 and distal damage 68 patients. As for clinical profile, there were differences. More severe heart failure were in the group with proximal damage and significantly more endarterectory for patients with proximal damage. We consider it as a relapsing thromboembolism, pulmonary thromboembolism. In the group with proximal damage, the pressure was higher and the function of the left ventricle was worse compared to the ultrasound of the ring of pulmonary artery with proximal lesion was of bigger diameter, and the function of left ventricle suffered more, not significantly, but more in the group with the proximal damage. And according to the total number of the hospitalization, we see for 3 patients with proximal damage, 4 of them are on ECMO, and there were patients on ECMO and 1 patient after endotorectomy with a distal damage. This patient with hyperperfusion syndrome we extended too many segments, unfortunately, and we got the lethal case. The complications are demonstrated here on the slide. You see this is mainly bleeding that did not require surgical intervention. And that was enough to arrest this problem. The frequency of secondary intervention was 30%, and the number of the segments with the secondary intervention was in distal group. The final indication was performed is performed on the slide, and the results of the final pulmonary resistance depending on the final positioning. Altogether, there were 30 cases, lethal cases during this whole period. In the distal and proximal part, they were more or less equal number of for the lethal cases. And to conclude, postponed results of endovascular treatment do not depend on the localization of the damage, and thromboembolic pulmonary hypertension have similar cases as in postponed results. Now I will demonstrate to you the clinical case. A patient with thromboembolic pulmonary hypertension had the open endarterectomy in 2 years. He again has the symptoms. The diagnostic catheterization was performed in the right chambers of heart. Ostium damage was found on both sides. Dilation is seen here. Then coronary balloon was substituted with peripheral balloon on the 35 guide with good coronarography result. Same on the right side. We see similar problem, the bifurcation, the damage with the damaged segment. The substitute for peripheral balloon and final dilation. Oh, well, we should mention this year all these patients. I can present only one case. The patients were operated this year endovascularly, and we don't have now the balloons. We use amber lines mainly, calibre from 6 to 8 millimeters. We can use on the coronary guide wire, on the 18 guide wire. In this case, there is no need to change the system, to substitute the system of the balloon or the balloons on the 35th guide wire, and that's why we can decrease the time and probably even the price of the surgery. That's actually all from my side. If you have any questions, I'm open to them. Please use the microphone. I'm from Moscow. What were the results, positive results, when you perform balloon angioplasty? What you consider positive result clinically, hemodynamically, and then I will have this. So you perform angioplasty. What is the acceptable pressure? How do you consider that the result is good? Well, thank you. Angiography result is evaluated immediately after the procedure. No residual stenosis and thrombosis after the intervention was considered as a positive result. The measurement of the direct pressure without measurement of the resistance we perform after each procedure. I cannot say that the pressure decreases immediately after procedure. The patients require few sessions, and only after third and fourth session we can get some significant decrease of the pressure. In most of the patients after the successful procedure, the frequency of the shortness of breath decreases, a 6 minutes walking test improves. So after the first session and at the very end, we measure the results of the ejection fraction and hemodynamics. The medium pressure in pulmonary artery decreases significantly, and we can see it. Why I'm asking, I will explain to you. In distal damages, it is less than half in one patient, so you have one session enough for something. These are median data. The span is quite big, but this well, actually, I will clarify here. Not all the vessels would be possible to be opened. The occlusion not always possible to be opened, and that's why we cannot always talk about successful procedures when we can recanalize occlusion. Short question, very short question. You mentioned in the group of distal stenosis reperfusion. According to the publications, reperfusion leakages appear quite often in 20 to 30% of cases. Why is so low percentage in your cases? Thank you. Let's go back to the presentation, please. In short, no need to spend all your time here, but just in short. Well, 1.5. You had 1.5% in proximal group and 1.5 in distal group. In proximal group, we had patients with distal lesion. If it was concomitant lesion, then the picture would be different. Well, let's proceed. We're already behind the schedule. Thank you so much. We will discuss everything at the very end. Let's continue. It was great presentation. We have here Mr. Danilov with the presentation about hybrid interventions for chronic thromboembolic pulmonary hypertension. I see you, you see and hear me. We hear you. I don't see my presentation, by the way. That's the problem. Do you see? Okay, now I see my presentation. I'm happy to greet all of you. Thanks for coming here. We developed in our cardio center as such an intervention as hybrid intervention in CTPH. Studying literature, we see that this initially an operable approach Let's say a few words about this history. In 2012, it was the beginning of complex approach. We see that it is at the same time when angioplastic of pulmonary artery plastic, the surgical support started developing. The catheterization started to be performed quite often, so the interest is quite intense. And to resolve the question on the tactics of treatment, the multidisciplinary board decides the therapist, surgeon, and angiography expert. This is how, from 2019, the algorithm for treatment of patients with CTPH problem with angioplasty of arteries and lung-specific therapy is already lagging behind. It is somewhere as a supportive therapy, not a must, but we'll still need it. This is an ideal scenario for chronic thromboembolic pulmonary hypertension treatment. If we perform thromborectomy, if it is operable, if it is not operable, then the best algorithm is to prescribe strong vasodilation, selective vasodilation, with further angioplastic. You know the results of this register. It was closed quite a time ago, and you will see that one of the reasons for rejection for thromboenderectomy are technically difficulties that a surgeon can face. But still, the question is there. If it is technically possible to perform this intervention, but there are some other cases. I asked our surgeon what would be the distribution of the cases to refuse thromboenderectomy. He says that there is a high level of pulmonary resistance. On the second place, concomitant severe pathologies of the lungs, and other cases, many other cases, among which we can see such as blood coagulation factor issues, thrombocytopenia, and other situations. The situations that does not allow us to perform this surgical correction, even if the technical possibility is there. Sometimes it's just impossible to perform it. And as always in these cases, we have question, what's better to choose? Do we choose surgery or PCI? And having analyzed our experience, we decided that we should not oppose these two methods. We have to consider them together, because in many cases we can use these methods simultaneously in one patient. Yesterday I performed pulmonography for the patient who is a good illustration of my words. You see that the right lung is more stage 4 stage pulmonary angioplasty, and as for left lung, it's impossible to perform angioplasty there. We have to perform surgical intervention there. This is the variant when we have some obstacles for surgery. We can make the situation better. We can improve hybridynamics. We can perform revascularization, and only after that we send it for the surgeons, and we can perform the surgical correction that would be accompanied by a lower risk. More often, this hybrid approach that we discussed today is considered from primary correction point of view, and only angioplastics. We stress on first uncommon unusual way, and then after we improve the total state, the surgeon performs the other intervention. We analyzed the pilot project. The patient who were feeling well, we perform first surgery, then angioplasty, and vice versa. And turns out that the second and third group, as if we talk about the results and functional status, for improvement of the functional status, they are comparable with the operable group. These are initially operable patients. They demonstrate the better survival ratio compared to the patients who had a better survival. If we prescribe only right saguat, then 6 year survival would be only 81%. We consider different cases. This is the case when angioplasty was performed, then surgery, severe patient, 60 years old with diffuse bilateral damage with proximal pulmonary arteries, high level of pulmonary resistance that is associated with high risk of perioperative complications. And probably you would first give this patient vasodilator, but we see the compression of coronary artery, and it does not allow us to choose the conservative tactics. We started with angioplasty. You see, we performed 4 procedures. The situation improved in the lower limbs, in the lower lobes, and at the same time it has demonstrated the resistance level. And what was most interesting, on the control coronography, we saw that the decrease of pulmonary trunk by 3 millimeters led to the fact that it stopped pressing left coronary artery. The patient changed completely. She became surgical, and that happened, thankfully, what we see after successful angioplasty. The second stage was surgical intervention. You see this is the morphology, and the patient recovered. And one more case when we started with angioplasty of pulmonary artery, no typical case. The young lady, 43 years, was admitted with a very severe stage. You can see that here, severe right ventricle failure. The question was to prescribe the drugs, but she had significant hypertonia. Surgery was not even discussed, so there were 2 sessions. The blood flow was restored in most vessels of the low lobe of inferior pulmonary artery. We see that this is the situation when we can have the urgent help. Then the situation changed. Only shortness of breath stayed, but the pressure improved, and further on we can prescribe Reotzigot, and this approach demonstrates very good result. The patient was prepared for thromboendorectomy, and it was performed successfully. I think you would understand me that sometimes the surgeon asks to help, and sometimes we just don't stop. The surgeons do not have anything to do. This is a more interesting, I would say, brighter case when the patient see the heparin-associated thrombocytopenia. This is the result we have hemodynamically. We see that the level of pressure and resistance are here, and the patient are in the prognosis, with a favorable prognosis. And to conclude, these are 10 years result. Perioperative and early post-op period mortality is 0%, very low level of complications, and about 15% of their cases we use hybrid approach. Most of them we start with angioplasty, and then we have surgical intervention. Thanks for the attention. Thank you. Thank you. Very interesting clinical cases you usually have, dear colleagues. If you have any questions, please ask. Manolis. Hello. Why do you say that it's hybrid approach? It is stage surgical endovascular treatment. If you say hybrid, if we think that it is endorectomy, balloon dilation, do they say it in literature that it's hybrid approach? It's beautiful. It's just beautiful word. We like it. Of course, you are right. It's staged approach, but we love the word. It's more elegant. Well, I know that I was doing hybrid approaches, but it's not staged as well. So it's the combination of combination, right? It's combined. Our German colleagues who tried to perform totally hybrid approach, and within one procedure, they performed thromboenderectomy. And during this deep frozen stage, they tried to open it, but it didn't work. So we just stretched this hybrid approach in time. One more short question. There is a Kawakami classification. We have this deposited lesion and other. But when we talk about proximal stage, we can call it wall thrombosis or thrombotic cup even. Is it possible for real to influence them with angioplasty? Because you speak about proximal damage, but sometimes it's just big thrombotic lesion, and visually we can get rid of it only using thromborectomy. What is your opinion? Well, this is a great question, a really great question. We have big experience with it. We know how to open proximal parts, and it could lead to optimal result. And it would happen due to the reason that you've just voiced. And my opinion is that you either improve the opening in the distal parts of the other segments as the first variant, or if it is impossible, in proximal part, you have to set peripheral big diameter stent. You have to do it, and the effect would be really good. And we have such international data, really. Thank you very much. We are behind the schedule, and I pass floor to Mr. Marokyan with the presentation Pulmonary Artery Balloon Angioplasty and Chronic Thromboembolic Pulmonary Hypertension from Almazov Center. Thank you so much. I decided to talk about complications. Let's talk about the following. From 2022, balloon angioplasty is class 1 recommendation, and it is important to see and to mention how the strategy changed. We used to think that 2 arteries in one session, 3-4 arteries. Now we try to treat as many arteries as possible, but limiting contrast. we need to revascularize as many arteries as possible in one session. We try not to leave stenosed or occluded arteries. And of course, we perform pulmonography before and after to see which arteries are there and to treat them. The Japanese colleagues divide the complications into 4 types. The first type of the complication is wire perforation. It happens in 7% of cases. And the embolization can be performed with balloon catheter, in small ruptures. The next type of complication, perfusion, injury that leads to blood spitting, and sometimes it just disappears itself. The next group of the complications is ruptures. In big rupture, we do not always react fast enough. I'll show it.
And the 4th group of complications is dissections. They are most benign complications. They can occur rather often, and they can resolve within 1 week. Well, as for occlusive dissections, I haven't noticed such situations. This is our patient after successful BPA. Well, you can see this spot here at the bottom. We can do the inflation with a balloon catheter for 3 to 5 minutes, and, well, no oozing. Can you launch the video? No, you can't do it, okay. Anyway, my colleague from Brazil sent me these slides. He had to use the balloon catheter for half an hour while he was preparing the embolizate. The oozing stopped. And you can see the publication. There was the rupture of one of the basal branches due to the orifice stenosis. The stent graft was implanted. A control scan was done a year later. Everything is fine. Well, here you can see the same principle. And again, we embolized by using coils. You can see it on the right. And this is a more severe complication, ruptures. And in such cases, cardiac surgeons can help you. And do lobotomy. Well, this is a rather rare complication. When we have arteriovenous fistula after balloon angioplasty, if the fistula is small, it doesn't pose a serious threat. And also reperfusion edemas, that's another group of complications, 5 grades of edemas, starting from the light one requiring no treatment to severe edemas that require ECMO. And, well, you can see the percentage is rather high, especially in patients with the pulmonary hypertension and occluded branches. Well, it's about 25 to 30% of cases as far as edemas are concerned. How can we treat edemas? Well, diuretic therapy, insufflation with oxygen. Also, if it doesn't help, CPAP, glucocorticosteroids administration, and in extreme cases, inhalation, NO or ECMO. Well, we have come up with the perfusion deficiency index to assess the efficacy of BPA, and the most effective patients are those who have the maximum occluded branches, because in the post-occlusion bed, the periphery remains. It doesn't suffer from pulmonary hypertension, and after the successful recanalization, well, the pressure in the pulmonary artery goes down quite significantly. And here I would like to show you several clinical cases from our practice. We try to recanalize occluded branches, so we have to resort to retrograde recanalization in those cases when the arteries are occluded from the orifice and up, and you cannot just place the guide catheter there. Here we used the two guides. We did the externalization of the wire, and we used the snare to catch. Well, again, here is another example. One guide was used, and again, you can see everything has been restored. Could you launch the lower video? The snare was formed by using one guide. Well, unfortunately, it's impossible to launch the video. Then the large artery was restored. Well, this is the third patient. The same situation, the occluded artery from the orifice. On the third video, you can see we recanalized using the Karlina technique, hydrodynamic method. The contrast was introduced through the catheter. This leads to the dissection of the intima, and thus we can get to the stiff part of the occlusion and use the microcatheter. In the past, this technique was described for use in the coronary bed. Right now, there is just one publication. It's our publication in the JACC, and the use of this technique, Karlina-like a technique for retrograde recanalization of chronic thromboembolic pulmonary artery occlusion. I tried to cut down on the number of slides shown, and well, you can see the conclusions. The future of balloon angioplasty BPA leads to improved imaging of areas with stenosis. Well, we can optimize the patients and identify the group of patients which are not candidates for balloon angioplasty. We can develop endovascular instruments important to cooperate with STEPH surgeons, and we try to get together, discuss all these issues. Only in this case, by sharing our experiences, we can develop our knowledge. And of course, the patients must be operated on in high-volume centers. There are three of them. We, the Almazov Center, the Cardiology Research Institute, and the Mishalkin Center, where we can discuss such patients with cardiac surgeons and to manage these patients effectively. Thank you very much. That's all there is to it. Any questions? Thank you for this presentation. Just a brief question. In your clinical practice, reperfusion edemas, how often do you come across them? Well, 25% of all cases. After the effective recanalization of occluded branches, well, if it's a big occluded branch, patients with systolic pressure over 60-70 millimeters, well, they often have edemas, every third, every fourth patient, and usually they occur at first stages. Well, by stage 2, 3, 4, there are a lesser number of edemas because the pressure drops. Well, at least in our patients, well, the risk is low, as the previous speaker said. What kind of risk? Sorry, the percentage of reperfusion edemas. How do you diagnose reperfusion edemas? Well, that's a clinical diagnosis, right? Well, all patients will be put in the ICU. Reperfusion edema occurs on day 1 usually, by the evening or the next day, and patients will be desaturated. Right, okay, but my question is, according to literature sources, 20-28% have patients who had an X-ray or CT. We do an X-ray, okay. In some cases, there was the low percentage. That's why I said there were 5 grades. Light, well, grade, it's innocuous. You may do nothing. Maybe some authors do not pay attention to this first stage. Well, it's not of the question of X-ray. Should all patients have the X-ray done or not? And of course, the frequency of the edema will vary, well, from 2% to 40%, depending on whether you do the X-ray or not. Well, or you can put the patient on CPAP. CPAP is not always needed. Well, but why not put the patient on CPAP just for prevention, for prophylaxis? Well, for prophylactic purposes, well, you can also administer glucocorticosteroids and diuretics. CPAP is not needed right away. Well, I'm not the ultimate truth, but sorry if there is a comment off the mic. All right. If you recanalized the large vein, well, not in all cases, not in all cases. Well, but you cannot have 25 or 30% of patients like that. Well, these are all patients with occlusion. Why not? Well, look here. Our study has shown, and we got a patent for it, patients with the lack of occluded branches are not effective for balloon angioplasty, for BPA. Well, you cannot effectively treat such patients as compared to patients with occluded branches, just because, well, they do not have the post-occlusion bed involved. But in case of stenosis, the peripheral branches suffer if there is long-term pulmonary hypertension. The efficacy of treatment will be lower here as compared to patients with the lower lobe occlusion. Again, the comment is off the mic. What is occlusions? All right. Well, thanks for this heated debate, but we must move on because we will have time at the end to have a discussion. We have a lot of experts here in this audience who deal with these issues. This will let us come up with the ideal option for angioplasty. Maybe in the future we can come up with the consensus, Russian consensus, how to do such interventions. And we know there are European and Japanese consensus, and there are still a lot of questions about how to do this kind of intervention. That's an issue for discussion, and you did a very good presentation, and this concept is very interesting in terms of occlusions, and well, there is the potentially healthy coronary bed behind the occlusion, so the final result can be much better. That's a wonderful hypothesis, yes. And the second aspect, and I showed it at the very beginning, you should treat as many branches as possible. Well, so the strategy is, well, all stenotic and sclerotic branches should be treated. All right, thank you very much. Let's move on to the next presentation. We're running behind the schedule. The Bakalov Institute, Karen Petrosyan, Pulmonary Artery Balloon Angioplasty, BPA in chronic thromboembolic pulmonary hypertension, STEPH. Colleagues, can you hear me? Yes? Can you hear me? Yes? Go ahead. Thank you. Good afternoon, distinguished colleagues. I'd like to thank the organizers for speaking at this conference. And I would like to talk about BPA in STEPH. And so, starting from 2015 to 2024, we had 96 sessions, 74 vessels were treated, and again 37% stage 3, 24% stage 4. And again, you can see the general assessment. Well, 6-minute walk test, 6 points. Again, you can see deep vein thrombosis, patients, and STEP. All the data are here. And again, you can see the pressure here. And again, as for site of lesions, isolated lesions, right pulmonary vein, 41%, 25 left pulmonary artery, both pulmonary artery, 34%. We assessed the geometry of the right ventricle according to cardiography. Again, you can see diastolic pressure 4.5, while right ventricle 41. Additional methods were used, such as IVUS. We also used OCT, which allowed us to identify the structure geographically, well, to see the narrowing, especially false positive narrowing. Here is a clinical case, and we have the occlusion of the right pulmonary artery according to OCT and pulmonography. You can see balloon angioplasty was done to have 30 millimeters of the pressure. And again, you can see the pressure is shown here. And 1 year later, well, again, we invited the patient for treatment. We did balloon dilatation 1 year later, and everything is fine. In this case, here you can see the patient, 51 years old. The diagnosis is CTEPH, chronic thromboembolic pulmonary hypertension. Well, you can see it here, and you can see the result of our treatment. Well, here is the clinical case. We did the recanalization with a good result. Well, that's an angiographic result of BPA and complications depending on the type of lesion. Again, it corresponds to global data, the technical rate success, and the rate of complications. What complications did we have? First of all, it was a perforation of the pulmonary artery. In case of BPA, you can see this is one of the most widespread complications. Here is another case, reperfusion syndrome, which was already asked about. And here you can see STEPH. The narrowing is not very manifested here. That's before and after. You can see reperfusion syndrome. An X-ray was done, then CT, and the outcome was very favorable. There was a case of dissection after BPA in the segmental part, the right pulmonary artery. Balloon inflation was performed for 50 minutes with a very good result. Well, long-term results of BPA, as you can see here, 6-minute walk test. Well, board burden, 2 points. Again, functional class by NYHA from first to 4, third one 75, fourth for patients, the quality of life also improved. Well, again, you can see before and after BPA, well, quite normal indicators. Well, again, BNP was dropped to 103 to 85. Again, you can see long-term results of transluminal angioplasty of left atrium branches in patients with CT-EPH. Again, you can see all the indicators here, how the situation improved, and again, the figures are self-explanatory. Well, these are long-term results of the transluminal angioplasty of the branches of the pulmonary artery in patients with CT-EPH. Again, we have quite improved results according to OCT. Here is the mortality rate during the follow-up period, 6-year survival rate. Again, you can see some of the patients, well, not operable, but in general, patients had the quality of life improved. Combined therapy, like, for example, surgery, and then medical therapy. After this, this allows us to reduce the number of complications after surgery. Thank you very much. And it was a pleasure to speak at this conference, and I invite you to our conference from June 26 to 28. Thank you very much for the interesting presentation. Colleagues, if there are any questions, please. Thank you for your presentation. Just a minor question: to reduce the risk of edema or perfusion edema, you use a distal pressure, which is, it should be less than 30, right? How do you measure the distal pressure? Well, first we open the occlusion using a small balloon. We use the catheter and did the measurement. If it's 15, we increase the pressure to 30. Well, so we try to achieve very good results. Thank you very much. Let's move on. The next presenter is Maxim Kashtanov, balloon angioplasty of the pulmonary artery in the clinical practice without expert surgery of chronic thromboembolic pulmonary hypertension. We're talking about the BPA in the center where there is no surgery or CT-EPH. A lot has been said about the prevention of CT-EPH, and well, it is very widespread. About 10% of patients suffer from ST-EPH. They have a poor prognosis. Well, here you can see the slides where the survival, 2-year survival rate was about 20%. And again, you can see patients are quite significant. Half of them can restore their functional status. Low consumption, low oxygenation, persistent edema. Well, balloon angioplasty is an important option in treating patients with ST-EPH, and that's, as you can see, recommendations class 1, recommendations of 2022. This happened thanks to the changes that occurred when the concept was revised by Dr. Matsubara, and what modalities can be used to diagnose CT-EPH. Well, first of all, in our clinic where I worked before, I worked in a different clinic, so you can see that at our center we use the one-stop shop method because, well, you can see the anatomical picture and the perfusion picture, because in this case we can determine our diagnosis more often, and thus we can analyze different segments. Well, pulmonography, angiopulmonography is shown here. Well, AP projection, AP view, lateral view. Well, again, you can see the 6 French pigtail is used. Well, 30 milliliters of contrast. Here is a man, 43 years old. Looks like normal perfusion, no deficiency in the lungs. 35 is the average pressure. And again, you can see we used angiotomography, and you can see, well, these heavy things showing that there is the damage here, there is the lesion here. Well, as for our technique, it is the one used by Dr. Matsubara, and again, Martina Kurdina, the Polish operator. said that there is the initial phase when we use small diameter balloon. We do the dilatation of usual lesion, and again, when we choose the balloon 1:1, and again you can see the lesion that will be opened. Well, here is another example. A man, 64 years old, was inoperable in 2017. Again, the patient has a CTEPH. You can see the pressure in the pulmonary artery, lots of different branches, and again, we do angioplasty of all lesions that we have, and basically we started with the initial lesion with Dr. Alikan, and we used the transbronchial contrast in order to visualize the distal bed of one of the occlusions, and after this occlusion was controlled using the contrast in the brachial branch. We published the results in JACC. Well, again, you can see 114 patients with BPA. The average age is 51 years old. Well, men 12, women 10. Well, again, mostly patients with proximal and 3 patients with chronic thrombotic disease. And I should say that most cases, I don't know about other colleagues, but we had the predispositions for STEPH. It may be inflammatory diseases, well, HIV, hypothyroidism, tuberculosis, psoriasis, well, asbestosis, and these are just specific concomitant conditions that may lead to STEPH. Well, you can see in hospital mortality 0%. One patient died, well, because of the repeat pulmonary embolism, and you can see this picture. Well, the peculiarity is that all specialists at all stages, well, missed small level of platelets, like 30, and from one branch there is the severe reperfusion edema developed, and the average gradient also dropped. So what is the peculiarity of working with patients with STEPH at the federal center, unlike regional centers? First of all, there are patients who are emergency patients who can be admitted with STEPH and shock. For example, we had a patient, a female patient, who was hospitalized once in 2 weeks due to bleeding, and well, in federal centers they refused to do this, but the patient was hospitalized to our center. She was subjected to angioplasty, and again, you can see other combinations: STEPH, morbid obesity, or proximal CTEPH, and high pulmonary hypertension, CTEPH, and arthritis. Here is an example of the shock. The patient who died, well, again, a PCI was done, and the patient was preparing for catheterization of the right outflow tract. The shock appeared, and well, you can see low molecular decoagulants, and again, you can see the gigantic right ventricle, and again, also there was the CT done before. You can see the thrombus on one side, and on the right side, the head of the proximal thrombus increased because of the anticoagulation, and again there was the left lobe of the lungs involved. What can you offer here? Surgical thromboendarterectomy is not available. Mechanic thromboextraction not available. Systemic thrombolysis, for example, is possible. We improved the hemodynamic a day later, but unfortunately 1 day later the patient died. Well, here is another patient, 50 years old. Well, shock. Again, you can see the lactate was 15 Stella in 2018. Again, you can see the local pressure. That's the way CT looks like. And here we do not see any thrombi except for the 10th segment of the lower lobe of the lungs. And you can see some signs of occlusion in the left lobe. You can see stenoted branches. We did the catheterization of the volta. You can see the pressure in the pulmonary artery. Tachypnea occurred. Well, she couldn't hold her breath. Well, you can see perfusion occurred. And what is the decision-making process?
As for thrombolysis, there were contraindications and for anticoagulants, ECMO and ECMO plus balloon angioplasty. We wanted to pass this way. This possibility was described in papers in this type of these patients with exacerbation, but unfortunately, in our clinic at the same day, cardiosurgeons used the last ECMO set, and the only thing that we could do, we implanted filter with a conservative anticoagulant treatment during a week, and with the support, she was discharged. In 3 months, it was already selective case, 47 median pressure. This is a quite clear picture of pulmonography, and this patient now has the balloon angioplasty. You see here her stages. All in all, she feels much better as she's been treated efficiently. And few last words. This is the first patient whom we operated. At the moment, you see that the patient is snowboarding due to the treatment that was performed. Thank you. Thank you so much. Dear colleagues, questions? You partially answered, actually, my question. How do you evaluate the patency of the distal branch when you are planning the intervention in the chronic occlusion? Well, the question is as following. When we perform pulmonography, and when we have occlusion, we don't see any distal branches. You can visualize it on the computer tomography. Sometimes we see it, and we can use the technique that was suggested by our colleague, transbronchial contrasting. And if it is a complicated occlusion, when the bed is not quite clear, it allows to evaluate the quality of the distal branch. For example, if it is a patient with arteritis, when we have the contrast in the whole branch has changed, you cannot recanalize this occlusion, same as in coronary arteries. Sometimes it is not performed due to practical reasoning. When the occlusion is recanalized, you pass this part, you visualize it, and then you do next steps. I hope my second question is, how is it accepted, the patency, the long-term patency, after you perform balloon angioplasty, one session, then you work on pulmonary and artery, with the long-term patency? Well, long-term patency, does it change? Well, it's a good question. It's more about anticoagulation. I think if it is adequate, then the patency would be nearly 100%, because the high pressure in the system helps us. We perform the balloon, and in a month, the patient comes, and when we perform the angiography, this vessel would look absolutely differently. In normal situation, we don't, if we don't have restenosis, if we don't have rethrombosis, if it is in the anticoagulation field, the first person, the first person who started talking about double energy CT diagnostic. It's a wonderful method that can be implemented and should be implemented. It allows to evaluate the result of intervention before and after. Using this method, it will help us further on with future processes. Thanks for the presentation. 2 energy CT, nice word. Does it substitute scintigraphy? Well, when we talk about scintigraphy, what do we mean? Usually in international recommendations, we say about a weak view scan. We introduce contrast, and if there is mismatch, it gives us the diagnosis, CTLA, and we get a huge number of patients. And whether it is CTLA or not, it is just additional load on the cardiologist. And this method, many radiologists and think that it's a good alternative to weak view scan, and it becomes cheaper. The tomographs are purchased to many clinics. I think it's an ideal substitution, and probably it's even better than weak view scan. But the second question, the purpose of treatment. There are consensus that say that there are 2 purposes. The first one is that the patient should reject the treatment himself, and the other thing is that in many patients we do not achieve of these 30 or 40 perimeters. We open whatever we can, but then whether we're lucky or not, well, after you stop, when you achieve a hemodynamic result, thank you for the very interesting presentation. If you still have the stenosis, which is the volume of stenosis in the long-term period, the percentage does not play here a significant role. There is a criteria of efficient angioplasty. When we see the venous flow, the picture is not always that important. Some narrowing can stay there. If we have good venous reflow, we can stay on this lesion, and then we can go back to this lesion when the distal part is open, when we see objectively the diameter. How many cases do you have for each patient? How many plastics have you had? So for 10 years, you perform the plastic, and then you would do it one more time and one more time. That's a good option, actually. If we talk about conceptually about the treatment of these patients, there are a few approaches, and we need to understand what is optimal approach. We have the approach POP-6 score. For example, Mr. Danilov, who is with us online, he knows this approach. We have Matsubara concept with small balloons, maximum, then big balloons, maximum branches. That depends on personal experience of the clinics. But the trend and the European consensus, they want to use this approach with multiple branches. But whether we use pressure wire or not, there are clinics, I know that in San Diego they use pressure wire, for example. This is justified, but sometimes it makes it more expensive. But the idea is good. The idea is good, I agree with you. I wanted to ask this question at the end, but still, when you start angioplasty, the patient has occlusion and stenosis. Where do you start? I have written this question for myself. I'll share my own experience. Where we start? I try to start with low lobe, branches because they make biggest input into the decrease of pressure. The idea is if we start working on high pressure in pulmonary artery and we treat inferior lobe branch or some other segment, medium segment, we will have the effect, but the pressure will not significantly decrease. If the pressure does not decrease, the edema would be more severe. If we treat low lobes, the edema would still be there, but the efficiency is higher. Formers. Okay. If you have stenosis, inferior and superior, I would go to the superior, to the basal segment. And the clinical state of a patient with this very severe occlusion of lower lobe and stenosis. What I want to say, there is no individual approach, right? If the person is clinically severe, we need to perform a bronchopulmonary angioplasty, and only then we will deal with the occlusion. Of course, if the patient is in severe state, if we will just not be too stubborn. Let's proceed. And we have Dmitry Sulimov from Leipzig, from Germany. He will talk about the interventional treatment of acute PE, a review of device. Thanks for inviting. I hope you hear me well. Okay. If we talk about I hope it's me. I don't have any disclosure, and I'm not Kashtanov Maxim, and we're talking about acute thromboembolic pulmonary artery. We try to turn pigtail, we try to perform localysis, we try different devices. Then we had an angiojet and aspirex. We get penumbra in different magnification and flow trailer. First and foremost, I'll talk about penumbra. Penumbra published a 12 French catheter with a special tip that decreases the volume of the blood loss. But the thromb, of course, is huge. We need to make them small, and step by step we have to aspirate them. Even acute thromb does not dissolve in the particles. They stay in legs and they come pretty hard into the lungs. This type of procedure is associated with big blood loss. I don't have lightning 12. I have the experience with penumbra. It is limited. The possibilities are limited. And I use catheter 8 French. As you can see here, it is already in the vein. Through introduce 11 French. It was efficient for a long time. It was long but efficient, and we managed to open both sides. But unfortunately, the patient died because the patient had too long resuscitation before she was admitted. But the aspiration with the fragmentation with the big catheter works. It requires a lot of time, and it is associated with a vast blood loss. That was demonstrated in the study. This trial extract with 8 French catheter, the patients with medium risk, and as the end point, they evaluated the decrease of right ventricle load on CT. We remember that right ventricle diameter decreases if there is blood loss. Here we have a good result. This is the medium risk patient, but they are not very interesting for us. Flow Trigger is a great system. The catheter up to 24 French. It is quite flexible, hydrophilic. It allows to introduce a distally. For this catheter, there are additional nithinol discs. They are modified, but It's important that the disc suits all the sizes. You introduce it, it is expanded, it works like stent free, it mobilizes the thumb, then you can pull it towards yourself and you remove the blood. And the particularity of the catheter that we have special syringe, special tip. It's all very big, of very big diameter, and the thrombus will pass through this tip because the size is big. Flame trial was recently published. It is not randomized study, but there were many patients. The patients with a higher risk, it's important. These two parallel group, the patients whom the patients, the surgeons decided, the physicians decided not to treat them commonly. And what is important here, there was significant reduction of mortality in acute period. So the trial was finished preterm because there was the mortality reduction nearly to 3%. It is absolutely significant result. And here's the patient, 52 years, shortness of breath. Before he was admitted, he lost consciousness. Since that, his shortness of breath is increasing. He has thromboembolism with a thrombi that is hanging from left to right, and he has significant dilation of heart chambers. The right ventricle is too big, and here is the beautifully hanging thrombo. And here is the video of thrombectomy. I'll show you the system fully. They introduce a 24 French dry scene. It is introduced. We always use IVOS in this case. It is a big access. Nobody knows what would be at the very end. Probably we will have local systemic thrombolysis. We always perform the puncture under ultrasound and suture in suture in advance. We go through ventricular artery. We use pigtail in this case. It's important that we do not rupture anything here. If we use 24 French catheter for aspiration, we can use implant supersede. It is introduced into the lower lobe segments. In this segment of catheter, there was some amount of air or fluid. The pressure is lost, so you first try to aspirate. If it filled immediately, you turn on the syringe, you see nothing is there. The thrombi are already at the entrance of the catheter. They just sealed. It's open in 24 French, 7 millimeters. You can imagine what is the size of the thrombi. You can remove this thrombi. We can reperfuse it. The syringe is of the 6 millimeters volume, 6 millimeters of blood loss. The aspiration is not needed quite often. In this aspiration, we see that it can be performed more regularly, but now it's even easier. At the end of the procedure, you will see all the particularities. And now we have the blood reinfusion. We rinsed it, we washed it. It's still there at the tip of the catheter. Aspiration is going, and this thrombus does not allow to aspirate it. We pull catheter. Of course, we can lose the thrombus at any moment when we are pulling it through the vena, through the heart chamber, and you will see the size of the thrombus now. you see that the tip was positioned distally in the vena cava, and of course we don't want to lose the clot somewhere in the introducer. The patients survived normally this procedure. We had the patients after the intensive care unit, but these are different patients. We cannot talk about tolerance there, but there are patients who are not intubated. Normally they tolerate the procedure normally without hemodynamic deterioration, though there is additional stenosing factor as there is a big thick catheter. And now we can see that there is a huge thrombi at the tip of the catheter. These are not all the clots. We have performed angiography. We have to repeat it with DSA. These are acute patients. They cannot hold their breath too often. We perform thrombectomy on the both sides regularly. As we have aspirated, the reinfusion is not so dangerous. I'll try to show you this big clot. We go to the other side. It's more interesting part because their thrombi were positioned more distally. This is the 16th French catheter. You can use it, and you can use it in this. You can catch the clots in segmental way. Not always the thrombi are allowed to catch them, especially if these are old clots or if they are growing for a few weeks already. They attach to the wall quite closely. But all in all, this possibility exists. The tip of the introducer is more problematic than the tip of the catheter. And we see that there is a good bolus, and we introduce the thrombi extractor. It looks like disc in the pulmonary artery. You just open it and you wait for 5 minutes. If the patient is ill for a short period of time and the procedure goes quite fast, and it would take only probably 40 minutes. If the patient is ill for 2 weeks already, then these are torturing attempts to mobilize thromb, and you will attempt to to perform it in 40 minutes. Finally, control angiography. We do not perform it always because if we get a good result, if the patient feels better, if the pressure in pulmonary artery decreases, just pay attention. Here is a perforation. It closes itself. We perform angiography, and the patient didn't have any issues here. It is the only complication that we had, and we performed about 60 patients. If we put it on the table. That is all I wanted to say. Well, questions, please. Questions, please. Thanks for very interesting cases. I saw on your table Swan-Ganz catheter. Do you use it when you introduce the Swan-Ganz catheter, or do you first measure the pulmonary pressure? No, we don't use Swan-Ganz catheter. Wow, cool. You've noticed it. We use it to control the patency of the introducer, to see that the introducer went through the ventricle and the inflated Swan-Ganz. If we already introduce the stiff introducer, we pull it into the pulmonary artery. If there is no resistance, then 24 catheter would. So it's like testing thing. So my question is, don't you want to set Swan-Ganz immediately there to use this kind of classical shim? Some people do it. I prefer PPM because it's faster. Thank you so much. It was a wonderful presentation. Would you tell us if it is acute thromboembolism, where do we start? Where do we start if it's an acute thromboembolism? We're talking about hours. Do we need pigtail? Do we need to perform thromboextraction and perform thromboembolism? What is the algorithm? What's the algorithm? It depends on what you have. I have this flow trigger, 24 hours. I'm just saying, give it to me. So it is the first choice. We do not perform systemic thrombolysis. If you don't need thrombolysis, if you can perform thromboextraction. If we follow guidelines strictly, then first we think about thrombolysis, find contraindication, and then we perform thromboextraction. But according to our experience and the results of FLAME study, we can immediately start thromboextraction, but that depends which tools you have. If you have only Penumbra 8 French, then it would be too long with the blood loss. If you have flow trigger 24 French, you can achieve a good result, and you will achieve it very fast. Dmitry, short question: do you use flow trigger only? But do you use? No, we don't use flow trigger. I'm cardiologist. I cannot work out of heart. Thank you for the presentation. In which case you would reject thromboextraction? You will not perform. Well, we evaluate the risk of the patient. If it is low-risk patient, if it is a low-risk patient, there is nothing to be done. If it is a patient for whom there are concomitant pathologies and here life expectancy is very short, if the patient from the with the dementia, Parkinson's disease, and so on, then in this case, I don't think we will improve his life. But this is a risk-associated procedure. And if this is a patient who already has infarction pneumonia on CT, or not one segment or infarction pneumonia, where symptoms started more than 3 weeks ago, we will not perform in this case. Thank you. One more question to continue. Do we extend the indication for thrombectomy for mechanical thromboextraction for the patients with intermediary risk, low and intermediary or high risk? Because here there are nuances such as guidelines. Well, the first studies were performed on the intermediary and intermediary high risk patients. And these patients, well, we all know these patients. They have the perfusion of heparin, oral coagulation, and the patient cannot live without oxygen, though there are no formal criteria to perform thrombolysis. But for the patient, you can perform you can improve during 2 hours. If you can improve significantly their life. We've just discussed chronic thromboembolic hypertension, but there is no actually the answer immediately to this question. And I think that we need to discuss the interventional risk where we can talk about it. Well, final question, the final question. Dmitry, talking about all modalities that we've discussed in the interventional, for the most patients, is it flow retriever or ECAS? Well, we don't use it at all, actually. Well, thank you.
Так, ну что у нас?
Well, and the last presentation. Thank you, Dmitry. It was nice to see you. And, well, Dr. Mandukan, selective thrombolysis in acute pulmonary embolism. Well, we don't have such devices at hand, and in this case, we have to rotate a pigtail in the lumen of the pulmonary artery. And of course, there are social catheter, selective catheters, Unifusa, McNamara, Fontaine, and again, we can put them in pulmonary artery to do the selective thrombolysis, but we use a pigtail on a wire, on a rigid wire. Then we do selective thrombolysis. Here is our patient who was hospitalized with thrombosis in the lumen of the lower lobes and outer lobes after selective thrombolysis. As you can see it here, there was a reduction of the volume of thrombotic masses in the lumen of pulmonary arteries, and you can see the mapping here, and you can see the restoration of perfusion along the branches as CT data show. Let me show you an interesting clinical case. Could you launch the video? Can you just click on the first video? Well, that's a total occlusion, thrombotic occlusion of the right pulmonary artery. Click on the second video. Well, on the left, there are thrombotic masses in the lumen of the low lobe. We used 35 guide. Well, fragmentation started, launched the fourth video. We did the same with the upper lobe branch. You can see the blood flow restarted more or less. Again, at the lysa, 35 milligrams, and again 50 milligrams systemically. We did the control scan through 3 days. You can see the blood flow was restored in the artery, and clinically the picture became better. The clinical condition is better. Saturation increased. It used to be 85, around 85. Now it's 95%. And again, the patient was discharged. No complaints. Now we manage this patient. We've been managing this patient for 3 months, plus 1 more month on anticoagulation therapy. Then we will consider this patient as the one with chronic thromboembolism, and then we will continue treating this patient using balloon angioplasty. Just in a nutshell, A.Korzh system, A.Korzh thrombolysis. A.Korzh has been registered in Russia. The idea is to use 2 catheters in the lumen of the pulmonary artery, and through these catheters we can deliver thrombolytic drugs selectively. There are ultrasound waves created, and well, here the thrombolytic drug will get into the thrombus. You can see the indications such as control the selective infusion of liquids, thrombolytics are used to treat thromboembolism with a volume of 50% of the thrombus in one or two pulmonary arteries. A lot of studies have been done regarding the utilization of ECOS, and the device is rather efficient. Well, there is the normalization of the relations between the left and right ventricle. Well, again, you can see velocity indicators have improved in terms of hemodynamics of the right parts of the heart. And as you can see from clinical trials, the results are quite good. Well, but we haven't used this device our own. We are waiting for our experience. Still, we don't have any experience yet, but soon we will be able to do it. So according to Russian clinical guidelines, well, the best option to avoid acute pulmonary hypertension is the adequate restoration of patency of the coronary bed in the acute period of the disease. Thank you very much. We are behind the schedule, unfortunately. We are very behind the schedule. The next breakout session should start. Just very briefly, if you have any comments or questions, very briefly. Well, our colleague in Germany said they don't use ECOS. Well, my response will be brief. The situation is that right now we don't have special devices. ECOS will be the first one registered in the Russian Federation, available now. Before that, flow triver was not available. I talked to our Turkish colleagues in R.G.Matip, I guess. Well, they work with all devices. ECOS, he said, is the only device they use, not AngioJet, not Aspirex, but ECOS. Now, well, this device can be used in the Russian Federation, well, if a patient has pulmonary embolism. ECOS is the only one we have right now. Can I also answer this question? Yes, Dmitry, of course. We've been waiting for your comment regarding ECOS. You have a lot of experience, not a lot of experience. If I didn't have flow triver, I would have continued using local lysis. It's much better because the use of thrombolytic drug is usually very low, 1 or 2 milligrams per hour, and it's very effective. But flow triver is much better, in my opinion. Thank you very much. Well, as for the technique that you use in order to save time, well, you use the two femoral axes, right into two pulmonary arteries, right? No, I don't think it makes any sense to do it. We do the fragmentation on both sides, then you pull the catheter into the pulmonary vein, and that's it. Well, why do you need to make another puncture for thrombolytics? All right, thank you very much, dear colleagues. In my view, that was a wonderful discussion, and we have one formal part. Well, the award for the best presentation, please. Well, actually, I am the author of this book. Thank you. All right, one of the co-authors, right? Well, thank you very much, dear colleagues. And we wish you every success. Well, good afternoon, dear colleagues. It's 16:39 on the clock. Please, moderators, take your seats. Dr. Ganyikov, Dr. Alexey Bazanov, Dr. Andrei Baev, Vladimir Ganyikov. Let's get started. And our first presentation, size matters. How does the quality of MSCT affect the choice of the size of the bioprosthesis and the results? Dr. Valentin Gurev, shall we accelerate? Well, let's at least save some time on discussion, right? But try to speak quickly. All right, size matters. Good afternoon, dear colleagues. I understand that at this stage of the development of endovascular technologies, putting in prosthesis in the aortal valve is not difficult, but valvular intervention, well, actually give us food for thought about circumstances, consequences, and one of the predictors is the proper planning of all procedures. And of course, our equipment helps us here to do planning of all stages of endovascular intervention, from puncture, planning of puncture, all the way to the final results. First of all, in speaking of those helpers that we need, these are assist instruments that help us in the vascular bed. We can reduce the volume of radiation burden and the volume of the contrast media and reduce the time of the procedure. In speaking of transcatheter implantation, we're talking about indications for intervention. Well, proper echocardiography, using the special equipment and training specialists who can do such things properly. We identify the peak indicators like blood flow velocity, the size of the aortal valve, etc. Then we move on to doing a CT. Clinical guidelines, unfortunately, do not tell us exactly how it should be done, but we have accumulated a lot of experience in analyzing procedures. And again, there was a 2019 consensus, point by point. There are all the aspects related to the selection of the size of the valve before we do the intervention. First and foremost, we do MSCT with ECG synchronization at the level of the aortic root in order to optimally select the size of the valve. In order to do a CT, we should do it from 1/3 of the upper part to the 1/3 of the femoral segment. This can be done without CT synchronization. Then we just bring all the pictures together for convenience. Well, as for how this should be done, again, it's echocardiography synchronization. The thickness of the slice should be not more than 1 millimeter. Of cardial structures, iliofemoral segment 1.5 millimeters. The velocity in case of C-injection 4.6 milliliters per second. That's usually enough for all patients. If we have a patient with big BMI, in this case, these parameters should be adjusted. Well, the main sizes, well, we should know exactly the annular size, the Valsalva sinuses, well, also the diameter of the TVOL, and also other factors shown here. Well, we can formulate the situation here. Well, the annulus should have clear edges. Well, again, 200 units of house field. Also with increased noise, the image will be a bit grainy, but it helps us to measure cardiac structures, and there might be some artifacts in patients with poor rhythm. As predictors, well, we can measure possible calcification using the Agatston units. Well, for example, you can see calcification here protruding into the annulus, and again, you can see it involves the mitral valve and the outflow tract, left ventricular outflow tract, which is a predictor of a complication. If we're talking about at what heart cycle, well, CT should be done in some clinical conditions like hypertrophy of the interventricular septum or fistula. The size of the annulus will change. So if we use average indicators, well, we should look at the biggest size of the aortic valve annulus, and thus we choose the bioprosthesis depending on the size. If we're talking about the comfortable place for an interventionist, that can be formed, well, you should remember the remote server when all modalities such as echocardiography, all the data will come to one big server. We as interventionalists can get access from our workplace, well, and we can do the analysis of all CT scans or ultrasound modalities to preserve calculations and transfer the data to the working station so that the people in the cath lab could work with it. Right now we have a balloon expandable and self-expanding valves. Well, again, mechanically expandable valves are not widespread here. There is no ideal valve. A valve should be chosen on the basis of anatomical structures of the patient. Going back to the planning stage, first echo, cardiography, then the analysis of CT with planning using the working station. Well, then we do synchronization in the cath lab, synchronization of the volume. Well, again, we synchronize modalities of fluoroscopy and CT. Then under CT navigation, we do the puncture. Recent trends have shown that each cath lab should have IVUS, but in 90% of cases we use CT navigation in our clinic. Here you can see the way we do the puncture of the femoral artery using the CT navigation. In 100% of cases, well, there is the overlap of all landmarks, and we do the puncture of the main vessel. Again, when we do the implantation of the balloon expandable prosthesis, we can see that landmarks fully coincide. Well, I mean the valve and the aortic ring. Again, the picture is static. Right now, it's impossible to synchronize all modalities, but that's basically enough for the good orientation in the valvular structures. If we say what happens when we overestimate our capabilities, well, you can see hematomas occur upon the impact on the valvular structures. That's not the previous patient, by the way. It's a different patient. And here there was a significant impact on annulus, and again you can see in the left picture there is mass calcification of the leaflets of the valve. Again, the annulus was cut. It was a sad outcome. This is another case. Well, calcification was cut again, there was the fistula in the right atrium, but hopefully that was hemodynamically not important fistula and closed in 2 weeks. In conclusion, I'd like to say that we need to have a thorough planning and be prepared for the operation. All factors should be taken into account, including calcification and proper planning is a must. Thank you. Thank you very much, Valentin.
Вы уложились, можно даже вопросы.
Any questions? Yes. Thank you for the presentation. You paid a lot of attention to preoperative preparation, and as far as I see, all the calculations are done using your workstation, right? Yes. And again, that's a good sign, but the surgeon must do it himself. What software do you use, and what software would you recommend for our colleagues to do the calculations, like to do the CT and to get the true data? Well, the angiographer's workstation. Let me explain. All patients who are candidates for transcatheter intervention, we send the CT data to the representatives of the company, and well, usually I do recalculation myself for each patient, and I use the angiographer's workstation. I think that's the best option for us, the best instrument we have when I can do all the calculations, all the needed parameters. As for my PC, personal computer, I use this software called Providar, but it is less convenient for sizing of the valve. For the rotor, well, not quite convenient. Thank you. Thank you very much, Valentin. Let's move on to the next presentation. People from St. Petersburg prepared this presentation. There are several of them. Please. Good afternoon, dear colleagues. I'd like to draw your attention to the topic predictors of death in patients with severe aortic stenosis and COVID-19. COVID-19 is gone, but now we can assess the situation, what happened, and we can look from the side. And heavy aortic stenosis is a severe pathology having an impact on the mortality rate. The valvular pathology is quite widespread, especially in patients with COVID-19, 10% of such patients. As you can see here, severe valvular pathology worsens hemodynamics, impacting on the outcome of patients with COVID-19. You can see the ESC guidelines of 2021, and they were lagging behind from the dynamically developed pandemic. Well, they are kind of cautious. They recommended the conservative strategy. The guidelines were cautious, and well, of course, the use of the aortal valve repair, open or transcatheter, can be indicated for some patients. Each case must be considered individually by the cardiac team, by the heart team. Nothing specific in those ESC guidelines. They were published in the fall of 2021 when the pandemic was in full swing. The publications included successful cases, well, from some specific clinics, hospitals, data from some patients. Other publications were devoted to aortic valve repair of non-infected patients, patients who are on the waiting list, high-risk patients, expanded indications for TAVI to reduce the duration of hospitalization, to reduce the risk of COVID-19 catchment, and also anesthesia that should be used in this case. Well, again, here is the biggest publication. And again, that was a retrospective analysis. Well, I'll talk about it later. Published in the American Journal of Cardiology. This slide shows the data of the insurance service in the United States. The red curve is the survival rate of patients after TAVI who were not, who didn't have COVID-19. The blue line, patients with TAVI who had the COVID-19, and there was a significant increase of 30-day mortality, about 30%. That's usually the elderly patients with COVID-19. The authors made the conclusion that TAVI should be postponed by 7 weeks following the recovery from COVID-19. But, well, these are arguable recommendations, because here we're not talking about the survival rate of patients with severe aortic stenosis with COVID-19, like the conservative group. What would have happened with those patients had the procedure not been done? We know that, well, we don't know what happened with the patients in the conservative group with COVID. Well, 19, we do not know fully. Well, here you can see some other publications of other authors. Yes, some patients may have valvuloplasty done or aortic valve repair. And you can see the DEVER registry, 26 centers, 136 patients with severe valvular pathology. Well, not that many patients, but still quite enough. Half of the patients had severe aortic stenosis, and it was one of the unfavorable pathologies, along with mitral valve insufficiency. You can see the number of patients who died. 70 patients with aortic stenosis. 15 patients had aortic valve repair performed, and you can see the mortality rate in this group. 15 procedures in 12 centers. In 26 centers. Well, so again, you can see it's difficult to say what happened in a particular center. 30-day mortality was 13% in the surgery group. And again, surgeries allowed us to reduce general mortality in patients with severe aortic stenosis and COVID-19 from 50 to 42. Well, we can show you the results of the DEVER registry in a graphic form, and you can see this particular curve. That's the curve that I mentioned before. It's very important. And the mortality in the conservative group, if we do nothing, if we just wait and see, well, you can see what could be the mortality rate. It's comparable to the mortality rate of patients with the higher risk, with the severe aortic stenosis. During the year, we will have the mortality rate like that within 1 month. If patients have COVID-19, well, for 2 years, we just accepted patients with COVID-19 out of all echocardiographies. We chose 131 patients, 33 patients with severe aortic stenosis. Also, we selected patients with the positive PCR for SARS-CoV-2 and typical changes for COVID-19, 102 patients, conservative treatment 91 patients, surgery 11 patients. We presented the data before, and in the surgery group we had 12 patients. However, after some time we realized that we did the wrong calculations. One patient should not be in the surgery group because he had been discharged before. He contracted COVID-19, then recovered, and then he was hospitalized 2 weeks later to our hospital. So we just put this guy in the conservative group. You can see characteristics of the patients. Well, the groups were basically the same, but diabetes mellitus occurred more often in the surgery group, and the ejection fraction was lower in the surgery group, as you can see it here. 39 parameters were assessed. Lab parameters, well, BMI, body mass index, age, and this is the discriminate analysis. 98% sensitivity, 90% specificity were achieved. So we have a formula that can be used for each specific patient in each particular period of time. And if we have the positive value, the patient has the favorable prognosis. The negative value, unfavorable prognosis. Well, you can see the 90% accuracy was achieved thanks to the detailed analysis of lab data, although it looks like lab data are dynamic, but statistics has shown that they can be used and we can prepare a formula for that. In 2021, the discrimination function had less sensitivity when we presented this data in Krasnoyarsk. Now it's the 90% sensitivity. And you can see the ferritin, creatinine levels, the peak ferritin and creatinine levels. Also, you can see AST, well, and the ejection fraction. We can assess 3 parameters when patient is admitted, and then we can calculate the parameters in dynamics. Using this formula, we can calculate the possible risk, whether the patient is in the risk group or not. What was also important, well, the low gradient and the severe stenosis. Why did we do it? Well, why did we operate on patients with COVID-19? A lot has been said about it. And now we can say that there was no single patient in the surgery group who died. Well, 3 out of 5 patients were saved. So 5 patients, well, let's say 5 patients, half of patients in the surgery group were supposed to die, but only 2 patients died, not 5. Right now, COVID-19 is behind us. Right now, there are no severe pneumonias in patients, but in the future, there might be other pandemics, and even if there is no severe pandemic, well, this work can be used to assess patients with the severe viral infection. Basically, we called all patients after several years, except 1 patient, and 13% of patients. 13 patients had very good results. 5 are expecting the surgery. The red line is the surgery group. 2 patients died, as I said, and also then we lost the 2 more patients in a half-year period. All other patients are alive, and the mortality in the conservative treatment group is shown by the blue curve, as you can see it here. Well, again, during 1.5 years, we kept losing patients. 11 TAVI, well, standing in 5 cases, using PTCA because the CT is not available at our center. We use valvuloplasty and the self-expanding valve. We had 2 complications. In one case, we used the conservative treatment. In the other case, it was a stent graft installed. The patients feel themselves okay. Again, if we compare our results with Nero, well, they're basically the same. As for the mortality rate, 30-day mortality in the surgery group, again, you can see the patient who was wrongly included in the surgery group. Well, at our hospital, the strategy of treatment was primary conservative. And cardiologists, we had to convince cardiologists to show the data, telling them that every second the patient will die if we do nothing. So let's at least try to save some patients. But cardiologists were not eager to do it because they were concerned about infection. It's quite obvious because of COVID-19, and in our view, very extremely invasive strategy could lower the 30-day mortality. Well, thus, if the procedure is done timely, we can reduce the in-hospital mortality, especially in the severe group of patients. And this group of patients has the ability to survive. We can identify high-risk patients who might be candidates for valvuloplasty without waiting decompensation from COVID-19, and maybe restore hemodynamics fully and then do TAVI. Thank you. Thank you very much. If we have no time for questions, let's move on. The next presenter from Moscow, Nikolai Silin, right? Hello, I'd like to speak on the subject functional 3D modeling of endovascular aortic valve replacement, procedure, first results, and clinical prospects. Well, as for EVAR, we do EVAR more and more, but we need to improve the quality and optimize the procedure so that the prosthesis could last longer. That means optimal access to coronary arteries, implantation of the valve, taking into account variable and abnormal coronal anatomy to increase the service time of the prosthesis, and also providing optimal TAVI, and also planning and overcoming difficulties in case of complex anatomy. And here you can see the better access to coronary arteries in the future, repeat TAVI, the preservation of the hemodynamic peculiarities of the flow in coronary arteries, and reduction of burden on the valves of the prosthesis. Also, you can see the leveling that allows us to prevent regurgitation. As for commissural leveling, well, there are whirlpools in the valsalva sinuses. The blood flow can slow down. There is a high risk of thrombogenicity, a high pressure on the leaflets of the prosthesis. One of the problems we're trying to resolve is the individual selection of the valve. Well, valves with high hinging of leaflets serve longer because, well, this allows us to reduce the pressure on the valve, and but PCI will be more complicated. In this case, we developed the 3D model of the cardio-aortal complex. It allows us to assess the TAVI procedure when we do the visual examination, and also under the X-ray control. Well, you can see what it looks like. There is the membrane pulsing pump that measures contractions and the force of the contractions and the frequency. Well, again, you can see this individual model is shown here. First, a CT is done, then export of 3D model and the printing. Well, then there is the plastic structure. We put silicone on it, and again, you can see the individual models taking into account the personal patient's characteristics. Well, you can see the situation in the cath lab, and again, there is the closed contour. Aorta is attached to the collector, imitating the lungs. The collector is connected to the left atrium through silicon pipes, silicon tubes. The fistula is shown here. We exert pressure to the myocardium and pericardium. As a result of it, there are contractions of the left ventricle, and there is the outflow of blood through the aortal valve. You can see the contrast media, the mark was dislocated, but you can see there is the flow into the ascending aorta. Here is a clinical example. A female patient, 73 years old, shortness of breath, the maximum gradient 106, average gradient 54, the opening square 0.54. You can see the individual model of a specific patient, and then the implantation takes place, usually at several stages, with the positioning of the valve and its rotation, the rotation of the delivery system. After this, we do the assessment of the position of the valve regarding the orifice of coronary arteries and native commissure. And when the result is satisfactory, well, the system memorizes the correlation between the pedicles of this prosthesis, and during the implantation of the valve on the patient, well, these pedicles should be positioned the same way as they are positioned on this model. Individual models using the 3D printing allows us to restore the natural anatomy for the procedure. It is important to see the emulation of calcification. 3D modeling allows us to assess the physical flow of the functioning valve, to identify the best structure of the valve. This simulation system allows us to reduce time of pre-operative planning, time of the procedure, to avoid the intraoperative complications, and also this model allows us to use it in a real situation. Right now, we've had already 30 procedures, 30 individual models were developed, and right now we are getting a patent for it. Thank you very much. Thank you, Nikolai, for this interesting presentation. Any questions? May I? Yes. Well, my question is, you are making these 3D models on your own, or some company does it? Yes, a company does it. Well, these are high tech. And what about the pump? Yes, the company developed the pump. Right now, we are trying to assess its characteristics. What particular company? Is it secret? Is it secret information? I don't have well, the information right now, but it's not a secret. I can just provide you this data. Thank you. That was very interesting. For all patients? No, not for all patients. Right, mostly in complex cases, and also when the valve are located low, and when you can close the left ventricular outflow, and also the outflow of coronary arteries. Well, and in this case, well, we usually use this particular system. All right, thank you very much. Let's move on. We have the next presentation from St. Petersburg, Alexey Barzanov. Good afternoon once again, dear colleagues. Well, you can see the title of my presentation. You can't enter the same river twice. Valve-to-valve procedures. The number of valve-to-valve procedures are on the rise every year. The demand is on the rise, and at the top left bottom, well, you can see the situation when in 2002 there was the first valve implantation, and you can see the faces of the surgeons, the expansion of the first prosthesis, and well, they also encountered the new era with such faces, especially when patients needed a repeat procedure, like when they needed endovascular valves. Right now, it's routine, about 1% of all procedures, about 1,500 procedures like that everywhere. Well, you can see the TAVI complications shown here. We developed the algorithm how to deal with these complications. Well, but there is the deformation of the prosthesis, 5 to 25%. It's not quite clear what is meant by deformation, and I'll talk about this later. Here is our modest experience. Well, 1 TAVI in TAVI, 2 TAVI in SAVR. And again, if we look at statistics, well, deformation of the prosthesis as the complication did take place twice, and now we answered the question, what is deformation? Deformation of the prosthesis of the aortal valve is the change of its shape and the integrity of the structure, leading to the dysfunction of the prosthesis, well, to paravalvular leaks and leading to the emergence of the clinical picture in a patient. Here are predictors of the deformation of TAVI prosthesis, and you can see them here by cuspid valve, the size of the valve, calcinosis, well, deep sinuses, and the issues related to the technical part, the depth and the angle of implantation, the correlation between commissures, and the function of the prosthesis. Here is a patient, 70 years old, with the family history of hypertension. He was examined for a long time. Different tests were done. Well, in 2019, he had complaints. Well, he was monitored. In 2022, the patient actually had a new stage as far as his clinical picture is concerned. Well, you can see echocardiography was done. Well, aortal stenosis was detected. The patient was hospitalized, and when we were preparing him for TAVI, coronography was done, and again, multivessel disease was detected. Stenting was done as part of the preparation for operation, and MSCT angiography was performed. That's a typical picture for such patients. Calcification, well, bicuspid valve. Well, again, you can see the coronary leaflets. Well, this is echocardiography data. Everything is quite self-explanatory. And here you can see the TAVI procedure, the first stage balloon valvuloplasty with a positive effect. And again, you can see we used Evolut R34. And after the implantation of Evolut, we can see the under expansion. A decision was taken to do the post-dilatation of the valve. And, well, again, it wasn't done right away. The balloon catheter shifted up and down, but nevertheless, the good angiographic results were achieved. Good echocardiography. We decided to stop here and to leave the patient as he is. And I already see that my colleagues have noticed, well, some defect in the center of the prosthesis, but due to the good echocardiographic results, so we decided to stop and do nothing else. Well, then the patient, because of this angiographic find, was monitored by us. He felt himself well. Half a year later, when we called him, well, he felt excellent, no worsening. But after several weeks following our call, he turned to a local cardiologist and said that there was a relapse of symptoms. The patient was sent to us, and we did echocardiography, and we can see the appearance of stenosis. It was growing, although the area was the same. There was the insufficiency developed, and again, you can see the I.A.Soinov specialist thought that there is the dysfunction of the valve prosthesis. MSCT was done, and you can see this particular picture. Well, you can see unfolding of the prosthesis. Well, and again, if you look at this picture with CT before the operation, preoperative CT, well, you can see there were a lot of calcium along the non-coronary leaflet. Well, for the first time, this patient was sent for TAVI because of the severe concomitant pathology on the part of the lungs, and there was no other choice but valve in valve. So we decided to do valve in valve, and we do balloon dilatation as the first stage in order to unfold this defect. Then we used the self-expandable prosthesis, which was implanted into the aortal position, and the inflation process took some problems. We had to make specific efforts, significant efforts for inflating, but the result is quite good angiographically, and again, echocardiography was performed right away, and you can see that there was a regression of all indicators. Well, in the post-operative period, again, an MSCT was done, and again, you can see the position of the balloon expandable valve in the position of the self-expandable valve, the position of the self-expandable valve, a very good expansion of the valve that did not give us any doubts. In conclusion, I'd like to say that you should not forget that complications may be not only at the point of access or because of rhythm problems, but complications can occur anytime and anywhere. We must understand that the right preparation will always help us, and pre-dilatation, especially in patients who have tricuspid valve calcinosis, well, there will be complications in any case. TAVI can be used in this case. A valve-in-valve can be used in this case. So the procedure itself was done quite recently when we had the May holidays. And as I was preparing this presentation, well, I found a wonderful place not far from the Philippines. And again, you can see the picture here. That's the TAVI Island next to the Philippine archipelago. Thank you very much. Thank you for this wonderful clinical case, Alexei. And what are the reasons of valve folding? Because of the size of the annulus, what we try to analyze this clinical situation. First, massive calcification. That was the main reason, especially on the internal leaflet. So calcium was the predictor of valve folding in the opposite direction, and that's probably the main reason. And maybe the selection of prosthesis per se, because retrospectively, of course, well, we all know that in case of tricuspid lesion, it's better to use the self-expandable valve, but at that time we didn't have this opportunity. Thank you. Just a minor comment. We had a similar situation, and this fold was just along the entire length of the valve. We just did the post-dilatation. Well, hopefully, this fold unfolded, and we took a deep breath. Well, it is of interest that the dysfunction occurred not right away, but it happened half a year after the implantation. We can also say that this pressure of the self-expandable valve plus oversizing led to the situation when the deformation occurred at some point. Thank you very much for your presentation. Did you do a CT before the discharge? No, we didn't do a CT before the discharge. And, I didn't want, well, maybe not we didn't want, but we didn't think that, well, clinically everything was all right according to echocardiography, right? Yes. So you can see the angiography results. The average gradient was 25 upon discharge for, well, prosthesis 34, evolute 34. It's not typical. What the balloon expandable prosthesis you use? 29. 29, okay. And as for balloon expandable prosthesis, there was underinflation. How many milliliters left? I didn't pay attention. Sorry, I didn't pay attention. That's important. To what extent the balloon was reduced? By how many millimeters? Reduction of the size has an impact on the length of service. All right, I can say that the volume mentioned for this prosthesis was fully used. Well, according to our expectations, we did the full inflation, and there was the typical click while inflating. But, well, how much is left, I can tell you right now. Thank you. Thank you very much, dear colleagues. Let's move on to the next presentation. A.V.Fedorchenko, commissural alignment and cerebral protection in TAVI. Good afternoon, dear friends. My presentation will be brief. Commissural alignment and cerebral protection. Commissural alignment is the angular relation between native and bioprosthetic commissure after the implantation of any valve. And in 2022, there was the alignment consortium results published. The major tasks related to commissural alignment. And in speaking of the classification, well, this slide shows the degrees of non-compliance. Well, you can see up to 30 degrees of non-alignment of the native leaflets of the valve is considered to be a normal juxtaposition, moderate up to 30 up to 45 in average, manifested 60 degrees and more. Why are we talking about commissural alignment? We've been implanting valves for many years, hundreds of implanted valves, but only now we started talking about the importance of this problem. At TCT 2021, the following data were published. They're shown here. The relation, well, the ratio between, well, the use of TAVI in 2021 and 2015 changed. Well, you can see there was a twofold growth in patients under 65 and less. If we talk about patients over 80, well, there was an insignificant growth of the number of TAVI, and also the same is true of fit patients. Life tells us that if we implant a valve to a patient who is 80 years old, well, he will be probably the first. It will be probably the first valve for this patient. If the patient is 60 to 80, well, maybe the patient will need a second valve. As for young patients, well, it's very relevant to have a second or a third valve implanted for a normal life. So we're talking about the commissural alignment. A study was conducted, and you can see the comparison of 3 platforms for valves. They're all self-expandable, Evolute R, well, Accurate and Portico. The results were published of the commissural alignment, and you can see some of the data on the slide. And again, in 100% of cases, it was possible to avoid, well, the manifested or average non-alignment of valves. In case of Accurate Neo, in 10% there was the manifested non-alignment, in case of Evolute R, and the 20% of portico.
If we talk about accurate neo valve, then it's quite easy to judge in our practice without any additional effort. We can implant it with pin down. As you see in the left lower corner, in 80% of cases, we get perfect commissural coincidence. There is no more than 30 degrees angle from the native valves. That is comfortable. They were deeper study from Caroline University, one center study. It was evaluating efficiency and safety of commissural accurate neo 2. The endpoint were death, infarction, and other complications. And the method was developed called Caroline method. If we talk about the valve, then the procedure starts from introducing of the valve into the fibrotic ring. Then we move to the projection of two sinus, left and right. And in this projection, we'll call it kind of the valve on the right side, and then we see the projection as the projection of three sinuses, and all the places and we are nearly sure that we are standing optimally in the valve itself. The next study that was organized in the big group of patients demonstrated that in 97% of cases we managed to avoid commissural disbalance of accurate neo valve. In this manipulation, they did not evoke some complication. The main severe complications that can appear in this group of the patient, the manipulation themselves are more or less safe. The next study that was published in January this year on the influence of disbalance to the valve work, transvalve regurgitation and paravalve regurgitation was evaluated, and the total aortic regurgitation in 0.5% of cases was there with a disbalance. And especially, it is important if we talk about disbalance, and we see mismatch of the valve and fibrotic ring. Here is the shim that demonstrates that on the lower part of the slide, if we see this balance, we see the disbalance of this kind of skirt that goes around the perimeter of the fibrotic valve. We have paravalvular leakage and there is small opening of the valve, though it has supraannular structure. You would say, well, it's all clear. If it is tricuspidal valve, it's all clear. What will happen if commissura are unsymmetric? There is a classification of dissymmetricity of commissura when you have more than 150 degrees. There are certain ways, and according to the statistics of the left side, we see tricuspidal valve, and we see that in 0.5% of cases it is symmetric. And on the right side of the slide, we have also tricuspidal valve, but if it is attached to, according to one of commissura, we have lack of symmetry. And how to choose the projection? How do we choose the projection? There is certain technical approach, as we see here. We have left and right commissura. Over right, we have a long line between non-coronary and two other valves. And according to this line, we position our valve according to these cusps. Same we use when we have the position between right and non-coronary cusps. That allows to set the valve according to the commissura. So the commissura balancing does not evoke any doubts, especially in young patients. And now let's talk about cerebral protection in TAVI. We see the frequency on stroke year by year that is on the same level. Hospital is not higher than 2% recently. We see that the death grows during the first months. If we had intraoperative infarction or stroke, the neuroprotection is really important, and there is a number of studies that demonstrate the advantage of neuroprotection. And in this slide, we see the main percentage of complications appears during the first 24 hours intraoperatively or in the near future. In most cases, it happens due to the embolic material of tissue, aorta, myocardial. In 0.5% of cases, there are thrombi, acute and fresh. I like this slide that demonstrates if we talk about silent infarction, then different manipulation they can provoke a distal embolism, and most severe intervention that is open for aortic valve, cabbage, PCI. It is the most severe if we talk about distal embolism. In 68-19% of cases, we see the distal embolism when we perform selective MRI after thromboembolism, and we have to keep it in mind, and it is important to protect. Today, we among many devices. There is Sentinel device, one size device. In 90% of cases, in different anatomy, it allows to perform the tasks. And in 50% of thrombus are caught. The real practice demonstrates that this device is used more and more. In 2018, there were 4,000 used, and in 2019, 7,000. A most significant study is protective TAVI study that demonstrated the decrease of the number of strokes on usage of neuroprotection, and significant decrease was only invalidizing stroke that is demonstrated on the right side of the slide. At the moment, a big British study is planned that was published last year on TCT, more than 7,000 patients. And it is Sentinel. And according to the time of 2025, in April 2026, the first results will be published. So everybody is waiting for 2026 when we see the final results. And to my mind, if there was such a possibility, in 100% of cases, I would use this protection system. Thank you so much. Any questions? When there is valve abnormality, probably would better take a balloon expenditure, balloon expensive, to see the clipping. I know that each valve has its life hack, how to set it, and I think that first and foremost, we see which valve we implant, balloon expanding or self-expanding. I cannot answer you 100% without. And what should be the orientation? The valve, the circle, or the position of coronary artery? I didn't talk about a position and asymmetry of coronary artery because it is a case for the special lecture. It's impossible to fit it in my time. We have to keep in mind coronary artery anatomy. Definitely, you're right. More questions? The question is off the mic. The question is off the mic. The question is off the mic. If we know that this valve would be implanted to an elder patient with low probability, we will have to intervene on coronary arteries. There would be one valve, and we will not need to do anything else. If it is ACS, the question is off the mic. 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 Well, ideally, we need to compare. I think we kind of relax a little bit Those who use it will just put pin down and you even don't think where it will be. It will be set perfectly. Probably it misleads us, or it leads us to certain relaxation. But if the patient has to have few more clapons, valves, and we don't know the state of coronary arteries, all in all, we have recheck, pin down, pin to the side. We have to do it. We have to do it. Thank you. The next presentation from Tomsk, Andrei Baev, our experience of using the Russian endovascular transfemoral aortic valve prosthesis. Dear colleagues, Sochi and I am cold. Not very warm city, yours. I will share our experience. Well, experience. We are only starting to move towards TAVI. Every year we had from 3 to 5 procedures. We tried different prostheses, and one of them is the prosthesis that I am going to talk to you about today. And just few words, introduction. Aortic stenosis is widespread and from non-rheumatic, and it hurts up to 5% of population older than 60 years. Today we have two radical approaches to treat aortic stenosis with mechanical or biological prosthesis and transcatheter implantation. While accumulating the data, the position of aortic valve prosthesis was changing, and then the studies appeared that they demonstrate that TAVI is equal to aortic surgical aortic transplantation and evaluate low risk. They demonstrate that on the ER stage, TAVI is better, and for 5 years it is equal to aortic substitution. The data of American Heart Association demonstrate that in group of the patient older than 66, TAVI is the most commonly used approach if we talk about the number of implantations, and the patients younger than 65 are only 5% in this structure. We see that the trend is obvious. Endovascular intervention on the aortic valve will grow and grow. The excess, I think we should not discuss any longer. Transfemoral approach is a priority. We can consider other excesses, but only if we cannot perform transfemoral approach. Here we see the situation in the Russian Federation. The requirement is huge, 25,000 procedures, but in 2023 only 2,000 TAVIs were performed. We really have room for perfection. These are prostheses that we have. We implant these prostheses, but for Edwards, I think we don't have it at the market any longer. And I would love to draw your attention. It is the first Russian prosthesis for transcatheter treatment of aortic valve, and it is the only synthetic cusps prosthesis. The thickness of it is 0.1 millimeters, and it is comparable to balloon expanding prosthesis, biological prosthesis. There is no degradation, and according to the words of the producing company, it has to have good endothelialization. Now a few words about the constructive particularities. Less Strauss, it follows the contour of the whole vessel. It has good opposition to the fibrotic ring for pulse dilation and for minimization of paraprosthetic leaks. This system has transapical system. In our clinic, we implant transapically and transfemorally. On the handle, we have possibility to position the prosthesis better. Medici company suggests 3 variants of the prosthesis: 23, 25, and 27 millimeters. You see here's a big. Here is a set, the delivery system. It includes the delivery system, the prosthesis itself that is set on the delivery system, predilation balloon bush that is important for forming adequate access to the soft tissues, and this miracle of technique, the compressor and the pedal. Few more issues. You have this proximal stoppers. Then system is pre-filled with non-toxic conservative solution. You don't have to deaerate it, and the system has these handles to correct all the angle and proper positioning of the prosthesis. Here's our clinical case: 76-year-old patient with stenting in history. Nothing special. According to A.V.Gorbatykh, the gradient of aortic valve, the opening is 62, regurgitation. We choose mid-inch prosthesis, angioplastics. This is a typical stage. Then we see that the aortic arch is calcified, but prosthesis passes the aortic arch without any obstacles. The process of implantation and on the control. And now the third picture I would love to show you to. On the control A.V.Gorbatykh, we see there is still regurgitation, so we decided to perform post-dilation. Post-dilation is performed, and this is the final result. Please show the pictures. According to the angio picture, no regurgitation. According to A.V.Gorbatykh, and this is the positioning in the aortic valve. It is positioned correctly. It is not deformed. And on discharge peak gradient 15, no regurgitation, and prosthesis is the only prosthesis for transcatheter implantation. It is also the only one with the synthetic cusps. It does not require rinsing. We don't need the support of the company representatives. I think it's a very important issue. I want also to mention that I'm not happy how they work, but well, this is my remark towards the company and what they can do further on. In the delivery, we have the valve, the bouge, and the most important, it's an important factor for our clinic, the price. We have to study further on this prosthesis, and we need to know also to study the volume antithrombotic therapy. If you have any questions, I'm open to your questions. Thank you, Andrei. Questions? The question is off the mic. The question: the patient after the implantation, do you prescribe anticoagulant therapy? As a biological transcatheter, we prescribe them aspirin. And there should be some evidence base. Are you not scared? Well, not about scary. The evidence base, there is no. So you remember that 25 or 30 years ago, with surgical cusps, they had a metal cusp over the, and then it turned out that you still need anticoagulants. The patients died, and all mechanical valves require anticoagulant therapy. So the question is still there. Well, probably I am not right, but usually I think that aspirin is enough, and the production company is still there. We see that the cusps intertalize. And because of that, we can have this biological prosthesis. It's only our third. We don't have at the moment any evidence base. Our data do not confirm this, neither confirm nor contradict it. As for double antiplatelet therapy, we prescribe it only for the patients after stenting, and they require prosthesis as well. But why? Why not to take risks now for certain period of time? Endothelialization should happen, but it doesn't happen fast. It is a big construction, and it's not a stent. Probably it would last at least for 3 years. Well, we do not prescribe anticoagulants. We just don't prescribe. If we are talking about warfarin, if there is high risk of bleeding, we should not do that, right? If there is a hemorrhagical complication, it's all clear. We can prescribe anticoagulants, right? Of course, it would not be warfarin. There is, all in all, to avoid the risk, or we have to explain to the patient that it is mechanical valve. You would probably need to take warfarin, but if there is no risk, there are more issues compared to the patient or with the fibrillation. And the patients take these anticoagulants just to remove this risk. If the patient had TAVI and then the patient dies from ischemic stroke. You participated, by the way, in developing of this prosthesis. It was your team who was developing this prosthesis. You even implanted it. What's your point of view? I did not want to interrupt. We were dealing with the delivery system, transfemoral delivery. We didn't deal with the design of the prosthesis, but I can support you and say that we do not prescribe warfarin to all the patients. There is no some specific regulation for antithrombotic therapy, but if we compare it to mechanical prosthesis, well, let's say if there is mechanical prosthesis, thrombosis will appear without warfarin very fast in the near future after discharge. And this question, whether to prescribe or not, why we prescribe it for mechanic and not, it was topical at the beginning of our work. It worked for a certain period of time, and many clinics have good experience. Some clinics do not prescribe, some clinics do. If the thrombotic risk was same as in mechanic valve, it would appear already. We would know already. So the question is still there.
The question is open in terms of endothelialization, in terms of autopsy data, in terms of functional characteristics on echo. Well, thrombosis is not a hidden condition. If there is thrombosis, that will be seen on echo. And after the Medench implantation, well, patients are being monitored. Well, our first patients, well, friends, I'm sorry, but we are drastically behind the schedule, so let's stop the discussion and continue it in private. Thank you very much. The last presentation, transcatheter plasty of mitral valve, the modern condition of the problem. Presenters from Moscow, please. Distinguished colleagues, esteemed members of the Presidium, well, TAVI, the condition of the problem of TAVI, and well, today I'll be talking about the mitral valve, and a lot has been said today about the advantages of TAVI and its place in practical medicine. The role of TAVI is quite clear. As for mitral valve, that's one of the most discussable subject in interventional cardiology, not just mitral valve, but also atrioventricular valve, tricuspid as well. Well, I'm not going to talk a lot about the problem. Mitral insufficiency is not an innocuous disease, as it seems at first sight, although patients do not get surgery and they're still alive. Well, there is a cascade of hemodynamic mechanisms triggered that leads to the point of no return, the dilatation of the left ventricle, and in certain conditions, patients have no therapeutical solutions left except for transplantation or assist devices. Well, in Russia, this problem is very relevant because we've got lots of patients like that. Mitral regurgitation, according to the classification, can be divided into primary and secondary, as you all know. Secondary as the result of the dysfunction of the left ventricle, and primary, that's the damage to the injury to the valvular apparatus per se. About 50% of patients with mitral regurgitation are candidates for surgery due to additional factors shown here, such as low left ventricular ejection fraction, high risk, older age, comorbidities, and here we're talking about an open surgery. As for candidates for surgery, we have only 2% of patients who do get surgery for different reasons, not because cardiac surgeons do not do their job well, but we have a range of different problems. Cardiologists do not send patients all too often to cardiac surgeons. Also there are new drugs to treat, heart failure, allowing us to decompensate the problem. And the third reason is the behavior of patients per se. Patients with heart failure, is very unspecific. It's not shortness of breath. When people can't live normally, they have chest pain. But in this case, it's a different situation. The decompensation takes place slowly. They may not notice it. They can get adapted to this condition. And unfortunately, this leads to heart remodeling. And later, this leads to radical problems. You can see the methods of treatment: medical therapy, surgery, mitral valve repair, transcatheter reconstruction of leaflets, edge to edge, and you can see one option of reconstruction is available because only one option is available in Russia right now, but globally there are more devices for endovascular repair and also endovascular repair of the mitral valve in particular. But for us, the most important thing is edge-to-edge technique. Here you can see a video, a small animation. It's a long one, about 6 to 7 minutes. I will skip it. And I think you are aware of this device. That's the endovascular repair, edge to edge. When we take the segments of the anterior and posterior leaflets in the area of the jet regurgitation, and we do the plasty, basically sewing each to each, and there is also the annulus plasty. Transcatheter mitral valve repair. Again, it is mentioned in many recommendations, especially patients with the high surgical risk. You can see the evidence type class 2 American recommendations, 2A, European recommendations 2B, lots of studies, lots of registers, a lot of post-marketing studies devoted to this problem. There was a study in Russia in 2021. It also showed the efficacy of the method. And I would like to draw attention to 3 basic studies. And that's Everest 2, surgery versus mitral clip, COAPT, mitral clip, and OMT. As you can see it here, mitral F-arm. Repair and medical therapy, 5-year results showed no difference between surgery and the transcatheter repair. 5-year results are shown here. Some improvement in terms of functional class in patients after the repair. One more study, COAPT. In COAPT, you can see the difference between transcatheter repair and open surgery. Again, transcatheter repair showed advantages, and mitral FR. The design of the study was the same, but you can see here there is no difference in treatments. Well, you can see the slide. The design of the study is the same, but the results are different. And because of these two studies, the discussion continues in the global community. As you can see here, in mitral FR, patients were anatomically more complex, and ventricular remodeling was much more difficult, while the end diastolic volume was higher. As a result of many discussions on these two studies, they were the term disproportionately severe FMR, disproportionately remodeling of the left ventricle. In case of this, response to treatment is better when the transcatheter method is used. And it looks like in one study, patients got optimal medical therapy, and the repair was done in this disproportionate therapeutic window. The results were better. In the second study, patients, roughly speaking, were all included in the study, regardless any selection, so there were no advantages of transcatheter repair. That's why this term, disproportionately severe FMR, as you can see it here, and again, there are co-apt criteria for selection and treatment of patients with mitral valve insufficiency and prognosticating the positive result. That's what I have already mentioned, disproportionately severe FMR, when the atrium has widened, but not the left ventricle. We can see that the result will be okay. As for disproportionately severe FMR, that means the heart, the ventricle, and the atrium are large. That means the patient should be on maximal medical therapy to achieve maximal ventricular remodulation. And only in this case, we can send the patient to mitral valve repair. The number of hospitalizations after mitral clip was less. In the group of medical therapy, you can see the co-opt 5-year results showing the improvement of the heart function with the reverse remodeling. And I would like to say that all these studies, especially the Everest, were done by using the first generation devices. One clip with one size, no choice. Now we have the fourth generation of the mitral clip. Well, these are clips with the wide size of the arm. You can see the patient's characteristics. You can see the new generation. And again, wide clips allow us to achieve the better results using just one clip. And we've noticed it in our practice. Before, we didn't believe it. Well, but the difference in width is only 1.2, maximum 2 millimeters. You can see the average number of clips, 1.3. Well, the quality of life improves after this procedure. Well, you can see the class change according to NYHA, and also as for 4th-generation clips, you can see adverse events. They are quite obvious. There is a wide range of sizes. The length and the width of the clip can be selected depending on a specific patient. You can see the gradient on the mitral valve is much less, so the lesser number of clips, the lesser the gradient. That's quite obvious. And recently, there has been the special strategy of treatment of patients, well, with symptomatic severe primary MR. Again, you can see the results coped-like and non-coped-like. These are things related to mitral regurgitation. In conclusion, I can say that as of today, transcatheter mitral valve repair is an important strategy of mitral valve treatment. It will be used more and more in clinical practice. And here's my last slide. And besides the mitral valve, in clinical practice, while tri-clip is being used, this picture was done the day before yesterday from our cath lab. We already have the experience of using tri-clip, less than 10 procedures, but nevertheless, the results are quite good and quite inspiring. You can see the tri-clip on the mitral valve, on the cuspid valve, and in the future, you can do this, well, if, well, you have enough financing, one delivery system, one patient, well, you can use 2 valves treated. And but that's the question of the future. Thank you. Thank you very much, Dmitry. Well, I hope no questions, because we overran our time. Thank you very much. You want to say something? No. That was a wonderful breakout session, and we should wrap this up. Well, I'd like to say a few words in conclusion. Well, my opinion is that we are on the threshold of the new stage of development of interventional cardiology as far as valves are concerned. And we can see the drastic growth of the number of valves implanted. More than 2,000 in Russia last year, 15 valves per 1 million. In Europe, well, and that was 3 or 4 years ago, it was 140 valves per 1 million. In Germany, 270. In the United States, about the same figure. So we're lagging behind, at least by 15 to 20 times in terms of the number of valves implanted per million. So we needed to catch up, because the train is leaving and we should not stay on the platform. And so right now we must deal with this problem more actively than we've been dealing with it before. So pay more attention to the subject. That's our wish to the organizers. Thank you very much. Thank you all for your perseverance. Alexander, the floor is yours. Thank you very much. Once again, I'd like to say that we've had a lot of new participants. Alexei Nikolaevich is one of them, our favorite professor from Kuban, where we are now in the Kuban region. It's not the first time we organize a conference here. More than 1,000 participants, 1,100 to be more precise. And for the first time, we had simultaneous translation provided. So there is the English track. I don't know why we did it and what for, but maybe, well, there might be some use. More than 200 personal presenters who came here to speak in person. Thank you very much for your support. I hope we will continue like that in the future. Thank you very much.